Okay. I'm gonna introduce you, and I'm gonna mention some points. Sure. I want to address. And at the end, I just want him to if he wants to talk. So thank you.
So I'm ready just to. Yep, I'm ready to make that go.
Good morning, everyone. I think we were over half an hour past, and I think we should start the meeting. Otherwise, we have got to comply with the board to make sure that the course, is at the standards that we need to have. I will really thank you, Dr. Luz, for coming, for quite some time, more than 8 years now. It's been great. Dr. Luz has been a speaker to us in this topic, which is sedations and physiology and pharmacology that is so important for us to know and address. Now it's becoming a state board requirement. I'm so happy that people address it and take it this seriously, because this is an edge for us. Dr. Luz did his chemistry bachelor's in Texas Tech in '81, then followed by his dental school in Houston. After that, went to San Antonio, did his GPR. Follow that, he stayed to this moment and is a faculty member at the University of San Antonio. He is very active in different associations, including the American Dental Association, AGD, the Texas Dental Association. He is very active as well with the Dental Licensing Board. He's been an active member in the American Society of Dental Anesthesiologists, which is now is a specialty, and he's been a member of them and given us lectures. He gives lectures all over board, and with that, I would like to say that he's a great man. He loves sports. He's a great athlete, a great husband. His spouse is a dentist too, Dr. Dreer, and I really will very happy to have you. And before the end, I would like to just mention a few things about the course, and I will really like to acknowledge and thank a few people that made this really possible. One is Ms. Diane Rhodes, a senior policy manager of the Texas Dental Association, which she was here with us on Tuesday at the Dental Society. She beta tested this course for today that you're receiving to get your 8 hours, for level 1, 2, and 3 of anesthesia. I would like to thank the RGV, the Dental Society, for sponsoring the C credits for today. And I really thank a lot, my dear colleagues and administration, and my administrators at the office, Lisette and Carolina, for the event to be held today. Dr. Luz as well, always thanking you for sponsoring this event with us. The different Southwest dental components that are participating with us today via webinar active. And my alma mater, Universidad Francisco Marroquín, the alumni and graduate students right now watching us, and as well the medical school at the University of Francisco Marroquín, which are watching as well, and from the GPR program from the University of Oregon, Portland, they are watching as well. With no more to say, I would like to just thank you for being with us, and the podium to you.
Okay, thank you. Do you want me to roll this video as well? Okay, all right, so let's start off with a video, which I have not seen yet.
My name is Dr. Duco.
And we do not have audio now. What did we do? Yeah. Okay. Hold on. I'm always open. Yes.
I saw your mask go down, so you bring your mask back up.
Bring my mask.
Yeah.
Oh, okay. Thank you very much. So Joseph, did I get that correct?
Yes.
He has been working his brains out for the last 45 minutes.
Lost my hair.
So while it looks like nothing had been going on up here and we're just like messing around, he's been pulling his hair out, and the problem was all my stuff is on a Mac and it's in a program that's not compatible with PCs and PowerPoint, and so he has been working very hard. So let's try this again.
Hi, my name is Dr. Duke Ho, and I'm the current president of the Texas Dental Association. I'd like to take this opportunity to thank many of you for your membership in our association. Please know each and every one of you are appreciated and valued, and we are working hard to serve you. Whether fighting against third-party payers, advocating at the Capitol, or simply bringing continuing education in a different format, like today, we are here to make your life easier. So always feel free to reach out to myself or anyone at the TDA team if we can better serve you. Thank you very much, and have a great meeting.
Okay, all right, let's see if I can go back. Bingo. Alrighty. Again, my first name is Ernie. My last name is Luce. I'm a general dentist at the dental school in San Antonio. I'm half-time faculty at the school, and I'm half-time in private practice. I see a lot of familiar faces when I come down here. And one thing Dr. Cruz reminded me of today is he sort of put it in terms of, oh, you're so famous, you go places and all these people know you, and that's really code for is you're blessed by a lot of friends. I go a lot of places, and there are peoples that I know that I call friend, and I'm grateful. I'm really grateful for that. That's just a wonderful thing that's in my life, and it's not my making. It's something I've been blessed to have. So thank you very much. Alrighty. So kind of the layout of the day. So we've got a really this is probably just about as a diverse an event as I think I've participated in. As I look across the room, I get the sense that there are a lot of staff members. Is that true? Non-dentists? Okay. And so we've got non-dentists, we've got dentists, but the general theme of the course is sedation and sedation-related issues one way or the other. But there's a whole spectrum of sedation providers as well. So we've got folks that do a little bit of oral sedation and then up through moderate sedation. And I know that there are individuals in the room that are doing deep GA. So not only do we have the full spectrum of sedation, we've got pretty much a full spectrum of just dental care people. So, and that's just the people in the room, which my understanding is about half the people that are one way or the other engaged. So the people that are wearing clothes that you would wear outside are here in the room, and the rest of you are in your pajamas, I assume, drinking your coffee and eating your pancakes. But so trying to speak to you in the room, also trying to speak to folks that this is being broadcast to. So I'm going to work hard to try and make sure that there's material for everybody, but please remember, this is a really broad group, so I will work as hard as I can to make material pertinent to everybody as best I can. We do have a big group. Sometimes that makes interchange or dialogue a little bit difficult, but I don't want to discourage it at all. So as questions come up, I'd like to at least start with, let's try and address them as we go. And as long as the program seems to keep going, I think that's great to work with questions as we get there. If somehow it seems like there's so many that we're struggling getting through material, then we might sort of batch the questions as we go. So we'll figure it out. There are some mics in the room. We'll sort of see how well either you can project from where you are or maybe come up to the mic. But if you don't project really, really, really well, and I will try and remember to repeat questions as well, the folks that are on the broadcast won't be able to hear the questions. Okay, all right, let's see if I can, I'm not used to holding two things, I'm used to holding one. All right, so let's start off with emergencies, and we're actually going to spend a big chunk of the day just dealing with emergencies. Let me ask, though, before I get into this, how many of you, whether you're a dentist or a non-dentist, are involved in or work in an office where sedation of some sort is done? So that would include nitrous oxide, oral sedation, IV sedation, deep GA. How many of you are in an office where some level of sedation is being done? Okay, so I see a fair number of hands. Are there folks that are in an office where sedation is not done? You know, where it's just local anesthesia? So, okay, so there's some of y'all too. Every office is prone to having to deal with a medical emergency along the way. So many of these emergencies, a lot of what I'm going to be talking about are not sedation related. We will get into sedation related emergencies, but we're going to talk about asthma and heart attacks and fainting and low blood sugar and all that sort of stuff. So there are email addresses on many of my slides. So in the event there's a question or something that you think of after the fact, please feel free to communicate with me by email. I try really hard to be responsive, so if you don't get a response from me in at least a couple of days, it means somehow I didn't get the message. Try again. Continue to nag me and I will respond. And let's see. Bingo. Okay. So regarding the emergencies, my goal today is to explore and update our understanding of medical emergencies in the office and how to be better prepared. Before I get into my material, I want to make sure that everybody is aware of an awesome resource that is available for free. So this can be found, this is a medical emergency protocol system. It can be found at the website ADSA Home, American Dental Society of Anesthesiology, adsahome.org. And then you look for a tab, which I believe will be down near the bottom of that home page, or a box that looks like this 10 minutes saves a life thing. You do not need to be a member of the organization. This is there for the taking. So the idea is no matter what kind of dentistry you do with or without sedation, we're all responsible for, having a basic understanding and a protocol for, well, what do we do if somebody faints? What do we do if somebody has a heart attack? What do we do if somebody has an asthma attack? What do we do if we think they're having a stroke? This writes all that out and separates it into some big categories. People that do no sedation, people that do lighter levels of sedation, people that do deeper levels of sedation. And of course the protocols, there's some technical differences in there based on, some differences in training that individuals may have. So for the offices that are not doing any sedation, there's a big chunk of this that is absolutely appropriate for you. And then for the folks that do deep GA, there's a section there for you as well. What about individuals that work primarily with kids? Are there any here? Yeah? So it's also written in terms of pediatrics, so pediatric dosing, for instance. I know I don't have the technical terminology correct, but it's like an active sort of PDF. You can put some baseline data in at the beginning of a case, and it's already pre-calculated doses for emergency drugs, so it's like already there. So you don't have to be thinking of that. So anyway, I just want to make sure that you're aware that this resource is available. Now then, some of you are probably pondering, well, the Texas State Dental Board a few years ago made very clear for sedation providers, and in particular level 2, 3, and 4 providers, that we have to have a written emergency protocol. So hopefully the dentists in the room that are doing sedation go, yeah, I'm familiar with having to have that. And if you've had an inspection, so if you're a level 2, 3, or 4 provider, you've gone through an inspection process, or if you haven't, you're about to. And one of the things that the inspector would have looked at would have been your written emergency protocol. Yes? Have I already lost you? Oh, it's going to be a long day if I've already lost you. What I'm getting at is this is a really awesome thing. The ADSA 10 Minutes Saves a Life. It is downloadable and printable. So I believe you could actually use it as your written emergency protocol. There are others out there. I think the main thing from the inspector's standpoint is they just want to make sure that you have a protocol. I'm not sure that they actually look at the technical details on, is that the appropriate dose of epinephrine for anaphylaxis, or is that not the, I don't think anybody is looking at that detail. But I have a lot of faith in the quality of this material. It's been very well thought out. It's been tested now for a long time. There have been hundreds and hundreds of thousands of downloads on this. So anyway, I would at least give it a look. But it's intended to be put onto a mobile device, and so it can just be right there. Protocol will never be any good unless you actually pull it out and use it. And if it's something that sits in a binder buried in a cabinet, I think it's not real likely that in a real crisis that'll get pulled out and get used. Okay, all right. When I was in dental school and I was learning about medical emergencies, a whole lot of, at least what I remember, regarding that training seemed to focus on what drug, what dose. I think we had an emergency kit which literally had about 20 or 25 drugs in it. And my sense was it was just very complicated. And it's clear that when we're dealing with a crisis, something that is emotionally challenging to us, emergency medicine physicians who spend their career dealing with nothing but emergencies, and the nurses that do the same thing with them, their day-to-day life is dealing with people in some degree of crisis. But that's not what we do. When something crops up that we go from, this is routine, to, oh my gosh, something really bad may happen here, there's a huge emotional load that gets in the way of managing that crisis, the technical management. And so simplicity is really, really important. And so as we move through this emergency material, I'm going to try and emphasize that my take is medical emergency management in a dental office should be extraordinarily simple. The more complex things are when you get the deer in the headlights look, which shuts down a lot of our brains. The more complicated the task you have to do at that point, the less likely it is to get done right, or the less likely that you'll remember it, which is the reason for the written emergency protocol, so that you don't have to remember things. Okay, but simplicity is really key. These are some of the excuse me, I got a cough. These are some of the things that we'll talk about today, so I won't read those, but you can see those. One thing that didn't appear on this slide, we will talk about some sedation emergencies as well. In terms of equipment, and in particular with sedation, so when we think about sedation, the theme, the general theme of the day is sedation. And so now I would like to ask, not the doctors on the call, but the non-doctors in the room. And I would like you to ponder, and if you're willing to throw an answer out, I would love it if somebody would throw an answer out. When sedation goes bad, what goes wrong? How does it go bad? And I'm thinking just really simple. When sedation goes bad, when people transition from, oh, they're fine, to they're not fine, what in general has changed? So my hint is, do they develop bad kidney function? No. Do they develop, an unwanted skin rash that gets them, Okay, so that stuff is silly. But you see the general theme. When sedation goes bad, it does that because of what goes bad? So I'm hearing vitals, I'm hearing heart rhythm. Okay, so I hear obstruction of the airway, so now I'm not a doctor anymore. It's like, what? I don't understand. Obstruction of the airway? What does that mean? Who said that? Bingo. Sedation goes bad because of bad breathing. I've heard a bunch of people say it. Sedation goes bad because people go from good breathing to bad breathing. And yes, bad heart rhythms will develop. But that's usually the core problem is not a heart that goes bad. It's breathing that goes bad. And then if you deprive the heart of oxygen long enough, okay, then other things will happen, including heart rhythm problems. So if the problem is bad breathing, and I intentionally use those terms, that's as simple as you get. Bad breathing. How do you fix a sedation that is starting to go bad? You restore, who said it? Good breathing. That's it. You ready to go home? Everything else is just sort of around this. But our focus, especially in sedation, but I would also say really in every emergency. Now, in every medical emergency, the problem isn't always bad breathing. In sedation, the assumption is the problem is bad breathing until you prove otherwise. Okay, the breathing is fine, something else is going on. But almost always the problem will be bad breathing. The fix is good breathing, restore good breathing. Now then, why does breathing go bad? And I'm looking back to my respondent a moment ago who said airway obstruction. What do we mean by airway obstruction? Okay, so it's just something that blocks the tube. And virtually always it's going to be the tongue resting on the back of the throat. So there are two basic reasons people will quit breathing well in sedation. One is the tube gets plugged, or mostly plugged. They may be squeaking a little bit of air past, but not a lot. The problem is the tongue is in the way. Okay, so you could tell in that example that there was still effort. I was still trying to breathe. I just couldn't get the air to go past the obstruction. How do you fix that? Okay, so how do we open the airway? So if the problem is the airway is blocked, we want to unblock it. Okay, so you call an anesthesia kind of plumber to unblock the stopped up pipe. How do we open the airway? So I heard people say open the airway. And I saw some people, sort of do it in the room. Head tilt, chin lift. Okay. Now then, I have another question. When people obstruct, when their tongue relaxes on the back of the throat, where are their eyelids? Are they open or closed? How many of you sleep next to a loved one that makes a lot of noise when they sleep? Some of you. What do you do when they make so much noise that I love you, but I can't sleep. What do you do? Who said that? What do? You poke them. So when they're making that noise, where are their eyelids? The eyelids are closed. So people that obstruct in a dental office when they're sedated, are they awake at that moment or are they snoozing? They're snoozing. Okay, now go back to sleeping next to a loved one that's making a lot of noise. And you poke them. Why do you poke them? You wake them up. And why does waking them up help? Do they pull their tongue off the back of their throat all by themselves? Do they open their own airway every single time? I'm going to say yes every single time. Now maybe they may go right back to obstructing again, but is it true that for at least a little while they will unobstruct? That's my opinion, is that pretty much without exception, if you wake a patient, a snoozing patient up, so if a patient is sedated and they're not breathing well, it's almost always going to be the tongue is relaxed on the back of the throat and they are still trying to breathe, at least some. But if you wake them up, they will pull their tongue off the back of their throat. Is there general agreement there, or would anybody like to, throw another opinion on that? I feel really strongly about that. Now, most of us in the room and on the call that are doing sedation are doing awake sedation. Level 1, 2, or 3, nitrous oxide. It's okay for our patients to fall asleep, but they should be easy to wake up. The folks that are doing deep sedation general anesthesia, they intentionally put their patients to sleep. They're giving them enough drug that they are either impossible to wake up or very difficult to wake up. But for all the rest of us, our patients should be easy to wake up. It's okay for them to fall asleep, but they should be easy to wake up. If sedation starts to go bad, it's because of bad breathing, but they don't breathe badly, really badly, until they're snoozing. So if you can wake them up by poking at them, they will fix their own airway. And at that point, you can say, so they've been breathing badly, the oxygen saturation may have gone down, the alarm may have triggered, which may have prompted, your attention in the first place. And so now you get them awake. Now what are you going to say or do? There you go. Take a big deep breath. And the patient will at least to some degree follow that command. You may have to prompt them a few times. No, come on, I need you to take a big breath. A big breath. Bigger than, there you go. Let me see your chest rise. Okay. And the oxygen saturation will come back up. How quickly will it come back up? This is a time sense I think you should have. If somebody breathes badly and they say they desaturate to 90 or to 85 or to 80, and then you wake them up and they start breathing again, how long will it take before the O2 sat comes back up? I'm sorry? About 30. So the reason I suggest, 30 seconds is a long time. It's like 1, 2, 3, and you're thinking it's really going to count to 30? No, but 30 seconds is a long time. So what I really want you to have faith in is the power or the value of a responsive patient. Do we have sedation crises? Let me ask it this way, do people die in moderate sedation? So if you do You know, a lot of pediatric dentists are level 2 sedation permits, maybe level 3 permits. If you're doing IV sedation, but you don't put people to sleep, you've probably got a level 3 permit. Do we have deaths in moderate sedation where people are awake? Well, are people supposed to be awake? Now, my take on this is there are people where the sedation, patients where the sedation is intended to be moderate. There you go. So I wish we could have put that on the video broadcast to everybody, but he goes, no, yeah, an intended moderate sedation that becomes deep. That's the problem. A deeply sedated patient is hard to wake up or impossible to wake up. So at that point, you know, I just went through this long tirade about the value and how easy it is to wake somebody up and they fix their own airway. Well, that's assuming you can wake them up. And if you've been here before when I've talked about a sedation emergency, you know, it's like, how do we wake them up? Well, you poke at them. Is it okay to hurt them? Is it okay to pinch? Squeeze the earlobe? Pull hair? Is that okay? My opinion is it is fine to inflict some discomfort if that's what it takes to get the patient to wake up. You may remember me flippantly adding, don't leave a mark that you have to explain later. Often when I ask about, well, how do you wake somebody up? You know, and we get a variety of stimulation techniques, but I'll also often get sternal rub. And that can be pretty stimulating. And so I'll do a sternal rub. And then there's a whole string of people that I will not do a sternal rub on for obvious reasons that I don't want to have to explain. Why is there a sore spot or a bruise right there on my daughter, my wife, you know, my girlfriend? It's like, I don't want to have to explain that. But don't be afraid to wake up, you know, to inflict some discomfort if that's what it takes to wake a patient up. So I would say we don't have deaths in moderate sedation. We have deaths in patients that we wanted or started off in moderate sedation, but they became deeply sedated, hard to wake up or impossible to wake up, and then they didn't breathe well and it didn't get managed well. And at that point, you know, you've only got a few minutes of tolerating bad breathing before brain cells start to die. So there's not a ton of time. So that's a stressful part of this. But the technical nature of fixing an evolving sedation problem initially is really simple. The problem is, say it. The initial problem is bad breathing. And so the fix is good breathing. And what's the primary way we reestablish that? Wake them up. That's it. Now then, yes, we can add open airway. There are airway maneuvers. We'll talk about that. And if you can't wake somebody up, then you do actually have to ventilate for them. And we're going to talk about that and reversal agents and calling EMS. And we'll talk about all that. But I want to empower, especially the non-dentists in the room, the influence that you have, the power that you have to do all this. All these things we're going to talk about today, all the drugs, the only drugs you can't give are the ones that actually get pushed with a syringe, pretty much. But all these other emergency drugs I'm going to talk about for asthma, diabetes, you know, you can give all these. Allergic reaction, you can give all these drugs. The only ones probably that I'll talk about today that staff members would not be allowed to give in a dental office would be probably the reversal agents, flumazenil and naloxone. But you can load them. You can do the airway maneuvers. You can put the airway devices down. That's a cool thing to do. Okay, so we're still on slide 3. What time is it? I don't see a clock. 9:15. So somebody cue me when we get to about 10. And we'll take about a 10-15 minute break. Is that okay? Okay. Okay, so let's start talking about doodads. So all of us in the room, whether we do sedation or not, must have basic airway equipment. So that will include a bag valve mask or a demand valve system. You don't need both, but you got to have one or the other. Personally, I prefer the bag valve mask on the top. It's more portable, and it does not depend on the presence of oxygen in an oxygen tank to be usable. It's better with the oxygen, but you can work it because you can squeeze the bag with your hand without oxygen in the oxygen tank. The demand valve system in the middle of the screen is dependent on oxygen in your tank to work at all. So you put the mask on, you press a button, and oxygen pours out. So if the tank runs out, you can't ventilate with this device. This is a crowded picture, but if you look at the green device in there, the green device, that's an oropharyngeal airway. Those are very simple devices that get slipped into the mouth. There's a video coming. You'll love it. But they're very easy to put in. All they do is hold the tongue off the back of the throat. And what did we say about how is it that airways usually get blocked? Tongue on the back of the throat. So this is a little plastic gizmo that's easy to put in. Anybody can do it. And it'll hold the tongue off the back of the throat. You've pretty much got to be out to accept it, though. If you try and put it into somebody's mouth that's awake, you'll probably wear their breakfast for the rest of the day, if they're awake. So a nasal cannula is a less invasive way of administering oxygen. Some sort of oxygen supply. So even if you don't do any sedation at all, as dentists in Texas, we're obligated to be able to deliver positive pressure ventilation. So we must have oxygen in a tank somewhere, and either that blue bag valve mask on the top right of the screen or the demand valve system in the middle of the screen. You've got to have that. So even the orthodontists, if we've got orthodontists in the room, you've got to have it. Who's the most likely person to need that stuff? Well, either grandma or grandpa with the kid, or, look at me. It's like I'm definitely in the older age sect in the group. So a lot of times the old dentist is the one that's at highest risk. So that raises another issue. Can your staff do this stuff without you? If the dentist is the sole source of information and skill, and the dentist is the one with the problem, then you've got a big problem. Okay, another oxygen delivery device, a face mask, a pulse oximeter. So I'm going to say some controversial things about oxygen use, but I'm going to start with oxygen use in an awake patient should be guided by a pulse oximeter. People that are not hypoxic, that are awake, rarely need oxygen. Okay, I'll defend that better later in the day. When the day comes that you're buying another bag valve mask, and these things are fairly inexpensive, $20-30, and they do fail, they're plastic, so the plastic ages and gets brittle. A dentist, this was a former resident, had purchased an elderly dentist's practice and was going through the emergency equipment. They told me, I picked up the bag valve mask and squeezed it and it broke into pieces. And it's like, okay. Well, that was absolutely the time to figure that out. But when you buy another one, spend an extra $10 and get the kind with a pressure gauge on the top. What that does is it tells you how much pressure you're putting into the airway system. The mouth, the nose, the throat, the trachea, the lungs, but also against the opening to the esophagus. So when we push air into the mouth and the nose with the bag, so you've all practiced this in CPR, the air can go two places. It can go down into the lungs, which is what we want. But it can also, if you push hard enough, you can push it down into the stomach. And in somebody that is out, and you push air into the stomach, you promote or you encourage vomiting. So now you get vomit in the airway right when you're trying to put air into the lungs, and you'll very likely get some stomach contents in the lungs, which is bad, especially in somebody that you're trying to ventilate for and trying to keep them alive. So not over-pressurizing that activity is a good thing. So let me ask, how many of you have ventilated for real? A few of you have. How many of you have ventilated for real in a crisis, not in a controlled anesthesia environment? I have once, and that was on a trail at Grand Canyon when a guy arrested. So as slow as I'm going today, I won't tell that story now, but we could tell it at lunch or at the end of the day. But my point is, did you see how few hands went up in the room? Practically none of us have ventilated for real. We've done it a lot on a plastic mannequin, but not for real. So technically, getting a good seal in an open airway is a difficult thing to do, but it's a very emotionally charged thing because you're worried that somebody's about to die. And that's a big deal. And many of us, when we're ventilating, we are trying to squeeze the breath of life in them as hard and as fast as we can, which is not the technically correct way to do it. You want to push very slowly and gently, which most of us will not do in a crisis. This pressure gauge, and it's easy to interpret, green, yellow, red. You'd like to keep the little arrow in the green part, because you're very unlikely to push air into the stomach and make them vomit. So, it's a long way to describe, consider getting a pressure gauge on your next bag valve mask. What about some emergency medications? Okay, so these are not particularly germane to sedation. This is just for a basic emergency kit. So in the middle of the screen, we've got a red little aerosol sort of squirt Banaka spray, breath spray kind of thing, but nitroglycerin. And then right next to it are some nitroglycerin tablets. Okay, and right next to that is some aspirin. When would we use the nitroglycerin and the aspirin? So we're thinking about cardiac events. Okay, we'll go through that in more detail. Down below you see a Ventolin, and in smaller print, the albuterol inhaler. When would we pull that guy out? Somebody having a bronchospastic event, an asthma attack. Okay, fortunately a lot of patients are going to know how to use that on their own. Then off to the left, I've got some diphenhydramine, which many of us will also call Benadryl as a brand name. We'd use that to treat mild allergic reactions. And so it reminds me of the importance of your protocols, how you write the name of a drug on your emergency protocol. So now I'm talking to the non-doctors in the room again. How many of you are aware that in your office you have some sort of emergency protocol, something written down? Okay, a lot of hands are sort of going up, okay? Now I'm sort of talking to the doctors. If you're thinking about an antihistamine, how often do you think you might spit out, I need some Benadryl? I need the Benadryl. How many of you have brand name Benadryl in your emergency kit? My guess is not many of you. Some do, but I'll bet a lot of you don't. Do you see the conflict, the problem if Dr. Cruz asks for Benadryl and in the emergency kit, Doc, we don't have any Benadryl. Are you sure? I know we've got it. Doc, there's no Benadryl in here. So now the doc starts looking around, and if he's in his right mind, he'll go, oh, the diphenhydramine, that's the same as the Benadryl. Many years ago when I was a resident at the dental school in San Antonio, we had a staff member, a hygienist, that was sensitive to strawberries and also had some asthma, exercise-induced asthma. Well, one day she had a salad that had a little bit of strawberry on it, and she went out and ran. So she developed a bronchospasm and an anaphylactic response. So I came back from lunch, she's sitting in a chair, and her lips are thick, her eyelids are swollen. She was almost unrecognizable. She had her name tag on, and it was Mary? You know, I changed the name there. My 2 attending staff for the program, 2 of the smartest people I've ever met, decided they wanted to give her Benadryl. And so they're rifling through the emergency closet right next to the dental chair. I'm just standing there watching, and they're literally tossing things out of the closet. What did they toss a box of out looking for? Benadryl. There was a box of diphenhydramine. So the docs, 2 of them, missed that point. So I sort of go back to, on your written protocols or on your drug itself, would it make sense to put a little label that just says Benadryl? Or you might say the same thing with your reversal agents for your sedation. Now, flumazenil is about the only name that I think, brand name Romazicon, I'm not even sure that it's still available. But flumazenil is about all I ever see or hear. But for opioids, the reversal agent is generic naloxone or brand name Narcan. How many of the docs are going to go, I need some Narcan? And what you probably have in your kit is naloxone. So, you know, it's silly, stupid stuff that can get in the way of managing. It's not always poor training. It's some little glitch along the way that prevented emergency from taking place. There was some sugar up at the top. We'll use sugar for patients that are hypoglycemic. And then on the top right, we've got different forms of epinephrine. So we'll talk about epinephrine. I learned this kind of, it sort of smacked me in the face. This was years and years ago. I was asking in a group, what do you think is the most important part of your emergency kit? And at the time, my answer was your oxygen tank. And a gentleman sort of pulled out his phone and he goes, my telephone. And I thought about it for a moment and it was like, oh yeah, you're right. Now for the individuals in the room without a Y chromosome, this is generally not a problem. For the people in the room with a Y chromosome, asking for help it smacks against the male ego. Many of us do have a hard time asking for help or directions or admitting defeat or however you want to put it. As I've aged, I think I've gotten better. Years ago at the dental school, so if you went to dental school in San Antonio, you may remember that if there was an emergency in the clinic, they would call a code orange. And so people from different areas would sort of come running. And I remember responding to a code orange, and this was many, many years ago. It was early in my career. And I'm sort of trotting down the hall headed to whichever bay. And I remember saying to myself, Okay, airway, breathing, circulation. I need to be able to handle this. I need to be able to handle this because I was nervous. Was that the right attitude? And my answer now is no. That was, I can do this, I won't need any help. That's the wrong attitude. I think we take an initial look, we do some initial things, and if we can't fix it to completion, get help. I've heard EMS folks say, call while the patient is still alive. We can help while they're alive. Don't wait until they're dead. We can't help then. And we sort of chuckle about it now, but it's absolutely true. So, I never ever, when I'm practicing emergencies with residents with a fancy little training device we've got, I never ever 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 dog folks for the minute your gut tells you to call EMS, you should call EMS. And I've made it really clear with the staff that I work with, if you think I've lost control, if you think I'm not making good decisions, if you think we should be calling EMS but I'm disagreeing with you, I'm encouraging you to put a footprint right there. Just walk right over me, call EMS. I will never, ever, ever get you into trouble. If you're trying to help a patient and you think I've lost it, call EMS. And there are clearly examples of where the doctor just, yeah, I know, we're okay, and the patient dies. So it's helpful, and we'll talk about this a little bit more in a few moments if I get there. It makes sense to have some pre-planned times to call EMS. That isn't your sole list, but go ahead and think out loud about times when you would call EMS. Somebody throw something out. I'm sorry? Okay, choking. If you can't fix them in the first few seconds, okay, I like that. Heart attack. Okay, are we going to fix a heart attack in the dental office? No. Okay, what else? Stroke. Are we going to fix a stroke? No. And if they're going to get treated for that stroke, do they probably need treatment really fast? Yes. Okay, so time becomes an element. So there's a number of pre-planned things, but all of those were based on you had a sense of what the problem was, and then you decided, I'm not going to fix this. What about a situation where you go, I thought I knew what this was, but no, I don't know what this is. It's a big deal, but I don't know what it is. That's another time to call EMS. But that, is harder to describe. But it's like, ooh, geez, this is not what I recognize. But it's a big deal, so let's call. If you're doing sedation, there's some extra things you got to have. So certainly reversal agents, if they're available, depending on the level of sedation you do. So if you're doing minimal sedation, if you use a single drug, a small dose of a single drug, you have a level 1 permit, you are not obligated to have advanced airway devices. Your basic airway devices are satisfactory, at least to the board. Bag valve mask, oral airway, your oxygen tank, that's basic airway equipment. If you do moderate sedation or deep sedation, level 2, 3, or 4, you must have advanced airway equipment. So that's going to be at least some kind of supraglottic airway device. iGel is just a brand. Or full-blown endotracheal tubes. So that would be something where the tube actually goes down between the vocal cords. And that's a skill to develop and difficult to maintain. The supraglottic devices are much simpler. They pretty much just sort of slide down the gullet. They're easy, but I want to make it clear, level 1 providers don't need to have this. Level 2, 3s, and 4s are obligated to have something like this, this particular device. That's just a particular brand. All right, so we've already talked about, when you should call 911. I'm going to keep going. I think it makes sense to put little hints about calling EMS into different places in your kit. So we open our kit. This is up at the school, so we've got this big kit. And the first thing you see is Do we need 911? You know, if you're opening up this kit, do we need 911? In the bag valve, whoops, that's not what I wanted. In the bag valve mask, which has an oral airway in it and the reservoir and the mask and all that sort of stuff, I've got a label that asks, if you're pulling out this device, do you need EMS? Or if you're pulling out a defibrillator, do you need EMS? Okay, you know, when we're sitting here think about it, it's like, well, yeah, of course. But at the moment of, that often, you know, we get so focused on trying to deal with the technical nature of the problem that we forget to go, yeah, we probably need help. Okay, so let's talk about syncope. What time is it?
9:35.
Okay, so probably the most common event in a dental office is a patient fainting. So syncope, just as a medical term, really, I didn't do that, is a broad event, a transient loss of consciousness with loss of postural tone, which means the patient would fall down if they're standing, followed by complete and usually rapid spontaneous recovery. Okay, now there's lots of reasons that this could happen. So it could be an abnormal cardiac rhythm. It could be, you know, especially for the gray-haired folks in the room like me, but do you ever sort of get down and you're doing something on the garage and then you stand up abruptly and the room spins? It does for me once in a while. So it's just an example of blood flow to the brain becomes inadequate momentarily. Okay, so that's syncope in a broad sense. Come on. Okay, come on. Yes, they fall down. I do not know why it is doing that. Okay, so there are sensors in the arch of the aorta. So this is blood coming out of the heart, sensors in the arteries that are headed up to our brain. They're stretch receptors, but that gets sort of translated to pressure. When there's a lot of stretch, there's a lot of pressure. When there's not much stress, there's not a lot of pressure, and so that gives input to the brain to decide to pump harder or not so hard. Okay, our heart will beat on its own. It sort of just runs on its own, but it's influenced by our nervous system. And so there's a part of the nervous system that will make it run harder and faster. So that's our sympathetic nervous system. There's a part of our nervous system that will slow the heart down. So there are times of the day where we don't need a lot of cardiac activity. And of course it gets broader than just the heart. Or there are times when we do need a lot of activity. So if you're a caveman or a cavewoman walking back from a hard day hunting and gathering, and you turn a corner and there's a bear, and the bear sees you and the bear thinks, dinner. So your body will squirt out a bunch of epinephrine, adrenaline, because your body is getting ready to run from the bear or fight the bear. So does it make sense that you need your heart to pump harder and faster, and you need to see better, and you need to be able to breathe better, and you don't need to, your gut doesn't need to be working, and you know, so there are systems that sort of shut down and systems that come on board. And then assuming you manage to outrun the bear or you actually kill the bear and eat the bear, well, now you got to be, so now you can shut down the heart running harder and faster and being able to breathe better, but now you've got to digest the bear. So there are different times, there are different systems that need to run differently, and so those will influence our heart. So we're talking about syncope. They will influence our heart. Okay, when we talk about syncope in a dental office, we're almost always talking about vasovagal syncope. So that implies some relationship with the vagus nerve. So the vagus nerve, you know, travels all over the body, not just, even though it's a cranial nerve, but it plays a role with blood vessel dilation and heart rate. So the bear, And that's as good as I could get as a bear sort of running after you and activating the sympathetic nervous system. Okay, so coming to the dental office is a nerve-wracking thing for a lot of our patients, right? You know, I am not a good dental patient. I'm a good dentist, but I'm not a good dental patient. So if most of our patients are anxious about being in the dental office, so if coming to the dental office is like seeing a bear, well, so does their heart rate go up? Does their blood pressure go up? Do you see that when you measure it? Does it surprise you? You know, I think sometimes we get overworked up about somebody's elevated blood pressure in the dental office. It's like, oh my gosh, you know, the body senses a threat. It's supposed to respond this way. Okay, that's not my point at the moment. People come to the office and many of them are nervous. But why is it that only a few of them faint? What goes wrong that makes some of them faint? Okay, because they're not fainting just because they have some spontaneous cardiac rhythm disturbance. That's not what happens. You know, they're nervous about what's going on. Well, there's a reflex. I know I butcher the name Bizzle-Jarisch reflex. I've never heard a clear pronunciation of that. But the idea is that when we're stressed and our heart is beating harder and faster and our body is getting ready to run from the bear, which means that our body is sending blood to these big muscles in our legs to try and run from the bear, or our arm to fight the bear. But when you squeeze those muscles, what does it do to the blood that got out there? And then you squeeze on the muscle. It pushes that blood back so that it can be oxygenated and pumped around again. So the system depends on the heart pumping the blood out, but then the peripheral muscles pumping the blood back. Well, what's the patient doing in a dental chair? They're sitting there, and if it's a guy, trying to not look nervous. Yeah. Yeah. Okay. So they're trying to not look nervous. So the heart may be going to beat the band, but there's not much blood coming back. And if they're just sitting there, blood tends to pool, especially in the lower extremities. And there's the potential that the sensors in the left ventricle will sense, hey, we're kind of running out of blood here. We're pumping blood out, but we're not getting blood back in. Okay, so that information gets sent up to the brain, and via this reflex, the brain, you know, in the presence of this exaggerated sympathetic activation, you know, being ready to run or fight the bear, if there's the sense that, whoa, the heart is running out of blood, so the brain puts the brakes on, slows the heart way down. Okay, so vagal tone goes up, but another odd part of this is when you withdraw the sympathetic tone, you know, then we end up with some vasodilation. So we slow things down and we vasodilate, and the blood pressure just plummets. How quickly does the brain run out of oxygen, run out of juice? When does the brain shut down? When blood flow stops, how quickly will the brain shut down? How many of you were watching the Buffalo Bills play? I guess it's been a couple of weeks now. So the player Darryl Hamlin, did I get the name correct? So I saw the event on TV. So how many of you saw it? A lot of you saw it. So you saw the two players collide, the tackle. My sense was it was just a sort of a normal solid hit. Darryl got up. I think the expectation or the understanding is that it was the impact that probably put him into cardiac arrest. I think that's my assumption with this. But he actually got up. Did you see him get up? He took, I don't know, a step or two, and then it was just like you unplugged him and the lights went out and he fell. So my assumption is he went into cardiac arrest at the impact. His brain functioned for another 4 seconds, something like that. But blood flow to the brain stops, so the brain shuts down just instantly as a protective mechanism. Okay, so in syncope, when the brain puts the brakes on the heart rate and promotes this vasodilation thing because of that reflex, blood flow to the brain stops or dramatically drops, and consciousness is lost rapidly. Okay, so what do you do at that point? The problem is blood flow to the brain. How do we get blood flow back? So just changing the patient's position will help a bunch. It's hard to faint flat. It can happen, but it's unusual. It'd be really unusual. So most patients are at least to some degree upright when they faint. Okay, so leaning back. If this is a simple faint or a vasovagal syncope event, they ought to wake back up in, I think my slide says 30 to 60 seconds. Maybe I don't have it on this slide. Do I have it at, 30 to 60 seconds? My personal experience is I think you've all seen syncope. And I would say I don't think I've ever seen anybody that was out for 60 seconds. I'm not even sure that I've seen 30 seconds. But I think I took that from a literature source. 15 seconds, maybe. They should wake right back up. If they don't wake right back up, I would say at least in the 60 seconds, then I'd be going, something else is wrong. And so I would want some vital signs. So this is a reasonably benign thing for the most part. It's nice to know, because some patients will tell us, Doc, I faint every time I get a shot. If I see blood, I faint. So there is this, remember, this exaggerated sympathetic stimulation. There's this mindset that every time I faint, every time I blank, I faint. If that's the mindset, the mind's a pretty powerful thing. So if they warn you of that, or you sense some prodromal signs and symptoms, maybe excessive talkativeness, or somebody that is shut down, when they were talkative, sweat. When I see it, in my life, a lot of what I do is I start IVs and I sedate patients. So starting the IV is probably the most common time for me to see somebody faint. By the time they get to the local anesthetic, my patients are pretty far out into Never Never Land, so they don't faint then. So if you take a patient that goes, Doc, I faint every time I get a shot, if we can get past the IV, and then we give them shots all over their mouth, they never faint. So it's a brain thing. It's not a poking the skin thing. It's a brain thing. Leaning back for venipuncture or injections. You've seen the patient probably just sort of these little myoclonic jerks. It looks a little bit like a seizure, but it's not really a seizure. Okay, lean them back. Oxygen only if they're hypoxic, so that means putting on a pulse oximeter. By the time you get a pulse oximeter on and get a reading, if you've leaned them back, they're probably already waking up. Nitrous might be helpful for future events, but I would also say lean them back. If you get a sense that I pass out when they draw blood, lean them back before you draw the blood. And very likely they won't. And expect rapid recovery. Okay. There should have been another slide there. There it is. I don't get, somehow okay. Asystole. Has anybody seen a patient go into asystole when they fainted? There's lots of examples in the literature of this. Most of you have never seen it. Why not? Most of your patients aren't on an EKG tracing when they faint. We give them an injection for a local anesthetic, and they lose consciousness. Some of them, their heart actually stops for a few seconds. It pretty much always starts again. So you just don't worry about that. But you look at the line down on the bottom here on this graph. You see a fairly rapid heart rate, and then it slows down, and then there's a few seconds of asystole. Rapid heart rate, slower heart rate, and then a few seconds of asystole. And then they start back up again. So it's there. You know, you probably, even if you had them on a monitor, you probably could not gather yourself quickly enough to start doing chest compressions. And I wouldn't worry about doing chest compressions. If this is in the setting of, I think he fainted, just give it a few seconds. I've never seen it, but I've talked to an individual to whom it happened. It was a former resident doing their first sedation after residency. And they called me and they go, Ernie, I started the IV, had them on the monitor, I put them on, I started the IV, and they fainted, and oh my gosh, they went into asystole. The point was, you can't imagine what it's like to watch your patient go into asystole. If you understand the rhythm tracing, you understand the implications of that little bumpy line stops, you just can't imagine the emotional load that goes with that. So anyway, the patient was fine. Everything was fine. It was just interesting sort of how and when it happened on that for that individual. Okay, all righty. Let's keep going. What time is it?
9:51.
Okay, I think I can get through bronchospasm. So bronchospasm is a reversible spasm of the smooth muscle in your little airways up in your lung. So in your lung, you've got big airways that have cartilage, like the stiff stuff in your nose and your ear, that's cartilage. Some of the bigger tubes in your lung have cartilage that hold that open no matter what. But then you get down deeper into the lung, and those little air tubes are soft and floppy, and there's smooth muscle there that normally is kind of relaxed, but there are various positions there. Remember, there are times when we want big open airways and times when we don't need airways that are so big and open. So our sympathetic and parasympathetic nervous system can impact that a little bit. In asthma, we've got some defects there that result in some ongoing inflammation in those little tubes. So we're not talking about the air sacs at the very end, and we're not talking about the big tubes near the top. We're talking about the little tubes in the middle where there's some inflammation. So the lining of the tubes gets thicker. There are cells there that produce mucus, this gluppy, thick, gluppy stuff. And smooth muscles that spasm that make those airways smaller. So the thickened skin, the thickened lining, the spasm of the muscle, the mucus production, all those things work together to make a bigger airway teeny tiny, which makes it so that you can't breathe. So asthmatic patients will occasionally have these events depending on how well controlled they are. So there are controller drugs that they may be taking. Singulair, Advair, there are a number of combination drugs that have long-acting beta-2 agonists and steroids and maybe some anticholinergic agents mixed in. So those are drugs for control. Rescue agents, things that would be similar to, if not identical to what you've got in your emergency kit, albuterol, are absorbed rapidly and for a short period of time will allow those airways to dilate and actually dry up a little bit as well. Okay, so in a bronchospasm, we'll typically hear some wheezing. And most likely, if this occurs, it'll be in somebody who already knows that they have this problem. And if they don't pull out their own inhaler, we'll be able to tell you what they need. And assuming they've used their own inhaler before, if they don't have it, I would just take yours, shake it up, puff it once or twice, and hand it to them. The reason you take your inhaler, shake it up, and puff it a time or two is your inhaler most likely sits unused for months or a year at a time. The little metering hole in there apparently has some I'm so sorry, has some potential to clog. So when you puff it, away, you may notice that that first little puff is kind of puny and then the second one is better. Most likely the patient will be able to administer the albuterol on their own. Come on. So once in a while I get asked, well, can you use epinephrine in place of the albuterol? For a while, the albuterol inhalers got pretty expensive. So if you want to look at literature, you can say intramuscular epinephrine was as good as albuterol at promoting bronchodilation. Okay, so you probably got some epinephrine in your emergency kit, either in the form of a break-open amp, or a rubber stopper vial, or an EpiPen, or something like an AviQ, an epinephrine device. You pull the lid off and it talks to you. Okay. So from a technical standpoint, the epinephrine is just as good. Well, then a follow-up question that I got was, can I just use Primatene Mist? Where do you buy Primatene Mist? HEB. It's at HEB. So you can buy epinephrine spray at HEB. I remember it's like, what? I can buy epinephrine at the grocery store? It's like, yes, you can. So is it okay to use, so wait, don't take your picture yet. Don't take your picture yet. Now take your picture. Can I just use Primatene Mist? Nobody that I know of is recommending that Primatene Mist is an appropriate substitute for albuterol. Because Primatene Mist is a few bucks and the albuterol is significantly more expensive. The Primatene Mist will actually take effect a little bit faster, but it's very short acting. And what's the problem with epinephrine? Whether we're injecting it or if they're inhaling it. Make you drowsy? Maybe. I'm thinking sort of the other direction. It has the epinephrine is beta 1 and beta 2 active. So the beta 2 part, our smooth muscles in the lung have beta 2 receptors, just like the smooth muscles in our big arteries, and when you put an adrenergic agent like epinephrine on it, it promotes dilation. So wait, you're thinking epinephrine is a vasodilator? Yes, epinephrine is a vasodilator when you're thinking about beta 2 receptors on smooth muscle. So that would be in the lungs, and that would be in big blood vessels. So go back to the bear. You turn the corner, you see the bear, and your body is preparing you to run or fight the bear. Does it make sense that your heart, that you get more blood to your big muscles to be able to run from the bear or fight the bear? So do you vasoconstrict or do you vasodilate those vessels? You dilate them. Epinephrine is also an alpha receptor agonist, which means it promotes vasoconstriction where those receptors are. Well, where do we find those receptors? Like skin and mucosa. Why do we use epinephrine in our local anesthetics? Because we're putting it in areas where we've got mucosa, these alpha receptors. We want the alpha effect that promotes vasoconstriction. It'll decrease bleeding, but it also limits uptake of the lidocaine or whatever the local anesthetic is. It helps keep the lidocaine in place. So you get a longer effect and maybe a more profound effect from the local anesthetic. Okay, but what about inhaling epinephrine for somebody having a bronchospasm? Nobody that I know of is thinking that that's a good idea. And a big part of it is it doesn't last long enough, and it has a bunch of unwanted cardiac effects, just like the IM epinephrine would. Okay, what time is it? Let's take a break. So what time are we going to come back, Dr. Cruz? 10:10. 10:10. I'll be back in 10 minutes. Okay. Were there any burning questions from our earlier discussion? Okay. Alrighty. I'm not sure if any questions have maybe popped into the video stream, but I trust that if something does, that somebody will let me know. Okay. So let's talk about blood glucose. And I deal with this regularly. My mom is a type 1 diabetic. My mom is almost 91. She lives in the home with me. She is an awesome woman. We live on an acre, and she does all the yard work, including pushing the lawnmower. She's about, a little less than 5 feet tall. She weighs less than 90 pounds. And she mows my lawn. But I bought her a new lawnmower. And actually, we didn't buy a riding lawnmower because we were because there's a little bit of a hill, and we were concerned about it rolling over. So we didn't think that was a good choice. But no, she's a wonderful woman, but she has type 1 diabetes, and so we're dealing with blood sugar issues just all the time. Okay, so let's talk about blood sugar in our patients. Now, most of our patients that have diabetes have type 2 diabetes, which means they've become insulin resistant. Their pancreas is still making insulin, but it doesn't work very well. It's often associated with, there are genetic components, but there are also lifestyle components. Most type 2 diabetics are overweight. There's lots of carbohydrates, lots of saturated fats in their diets. But those are clearly not the only issues. But nonetheless, most diabetes is type 2. The main problem with those folks is their blood sugar gets too high. It's not that they never become hypoglycemic, but that's at least been my experience, has not been the major problem. It's been that they get high. So when people are high, at some point, it gets high enough that the brain doesn't function real well. So we see confusion. Okay, there's weakness. There may be abdominal pain. If they're actually forming ketones in the blood, it'll come out of the lungs and it'll smell like sort of a fruity smell or maybe an acetone kind of smell. That's usually pretty high. So if we get somebody that has elevated blood sugar and they seem different, they don't seem to function quite right, and their blood sugar is too high, I believe that represents an opportunity to use our telephone and call EMS. How many of you in your office have access to a blood glucose meter? Some of you. So I assume some of you don't. So if you have access to a glucose meter, take a blood glucose measurement and decide if somebody's high or low. What's the real crisis? When does blood sugar that's out of whack become a crisis, especially from a time standpoint? Is it when they get too high or when they get too low? It's when they get too low. So I'm not saying that elevated blood sugar is not a problem. It is. It's a big deal. But it evolves slowly, and the problems that develop, the electrolyte abnormalities. So when your blood sugar gets high, the problems that develop are not just elevated blood sugar, but you develop electrolyte abnormalities. So simply just trying to fix the blood sugar at that point won't really fix them. So they need to be in the hospital for a while. If you have a patient that is diabetic, is behaving weird, though you would assume that their blood sugar is low. Because you already answered, the crisis from a time standpoint is blood sugar that gets too low. This can evolve over minutes. And so I've seen it in my mom. If a mistake gets made with an insulin dose, and I've seen this happen, she is determined to serve other people, to serve others in whatever form that is. But sometimes it occurs by she takes her insulin and then gets distracted and starts doing something else like feeding the cats in the home or coming over to wash dishes on our side of the house or whatever it may be, and she in essence just forgets to eat. And so she's taking insulin and not taking any food. So for diabetics, food is medicine. And so if the pancreas isn't working correctly, so that's the problem. In type 2 diabetes, the insulin that's being made, the individual is resistant to it. It doesn't work real well. In type 1 diabetics, the pancreas is just not making insulin. Although there seems to be some evidence that maybe once in a while it does a little bit. You know, we can't always understand her response when we do give insulin, but nonetheless, it's a pancreas issue. But she'll get distracted once in a while, and her blood sugar will get really low. Once I saw her down in the low 30s, which is really, really low. If you have a diabetic and you can't measure the blood sugar right there and they're behaving weird, you should assume that the blood sugar is low and give them some sugar. Okay, we'll talk about the forms the sugar should take here in a minute. Give them some sugar. If their blood sugar is low and they get better to the point of they feel good, you're probably okay. That probably does not justify an EMS call in my mind, although remember I said if your gut tells you you need EMS, call EMS. You know, what's the worst thing that happens is they get there and go, yeah, things have resolved. It's good. Okay. All right. Thanks a lot. Thanks for calling. We'll see you later. If the blood sugar is high and you give them sugar, well, now what? How big a deal is that? Is that a big problem or a little problem? You just make the high blood sugar higher. So it's not that big a deal. If they're already behaving weird and you give them some blood sugar and in 15 minutes they aren't better, then the problem is probably not low blood sugar. So if they're diabetic and they're behaving weird at that point, you know, we're thinking, is this a stroke? Is your diabetes out of whack? And without a blood sugar, you know, you can't carry that, you know, information trail one step farther. Just call EMS. Okay, so some of the, you know, if you look at, well, what do you see? Shakiness, dizziness, tachycardia, confusion. Some of those things are a little different, but my sense is there's a lot of overlap between how patients look when they're hypoglycemic and how they're hyperglycemic. Now, if you smell the fruity breath or the acetone on the breath, that fingernail polish remover, that's elevated blood sugar. So folks that have blood sugar that's too low, you know, there's no like odor on the breath. Okay. For my mom, and you would have to know my mom to appreciate how crazy this is, she sort of becomes like a drunk sailor when she's hypoglycemic, which is completely out of character for my graceful, Christ-loving mom. She is a saint, but when she becomes hypoglycemic, she is just so out of character, and it's just, even though she's talking, it's just so out of, it's like, Mom, let's check your blood sugar. It's always really low. Okay, so we've got high blood sugar and low blood sugar. It's hard to tell clinically, without a meter, is the sugar high or low. If you don't have a meter, assume that it's low and give them some sugar. Okay, so now let's talk about sugars. One thing I never got a good sense of in dental school was how much sugar. So down at the bottom of the slide you see 10 to 15 grams. Most any form of carbohydrate will work. There are some that are absorbed much faster than others. Table sugar is okay. Or sweets or candies or soda pop are okay. Or orange juice, those are okay. Okay? Glucose, which is the same as dextrose. So if you can come up with a product that says glucose or dextrose, they're the same thing. They're actually absorbed and do exactly what we want the fastest. So that's really your best choice. So on the right-hand side of the screen, you see a dedicated glucose tablet product. And my guess is a lot of you have seen these. They're sort of like big sweet tarts. Those tablets, I think, are pretty consistently 4 grams apiece. So for a diabetic that's behaving weird, if you either know their blood sugar is low or you're suspicious that it might be low, you're giving them 3 or 4 tablets. Okay, if you're using some other product like soda pop or lemonade or a candy bar or crackers or something else, expect the response to be a little slower. But then you're having to figure out, well, how much of this would be about 10 or 15 grams? Okay? The dedicated sugar tablets are not always easy to find, and at least at the HEB where I live, they sort of lock them up in the pharmacy, so you can't just pluck them off the shelf. In the grocery store, it's like they're candy. They're sweet tarts, and you lock them up. I don't get that detail. But if you go to the candy aisle and you see the Mentos, those are mostly glucose. They're about 2 grams a candy. So if you wanted to buy those would be okay. That, in my mind, that would be a reasonable substitute. The sugar tablets are not really particularly expensive, and you can order them from your favorite online retailer. That would be fine too. From a speed standpoint, glucose gets in better than sucrose. Sucrose is table sugar. So processed foods that are sweet, those have sucrose in them in general. Mentos are mostly glucose, which would be a little bit better choice. The gels, how many of you have a gel in your emergency kit? Have you ever tried the gel? Do you like it? Yeah, have you ever tried it on yourself? I find it pretty, yeah. So now my question is, how effectively, if you just sort of coat some on the mucosa, does it soak through the mucosa well? And that answer is no. So the gel products, they need to swallow the gel. You need to get it in their gut, in their stomach. It will absorb significantly faster. So transmucosal absorption of glucose is not particularly good. Okay, it does occur, but it's not particularly good. Let's see. Don't have them take the Mentos if they just drank a Coke. I expected people to laugh at that. So you've seen what happens if you take some handful of Mentos and you drop them in a jug of Coke and it sort of explodes. All the CO2 comes out of solution very rapidly. Okay, don't use that in somebody who's been drinking Coke or soda pop. For those of you with IV starting skills, if you're doing IV sedation, you may have some dextrose in a bottle, although it's pretty hard to buy. Has anybody bought any recently? It's hard to buy. My stuff has expired. But 50% dextrose is also an easy way to put sugar into the body. So do you remember the dose of sugar that we're thinking of? For somebody that's hypoglycemic, think about 10 to 15 grams. Okay, if you've got a 50% bottle of dextrose, it's a 50 ml bottle, 50%, so half of that liquid is sugar. So half of 50 is 25. So that bottle has 25. So don't run in the whole bottle. Most likely don't run in the whole bottle. A third to a half the bottle would be appropriate. But the most important thing to remember is if you're using 50% glucose to raise somebody's glucose and you're doing it IV, now it would be inappropriate to be putting it in IM. The volumes you'd be using are way too big to be injecting into a muscle. But if you're giving it IV, remember that 50% dextro, the osmolarity is extraordinarily high. You're putting a liquid into tissue, but that liquid doesn't have much water in it. It has lots of stuff dissolved in the water, but there's not a lot of water there. So if your IV fails and the liquid that you're injecting starts collecting in interstitial tissues, like the IV infiltrates, and you get a pool of this liquid in tissue, and that pool of liquid has a lot of water in it or a little water in it? A little water in it. But the tissues surrounding this pool have a lot of water in them or a little water in them? A lot of water. Yes, relatively speaking, the surrounding tissues have the liquid in there has a lot of water in it. So what's the water? The water where it's crowded moves into the spaces where the water is not crowded. That kills the tissue surrounding. So this is a picture. Now I didn't take the photograph, it came off the internet, but it's a 50% dextrose tissue injury. So the idea would be is that yes, you can put dextrose IV, but make sure your IV is really flowing well. So I would say, do you use sedation? Do you do sedation with a butterfly needle, or do you use a catheter? If you use a butterfly needle, we know the literature is clear. Those things infiltrate rapidly and predictably. You've left a little scalpel blade down in the vein. They move around, of course it's going to cut through the side of the vein, and then whatever you're putting into the plastic line is going to leak into the tissues. Most of the things we inject, it doesn't really matter very much. 50% dextrose, though, is bad to inject into interstitial tissues. And so that's a picture of what it looks like. Okay, so 50% dextrose, don't overshoot. Make sure your IV line is actually flowing well. Other options for hypoglycemia is to use a drug called glucagon. It comes in several forms now. This is an older style where the patient, this was intended for patients, where the patient would have a syringe with fluid in it. They would have to stick a needle into the vial that had dry powder in it. They'd shake up the liquid in the powder, and then they'd draw it back into the syringe and then stick it in a muscle, or you could stick it in a vein. And it would stimulate sugar release by the liver. The other thing it would stimulate is the vomiting reflex. So a lot of people throw up with glucagon. It's a fairly expensive product too. There are a couple of newer brands. Baqsimi is a spray up into the nose. And this is a preloaded glucagon pen. Again, this is intended for patients, so there's no mixing. It's kind of like an EpiPen in thought or in concept. So you just sort of pull a cap off and stick yourself. Okay, so blood sugar issues. So too low is the crisis. Get sugar in. If they get better quickly, you're good. If they're high, if their blood sugar is high and they're behaving weird, that's an EMS call. I am not going to inject insulin. And my mom and I have tried it a couple of times when she wasn't sick, but her blood sugar was really high. We've tried little doses of insulin, and oh my gosh, she'll be high and then she'll be in the cellar, and we're trying to fight that. And that's in a controlled situation, or at least we think it's controlled. And we still can't do it predictably. So if they're sick and their blood sugar is really high, or you don't know, give them sugar, but if they don't get better in 15 minutes, then that's an EMS call. Let's talk about stroke. So strokes come in a couple of different flavors. A stroke occurs when a blood vessel that carries oxygen and nutrients to the brain is either blocked or ruptures. Tissues distal to the clot or the hemorrhage become ischemic and die. So stroke implies death of brain cells. Most strokes are related to atherosclerotic plaques. Same kind of thing that goes on in your coronary arteries in your heart. So when people have heart attacks, a stroke is like a brain attack. It's the same kind of process, for the most part, the same kind of process that's occurring in arteries that supply the brain as opposed to arteries that supply the heart. 10 or 15% of strokes are associated with a blood vessel that'll actually burst. And blood is just leaking into the tissues of the brain. But most strokes are associated with a vessel that becomes blocked. So those atherosclerotic deposits build slowly over decades, but then at some point one of them will become fragile in an inflammatory environment. It'll rupture, exposing connective tissue down underneath, initiates the coagulation cascade, and a clot forms and blocks the tube. So that's most strokes, and that's the mechanism for essentially all heart attacks as well. So what do we do if we think somebody's having a stroke? The most important thing is to cough. We're all coughing here. Okay, no, not cough. Most important thing is just to try and recognize basically what's going on. So there's several stroke screening tools. Now I'll tell you, I've never knowingly seen a stroke, an evolving stroke. I've seen people that have had strokes, but I've never seen an evolving stroke. I think the most commonly used screening tool is called the Cincinnati Pre-Hospital Stroke Scale, and you look at three things. You look at facial droop. So facial droop just simply means, when the starting idea is that when we smile or grimace or frown, we usually do it symmetrically. So it's just the muscle movements are the same left and right. When we have a stroke, it's typically one side of the brain is affected, so it will alter us in an asymmetrical way. So it changes things that we expect to be symmetrical into asymmetrical things. So the facial droop, you ask somebody to smile or grimace or frown, and they do that, and you go, that looks funny. And that's really all you have to know. You don't have to go, well, is it the left side that's funny or is it the right side that's funny? It doesn't matter. The fact is, that's not the way you smiled 30 minutes ago. That's not a normal looking smile, grimace, or frown. You look at arm weakness, and I got to put these things down here. I can leave this. So you ask them to put their arms out or out like this with their eyes closed. Their eyes need to be closed. And the idea is that either one of them won't move at all, or it won't move much, or it'll drift. But otherwise, everybody else in the room ought to, if I said close your eyes and put your arms up, you do this and you do it symmetrically. So the stroke would make that happen asymmetrically. If their eyes are open, there's the potential that they can accommodate and recognize that, oh, that's not quite right, and be able to accommodate. You don't want to give them the opportunity to accommodate. So we've got the facial drooping, the arm weakness, and some sort of speech difficulty or garbled speech. So it's like your words just don't sound right. Any one of those three things that's positive, just one of them, there's a 72% chance they're in the middle of an evolving stroke. So that would be the trigger point for me to call EMS. Any one of those three, okay? There are other kinds of neurologic events, though, besides a full throttle stroke that results in death of brain cell tissue. There is something called a RIN, reversible ischemic neurologic deficit or event. A transient ischemic attack is another similar sort of thing, TIA. They're technically slightly different from the time parameters that are involved. Patients will often refer to these as mini strokes, or maybe I've had a mini stroke. It's kind of like I had some symptoms, but they went away quickly. Clinically, they look, in the chair to you, they look like a stroke. You can't tell the difference until you get to the hospital and start doing CT scans and that sort of thing. So I don't think your CT scanner in the office will do it. I don't think your 3D scanner will do it. A TIA, by definition, will fully resolve within 24 hours. Even if it goes away in a few minutes, they still need to go to the hospital. 20% of patients that have a TIA will have a full throttle stroke within the next 3 months if they don't get managed. Half of those will occur in the next 48 hours. So if they go, if it's this is just a mini stroke, I've had these, don't let them talk you into not calling EMS. I would call EMS, let EMS work with them in terms of are they going to take them in, but EMS, I'm just certain we'll push them to go. Now, of course, if the patient goes, I'm not going, you can't make me go. And they'll go, you're right, we can't make you go, but you got to sign this. So it'd be nice to have, EMS deals with that, I'm sure, on a regular basis. We don't. I'm sure most of us wouldn't get the paperwork right. But put it this way, I wouldn't get the paperwork right. So I'm telling you, if they have a neurologic event like this, whether there's a history of TIAs or not, you can't tell the difference in the chair, call EMS and let the system run at that point. Why is it problematic to go, well, let's just wait a day and see what happens. I'll let you go and see how you are tomorrow. Why is that a problem? I hear murmurings, but my old ears didn't pick it all up. If people are going to get treated for a stroke, so most strokes are ischemic, there's a blood clot. Well, if they're going to become a candidate for a clot-busting drug, it has to be given early. Depending on the exact nature of the stroke, within 3 hours or maybe as long as about 4.5 hours after the onset of symptoms. So when the patient was last known to be normal is really important. What if you've sedated a patient and they were normal when you started and now they're not normal at the end? When were they last known to be normal? At the beginning of the procedure, at the beginning of the sedation. So there's one case that I think is important. It'll sort of nail down a certain thought about managing emergencies. It involved a patient who was being treated by, I can't remember if it was an anesthesiologist, an oral surgeon. It was a level 4 provider. So the patient got deeply sedated with propofol. The procedure occurred, everything was fine. They shut off the propofol. Well, if you're familiar with the use of propofol, it goes away in a matter of a few minutes. I mean, patients sort of wake up and kind of get up and walk out. So the body breaks it down very quickly. And the expectation is that recovery is quick. Okay, so the procedure occurred. They shut off the propofol. A few minutes go by, the patient doesn't wake up. And there's a little bit of concern, but somewhere early in this process, the wife of the patient, I don't know the details of sort of how she got involved, but it became clear that, oh, Howard, every time he gets put to sleep, it takes forever for him to wake up. This is normal. And so they sat there and waited for, I don't know, an hour or two. And finally the doctor goes, this ain't right. His this ain't right meter went off. And at that point goes, we're going to the hospital. So they called EMS and went to the hospital. And it turned out the patient had stroked on the table. But, they'd let, I think it was a couple hours go by. And so by the time all this happened, well, now the patient was outside the window of being able to be managed with a thrombolytic agent to break down the clot. And so the patient ended up with potentially more neurologic deficit than they would have otherwise had. So do you think the patient's wife was happy about that? So do you think the patient's wife goes, oh, doctor, the fact that my husband is an invalid now and he might not have been, that's my fault? Do you think that's what she said? No, what did she say? It's, you should have known better. So when, not just with stroke, but any time with emergency, if you think you know what's going on, but, there's some party that's going, this ain't right. We've used propofol, they should wake right back up, and they're not. This ain't right. Don't sit on it. Choose to act sooner rather than later. Okay. Come on. What about oxygen? So I've sort of started the oxygen discussion. According to the American Stroke Association, so this isn't Ernie's opinion, this is the ASA, American Stroke Association. You only need oxygen if they're hypoxic. Well, how are you going to know what the O2 sat is? You're going to put a pulse oximeter on them. So for the offices that are not doing sedation, do you need a $2,000 box that does pulse oximetry and a blood pressure? No. You can go to your favorite online retailer, and for literally as little as about $10, you can get a cheap little finger probe that just sits on the finger. I think they're accurate. I bought a couple of the cheap ones. They seem not to be particularly durable. But my sense is they're accurate enough. But I believe that we should have a pulse oximeter on our oxygen tanks. So if we got patients that are awake, so most stroke patients are going to be awake, because we're doing this testing, the grimace, the arm movement, the speech, they're awake to do that. But you can tell something's not right. Put them on a pulse oximeter. If they're hypoxic, dribble in a little oxygen with a nasal cannula. Okay? But otherwise, if their O2 sat is in the middle to high 90s, they don't need oxygen. Oxygen can conceivably make them worse, and I'll give you some examples of that later here. What about aspirin? Well, the slide tells you no aspirin. Why not? Some strokes are hemorrhagic. That means they're bleeding into the brain. What does aspirin do besides maybe fix your headache or give you a stomach ulcer? So lots of patients who have had cardiac procedures are using it as an antiplatelet agent. It reduces the potential for future clots to form. So, no aspirin. Now, they might get it in the hospital once they've been definitively diagnosed, but not before they've been definitively diagnosed. So no aspirin in the dental office. which is different from heart issues. So I've already talked about time, calling EMS as quickly is important in stroke, okay? That's probably the main thing is recognize it, get help. You're not going to fix it. We're not going to fix it. Get help. Let's talk about seizures. So seizures is a big, big topic. I don't pretend to understand them particularly well. My depth of understanding is really shallow. But I think we can break them down into generalized seizures that involve both sides of the brain, and the patients lose consciousness, as opposed to focal or local seizures that involve just one side of the brain where they actually remain conscious. I think when most of us think of a seizure, we're thinking of generalized seizures that are either the fairly violent-looking grand mal seizure, tonic-clonic seizure, where there's lots of fairly violent, sort of rigid-looking movements, or maybe an absent seizure. I have a cousin who has absent seizures. And it's sort of like you just, she's moving along and then she just stops. She doesn't fall. She just stops. And then in 15 seconds ago or so, she'll pick back up and just sort of pick up where she went, where she stopped. So they're much more subtle and you might even miss them. Okay? So we're going to sort of focus on generalized seizures. How many of you have seen a patient have a seizure? And my guess is a lot of hands go up, and probably lots of you that didn't put your hand up have seen them. I've seen several. I've never treated one because they went away so fast that I never did anything short of, if I was in their mouth, getting stuff out of their mouth. Now, what if I had a rubber dam on? Well, you might not be able to meticulously get your rubber dam clamp forceps and get that clamp off. I don't know if you could either just leave it there or if you think you could just grab it. But once they start to seize and the mandible starts to close, and if your fingers are in there, you might not get them out. So I'd probably leave the rubber dam. If they've had a previous diagnosis of a seizure, I'd let them go home. If this seems to fit their normal pattern, I'd just let them go home. If it's a new onset seizure and it goes away quickly, literature I'm familiar with suggested just send them for neurologic workup. They don't need to go to the ER. But if their seizure lasts, so a common number in the literature is 5 minutes or more, or they have a second seizure that occurs quickly, then it makes sense to get them to an urgent care center and you're calling EMS. If the seizure persists, consider adding a benzodiazepine. Now that would probably need to be injected. So an oral triazolam probably isn't going to do you any good at that point. But if you can inject a benzodiazepine, that would be good. Do you need to have an IV sedation permit to inject a benzodiazepine for a seizure? You're not doing sedation. You're managing an emergency. So yes, anybody, any dentist in the room here, irrespective of your sedation permit status, could inject midazolam to stop a seizure. You'd need a permit to do it to make a patient relaxed in order for you to take out a wisdom tooth. That would be different. Hypoxia is an issue during seizure. So getting oxygen on board early on can reduce hypoxia. Okay, so you're going to get the sense that I'm really dogging oxygen. I dog the use of oxygen in patients that are not hypoxic. People that are hypoxic, that have low oxygen levels in their blood, need oxygen. When considering the time that it takes to start an IV line, so how many of you start IVs? There's a few of you that start IVs. How many of you started an IV on somebody actively having a seizure? I haven't. I've started thousands of IVs. But I've never started one on somebody having a seizure. So considering how, and those of you that know me, how long does it take me to start an IV? You know, you set your calendar by how long it takes. I do not do it quickly. So just stick them IM. Just stick your drug, inject it IM is probably the easy way to do it. If you know, or you could spray it up the nose. If you already had an IV line in, okay, then you could put it in IV. But starting an IV in the middle of a crisis, if you think it's easy on this particular patient, fine, go ahead and do it. So the question is, what intranasal or intramuscular drug would I consider? So I would say any injectable benzo is what I would consider acceptable. Lorazepam is a slow onset drug. Midazolam or diazepam are fast onset drugs. You'll get blood levels quickly. So my recommendation would be midazolam or diazepam for IM injection. If you're going to spray up the nose, so are any of you sedating by intranasal injection? I have a little bit, so there are a number of drugs that will soak across the nasal mucosa. Midazolam is one of them, but it would need to be the concentrated form. So who are my level 3 and level 4 providers? IV sedation, deep sedation. You know, so you're buying midazolam either 1 milligram per ml or 5 milligrams per ml. If you're going to squirt it up the nose, you want it in the concentrated form, 5 milligrams per ml. And the reason there is it's hard to get enough volume in the nose and get it to stay in the nose. You know, try this at home. Take a syringe, fill it with 5 cc's of tap water, squirt half of it up one nostril and half of it up the other nostril, and then you send me an email and tell me how much of it stayed in your nose. And the answer is going to be almost none of it. So to get enough midazolam in of the pre-diluted form, it's impractical from a volume standpoint. So my opinion is, in this situation for a seizure, I personally would probably forget the the intranasal thing, but I'd just stick them in a muscle. Other things that will maybe result in a seizure. So having a real low blood sugar, seizure, local anesthetic overdose, that's a big deal for us. Alcohol withdrawal, benzodiazepine reversal, they precipitate a seizure. Okay, let's talk about allergic reactions. Okay, an acute allergic reaction is a rapidly and progressive reaction that can be fatal. There are not a single clear definition of what anaphylaxis is. So many of us learned anaphylactic reaction, delayed hypersensitivity reactions. Now I think more common in the literature is just severe allergy and mild allergy. A severe allergy, I would say, is similar to, if you think about anaphylaxis, I would consider those two together. We usually see multiple organ systems involved. Okay, it's a rapid onset kind of event, and you likely see all these things, but most commonly you'll see difficulty breathing and maybe some dizziness. You'll also see a skin reaction in virtually everybody. So 3/4 of patients that have anaphylaxis will develop wheezing, so it'll look like an asthma attack. Not quite half of them will get dizzy. That's associated with blood leaking out of the blood vessels just becoming real permeable, and fluid is just leaking out of the vascular system, so less volume, less pressure. A few folks will develop some GI issues, but almost everybody is going to get a rash, widespread rash and hives. So the hives are the raised events. And then they're going to maybe very likely get some swelling. And this is where I think I probably have something new for you. Did it sound like I said nude? Sorry. I'm so sorry. That's not what I meant to say. So when you think about this angioedema fluid, it's going to take me a minute to settle. So when you think about angioedema, I've always thought about it sort of looking like this, where you see this symmetrical swelling of the eyelids or the lips. Okay, and that's kind of the way I've lived most of my career. But that's one-sided. And there's a lower lip that's decidedly more involved than the upper lip. So years ago, I had taken out some third molars on a young man, healthy young man, and the father was an orthopedic surgeon and the mother was an internist. So they were both physicians. The procedure is fine. The two lower third molars were mesially tipped, and so I reflected a flap, and I took my straight surgical handpiece and made a trough out on the buccal side where the third molar was and split the tooth, and then was able to lift out the pieces. And that was all pretty uneventful. So the procedure finished up, the patient went home, talked with him that night. I think he was fine. And then another day or two later, got a call from, I guess it was the dad at this point. Yeah, everything's fine. My son's not having any pain, but his lower left lip is really swollen. I go, just the lip? And he goes, yeah. And so at that point I'm going, oh crud. I bagged the lip with the shank of the burr. So those of you that have used a handpiece, splitting teeth or troughing teeth, I'll bet I'm not the only one in the room that has allowed the shank of a burr to get up to a mucosa, and it takes about that long, to create a hole in the tissue that big. And it's like, how did I miss that? But I described what I thought it was to the dad. He goes, well, and I said, go back and take a look. So we went back and looked, and he came back to the phone, and he goes, no, there's nothing there. The tissue's all intact. And I go, are you sure? So I just can't think of anything else that this would be. Should you go back and look again? And so we went back and looked, and he goes, I'm an orthopedic surgeon, right? And I go, yeah. And I described the handpiece I used, and he goes, I used handpieces exactly like that. I know exactly what you're talking about. There is no tissue damage there. And so we both sort of scratch our heads on the phone and go, I don't know. So we hang up the phone, and then I get a call back in another couple of days, because otherwise the young man was fine. Get a call back in a couple of days. And so I'm not sure if it was just through discussion with their colleagues or if they actually had their son go see an individual, but the final assessment was it was an allergic reaction to the NSAIDs that he was taking, and it manifested as a unilateral swelling on his lip. When you think about allergic reactions to drugs, what class or group of drugs floats to the top of your mind as really likely to cause allergic reactions? Antibiotics, and near the top of that list, what kind of antibiotics? Penicillins, okay. Monoclonal antibodies, according to an FDA incident sort of database, monoclonal antibodies are number 2. And then if you group acetaminophen and NSAIDs together, which we promote like water. That's number 3. I had no idea. Lots of people are allergic to NSAIDs. We don't talk about that very much. You know, we talk about how opioids are evil, and we don't talk very much about there's a lot of baggage with NSAIDs. And part of it is a lot of people are allergic to them. But what this really opened my eyes to was when you get this angioedema, this swelling, it is not always symmetrical. That's what was so, I don't get this, was because it was asymmetrical. So when you're thinking, now I wouldn't say that this young man had anaphylaxis because he had he didn't have any breathing symptoms, no dizziness, no GI stuff, no other skin manifestations other than the swollen lip. So he didn't get epinephrine. There was no reason to give him epinephrine. But it was judged to be an allergic reaction to the NSAID. So in the event that we do have somebody with this full body reaction, and most likely they're having trouble breathing, anaphylaxis is a big deal. People die from anaphylaxis, and they can die quickly. Many of us probably have a preloaded auto-injector in the office. Those preloaded auto-injectors are always 0.3 milligrams for an adult, 0.15 for a child. The really important detail there is, well, when does a child become an adult from an epinephrine standpoint? And the answer there is when they reach 30 kilos or 66 pounds. Okay? Where do you stick the needle? The traditional answer is lateral thigh. Now remember, these devices are designed for dental offices or patients? Patients. It's technically easy to sort of sit down in a chair, kind of brace your legs, and stab yourself in the thigh. And there's some data out there. There's like one article that has been parroted 1 billion times about how the epinephrine pickup is better than the thigh than it is in other muscles. But if you look deeply into that and the way it was done, it doesn't hold water. So the sense I get from experts is any big muscle is fine. Triceps, deltoid, lateral thigh is fine. Caboose would be fine. But, you know, someplace where you have easy access. All right, so the AviQ device, you pull the lid off and it talks to you. It tells you what to do. The EpiPen, you pull a couple of caps off. You sort of have to know it has in writing what to do. Okay, so you see on the very end there, that orange end, that's the business end. Yep, that's where the needle comes out. Don't get your thumb over that. And I've seen it happen. How many of you have epinephrine that's in a container like this or in a break-open glass ampule? And I'm guessing a number of us do. Okay, does that epinephrine work? Sure it does. It's epinephrine. What's the potential problem? There's a full milligram in there. Okay. Now then, what route is indicated for the initial administration of epinephrine in anaphylaxis? Intramuscular. Now, I remember being taught sub-Q in dental school. I think current recommendations would just say intramuscular. What did I not say? Intravenous. Is there ever a time when it's appropriate to give epinephrine IV for anaphylaxis? And if you want to be technically correct, the answer ultimately becomes yes. I think that should happen in a hospital emergency room with an emergency medicine physician that has done this. Because it generally requires diluting the epinephrine in a certain way and administering it slowly. There is one time when we do intentionally inject bolus IV epinephrine, and when is that? When do we inject bolus IV epinephrine IV? Thank you. Cardiac arrest. You're doing chest compressions. So another way to say it is the patient is dead. They're dead and you're trying to bring them back. So in my world, that's the only time that it's appropriate to give IV epinephrine. And many of you are thinking, I'd never do that anyway. I know of 2 cases in Texas from 2 very well-educated individuals that got distracted trying to thinking they were dealing with an anaphylactic reaction in an awake patient. They gave an awake patient who had an existing IV. They put some epinephrine into the IV. Both patients survived. One ended up with some permanent cardiac damage, and the other one got cardioverted, and I'm not sure if that occurred in the ambulance, in the office, or in the ER. But I'd say both dentists dodged a bullet there. So for the folks in the room that do sedation with an IV, so that'd be my level 3 providers and level 4 providers, if your epinephrine is in this form, how are you going to make sure that you never give it IV in a crisis for anaphylaxis? Now, I am a big believer in labeling important things about drugs. So, I mentioned the brand name and the generic name thing for like diphenhydramine or Narcan. Okay, so if you're going to use epinephrine like this, I like the idea of, in very big letters, IM only 0.3 milligrams. Now, another option could be maybe in one part of your kit you have a preloaded epinephrine injector. Those are almost impossible to use IV. They work IM. And then in my own kit, my epinephrine that's like this, it's in the defibrillator case. So I only get it, it's only sticking out at me when I pull out the defibrillator. So that's a mechanism for me knowing, if you think, oh, I'd never do something stupid like that, like give epinephrine IV. How many of you would ever climb into a little airplane that has no doors or no windows, a little bitty airplane, and forget to fasten your seatbelt and take off? Would any of you ever do that? No. Can you imagine anybody to be so stupid? You're looking at him. Because I did it. It's like, how do we do, I've always been interested, it's like, how do smart people make bad decisions? Because there's lots of examples of smart people making bad decisions. I'm not worried about us making a thoughtful decision that's the wrong way. We get distracted, we get stressed, and then bad decisions get made. So I think mechanisms that help defeat that. So in particular, like labeling your epinephrine or deciding where you're going to store it. How many of you are going to pull out your defibrillator as initial management for anaphylaxis? That doesn't make sense to me. So those are ways that I try and make it difficult to give the wrong drug, the right drug by the wrong route. Okay. If you're drawing up adrenaline from a vial, 0.01 per kilo up to 0.5. Do you remember what the dose in the preloaded EpiPen is? 0.3. For some folks, that is not adequate. So, and how often will people need more than one epinephrine dose? About a third of the time. if you're giving somebody epinephrine, whether it's in cardiac arrest or it's in anaphylaxis, they're going to the hospital because you're either all but dead or you're in the middle of an anaphylactic reaction and you may need another dose of epinephrine, and my supply is limited. They've got a bunch. So you're going to the ER no matter what. Even if you have an anaphylactic reaction, you get better, fine. You're going to sit in the ER for several hours and recover there. And they may give you some steroids there. They may give you some diphenhydramine there. That's fine. Let me see, do I have slides? Do I address that with slides? Yep, don't give it IV. We've had that discussion. The steroids, don't feel strongly that we need to be able to give steroids in the office. If somebody has anaphylaxis, we need to give them epinephrine. We need to give them epinephrine. We need to get them to the hospital. The antihistamine, the steroids, let them do that in the ER. This is some data that looks at intramuscular epinephrine and intravenous epinephrine. So this was a study done, it's fairly recent, 2015, 328 intramuscular injections, and this was all patients, all different health histories. 2 patients had a little bit of chest tightness that went away. 2 patients became hypertensive and it went away without any external management. So in this group of 328 patients, were there any significant cardiac events from the epinephrine? No. Compared with some IV epinephrine, you notice how small the group is because it's just not done very often. 30 patients and this was done in the emergency center with skilled people. 4 accidental overdoses resulting in arrhythmia and ischemia. I don't think there were any deaths. So what's my point with this? So what about somebody that has cardiac disease, but they're having an allergic reaction? And I've already made the pitch. Well, epinephrine, all these cardiac effects, heart beats harder and faster. So is it okay to give somebody who has cardiac disease epinephrine in an anaphylactic reaction? Is it okay? And my answer is, don't fear the epinephrine. If they're having an anaphylactic reaction, give them the epinephrine. Call EMS. But the data suggests you are very unlikely to induce any significant cardiac event, even if they have a significant cardiac history. Okay, so epinephrine, EMS, oxygen only if they're hypoxic again. Benadryl, glucocorticoids are not important for early management. And that's from a Cochrane review, which I would consider pretty reliable information. Okay. Chest pain. What time are we getting to? Please, yes. Okay, so the question is, if I have a patient that I think is having an anaphylactic reaction, and then I give them an IM injection of epinephrine, you're asking about when would you give more? My answer would be, assuming that they get better, if I was to give them, so if I pull the trigger on the epinephrine, I'm picking up my phone to call EMS. So EMS is on the way. Assuming EMS has not gotten here yet, if at, at 5 minutes, it's picked up pretty quickly. If they aren't better, I would give more. If they are better, I would wait until they start to get worse again. So it wouldn't be an automatic time thing. My understanding is that 2/3 of patients that get 1 injection of epinephrine for anaphylaxis will not need any more epinephrine. So don't just automatically give them more. So I'd be waiting to see, do they get worse? If they get worse and EMS hasn't given them, gotten there yet, then give them more. So the question is, would albuterol be helpful? So remember, epinephrine has multiple receptor activities. So epinephrine has alpha activity, so it will squeeze blood vessels in the periphery, which will squeeze blood back towards the central part of the body, and in that big dose you get a lot of that squeezing, and that will help raise blood pressure. It also has beta 2 activity, which will dilate the bronchioles in the lung, both of which are good. So remember, many people that have anaphylaxis either wheeze, that's because they develop a bronchospasm, or if they get dizzy, they're pouring fluid out into the interstitium. So the epinephrine will help both of those. If they don't have a lot of dizziness and it's just wheezing, I've heard an expert say, yeah, the albuterol would probably be a pretty reasonable choice. So you sort of asked the question about maybe adding the two together, and I would go, it sounds good. I can't say that I've read any literature on it, but I got the sense from a physician who, I can't remember their credentials or details, that suggested that there'd even be some patients where you could substitute albuterol for epinephrine if all you had was wheezing. Now, I'm not advocating that here today, but could you add the albuterol or consider? It's like, yeah, sure. Could you hurt anything by adding it? I don't think so. I don't think so. And that raises another important detail with the emergency drugs as we roll through them. Can you hurt somebody with Benadryl? Diphenhydramine? Probably not. Can you hurt them with sugar? Probably not. Okay. I'm sorry? Well, yeah, okay. But that would take a while. Could you hurt them with your EpiPen, your preloaded epinephrine pen? Well, I just showed you some data that suggests probably not. What about your nitroglycerin? We haven't gotten there yet, but probably not. That would be a really, so the drugs in your basic emergency kit, you would be really hard pressed to see where you would actually hurt somebody if you gave it in an inappropriate way. What about the ability of non-dentists to give some of these drugs that we've already talked about? So let's start with the EpiPen. Can staff members use an EpiPen? Yeah. Yep. Sugar? Albuterol? Yep. What couldn't a staff member give? What about nitroglycerin? Aspirin? So I had a conversation with a board member some years ago, a former board member who became a faculty member at the dental school, and asked him about this. And he goes, the way we looked at it was, if the drug was something that a patient would give themselves, we feel like anybody in the office, it would be acceptable for anybody in the office to use it. Well, nowadays, Narcan, naloxone is on that list, with the available little intranasal spray. That's not a patient-administered thing, but a loved one-administered thing at home. You can get that, I think, without a prescription now even. But so the short point is that staff members can give all these drugs. There's probably a hold on injecting naloxone and flumazenil. But otherwise, all these other drugs. Okay, did I answer your question? Awesome, okay. Let's press on. So let's talk about hearts. Does anybody recognize this guy? His name is Barney Clark. He was a retired dentist. and he developed heart failure. He was the first patient to receive a mechanical heart transplant. It wasn't a living heart transplant. He received a mechanical heart. And it happened when I was a sophomore in dental school, I think in 82, I believe. And he lived for, I don't know, 6 weeks, 3 months, something like that. I think he died of a pneumonia. Anyway, it was just interesting. He was a dentist. He was in his early 60s too. He was younger than I am. So how does this stuff happen? How does heart disease happen? Now this process takes decades. So I see lots of really young folks in the room. Do you have any atherosclerosis? Any of these little plaque-like deposits? Where inflammatory products and cells and cholesterol and fatty deposits develop under the skin in your arteries. Do any of you have it? Do you eat pizza? Do you eat hamburgers? Do you eat donuts? You got it. And I can say that because when I was a kid, I had a brother and my parents, and my mom would buy 18 Krispy Kreme donuts. So these weren't little donuts, these were the full-size donuts. My mom would have 2. My dad would eat 2. My brother would eat 2. So that's 6. And we had 18. Where did the other 18 go? Into my tummy. I could polish off 18 donuts. How many of you went to high school and there were like little coupons to buy a Whopper, get a Whopper free, or buy a quarter pounder, get one free? And so I'd go on a date with my girlfriend and we'd get 4. And she'd eat 1, and I could easily polish off 3 Big Macs, 3 Whoppers. That was just no problem. So I don't do that anymore. But those are the things: smoking, diabetes. There's lots of lifestyle factors that contribute to the development of atherosclerotic disease. And when it happens in your coronary arteries, then we call it coronary artery disease. Probably everybody in the room has some degree of this present. It takes decades before it becomes, clinically manifests as heart disease. Okay, but pretty much all of us have it. So in the cartoons, we start by infiltration into the lining of the walls of our arteries, and the buildup of these plaque-like deposits. The cover to these is often fragile, not always, but often is fragile. It'll rupture open, expose underlying connective tissue, prompting the formation of a clot inside the blood vessel. So the blood vessel doesn't rupture and leak out. It ruptures on the inside, and a blood clot forms within, abruptly limiting blood flow or stopping blood flow. So when I went to dental school back in the 80s, the concept of coronary artery disease and heart attack was you've got crud just building up in the pipe, and at some point you get so much crud that blood just doesn't flow and you end up with a heart attack. And that is not the current accepted theory. The current accepted theory is, yes, you've got the crud in the lining of the tube, but at some point, some of that crud, the skin covering that crud is fragile. You're still in this inflammatory environment, probably with the pizza and the hamburgers and the donuts and all that, smoking and all that stuff. The skin cracks open, exposes connective tissue, a blood clot forms, and abruptly stops or limits blood flow. Okay, so it's not just the slow buildup of crud, it's the presence of the crud that is associated with the formation of a clot, rupture and a clot, rupture and a clot. Okay, you can see some manifestations of these on panoramic radiographs, so you see these calcifications in carotid arteries. To me, this does not mean they're going to have a heart attack today, but it means they've got some atherosclerotic disease. So, somebody that actually does develop chest discomfort that's associated with limited blood flow to the heart muscle. So ischemic chest pain is described as heavy, aching, squeezing, pressing. An elephant is sitting on my chest. Pressure. As opposed to, it feels like a knife is stabbing me right here. Right here, Mr. Smith? Not over here? No, not over here. It's like a knife poking me right here. Is that cardiac? No. Cardiac ischemic chest pain is dull, heavy, crushing, squeezing, pressure. Where does it hurt? Everywhere. It just hurts everywhere. An elephant is sitting on my chest, kind of thing. So that's ischemic chest pain. And it's associated with, one way or another, inadequate oxygen making its way to the heart muscle tissue. So the heart is working, it's always working, it never goes to sleep. It just sometimes it's working harder, sometimes it's working a little less hard, but it's always working, so it always needs an oxygen supply. And if it's being asked to work harder than the oxygen supply that's available, that's how it tells us there's not enough oxygen here. Dull substernal crushing chest pain. So we think about stable angina and unstable angina. Stable angina, we think of chest pain that occurs when we exercise, or maybe we fight, with somebody. But often it's associated with some degree of exertion. Come on, okay? It's usually associated with coronary arteries, so the arteries that supply blood to the heart muscle, that at least somewhere have at least 75% blockage. That's a lot of blockage before you start to see symptoms. It's a lot of blockage. Unstable angina is chest pain at rest, and the paradoxical thing is that it's associated with lesions that are not so big. So you're going, wait a minute. So does the patient with unstable angina progress to stable? It's like, I can't fully explain this, but the lesions in patients that develop unstable angina are generally not as occlusive or obstructive as the ones that we see in stable angina. So I can't fully resolve why that sort of doesn't seem right there. Okay, but stay with me. But remember, the lesions rupture and a clot forms. Rupture and a clot, rupture and a clot, rupture and a clot. That's how heart attacks occur. That's how strokes occur. Stable angina is different, and I'll explain that better here in just a moment. Okay, so there's several things, stable versus unstable, but I want you to focus on, I think a box appears. In stable angina, chest pain associated with exercise. What makes it go away? Well, just think simple. Stop exercising. And maybe give them some nitroglycerin. Okay. So in stable angina, is blood flowing through the coronary arteries? Is blood flowing before the exercise starts? They're not having any pain. The heart is working. So are the coronary arteries getting at least some blood? Yeah. So now you ask the patient to climb up steps or to run or do whatever. And at some point they start to have chest pain. Is there still blood flowing through the coronary arteries? And I'm going to tell you, yes. Why are they having chest pain? Well, there's a limitation in the blood vessel that limits the blood flow, and now you can't get enough oxygen to the muscle. So what do we tell the patient to do? Say it again. Rest. Yeah. Stop exercising and rest. So now the demand goes down. Not as much oxygen is needed because the heart isn't being asked to do as much work. Does the chest pain go away? Yeah. Assuming that it does. That would be the norm in stable angina, is that you're not exercising, you're fine. You increase demand, go climb 15 flights of stairs. You have some chest pain. Oh, I got to stop. My chest pain goes away. What changed about the coronary artery blood flow in that situation? You're correct, because you guys said very quietly, nothing. No, it's true. When I finally thought of it this way, suddenly stable and unstable angina clicked for me. In stable angina, blood flow in the coronary arteries is maintained. It's just limited. It's always limited. But you don't know it until the patient asks the heart to do a lot of work. Okay, now let's contrast that to unstable angina. Acute coronary syndrome, which then will often progress to full-blown myocardial infarction, heart attack, where you get dead heart muscle cells. Remember, that's angina at rest. So, Grandpa Ernie is sitting in the chair watching TV, channel surfing. You know, when I was a kid, to channel surf, you actually had to get up and walk over to the TV. You know, now we've got these remotes. Okay, so Ernie is channel surfing. Oh my gosh, my chest is hurting. Was I doing any exercise? And the presumption is, did I create any additional demand on my heart sitting there watching the TV or reading a book? No. But I started to have chest pain. Well, we already know that the dull substernal crushing chest pain is associated with inadequate oxygen supplied to the heart muscle, right? So if I didn't change the demand, but I got chest pain, what had to have changed? The supply. The blood flow dropped below some threshold that resulted in chest pain. So how do we get blood flow to drop abruptly in our coronary arteries? Rupture, clot. Rupture, clot, rupture, clot, rupture, clot. So it's the atherosclerotic, the cholesterol-laden deposits, you know, the pizza, the Big Macs, the donuts that I ate, I know I have these, that remain in an unstable environment, and for some folks, the skin cracks open on the inside of the vessel, initiates the coagulation cascade, a blood clot forms, limiting blood flow. That's how a heart attack happens. That's how unstable angina happens. So do you see the difference between stable angina and unstable angina? In stable angina, is coronary artery blood flow stable? Yes. The patient got, Doc, I'm really nervous about the shot. I'm really nervous about the shot. I'm really nervous about the shot. We're just going to do the shot. You'll be okay, Mr. Ernie. Okay. And they're nervous, and their blood pressure goes up, and their heart rate goes up, and oh, my chest is hurting. Okay, so leave them alone. Let them be. If they settle back down, the chest pain goes away, especially if there's a history of stable angina. I'd go on and do my dental work. If they have chest pain, if they have chest pain for the first time in your chair, we don't know what it is. They're going to the hospital. If they have chest pain, just grandpa is, I'm bringing my kid to the dentist and I'm sitting out in the waiting area. Your staff member comes back and talks to you and says, Mr. Luce doesn't look good out there. Would you go out and talk to him? I don't think he's feeling good. And he admits to, yeah, I think my chest is hurting. Has this ever happened before? Well, only when I was exercising, and now I'm just sitting here. You know, my doc told me I probably need to go to the ER if that happens. Or, yeah, I've already taken some nitroglycerin and it hasn't helped. Yeah, they're going to the ER. So, but I want you to get the difference between stable and unstable angina. In stable, coronary blood flow is reasonably constant. In unstable angina, coronary artery blood flow dramatically drops and probably stays that way until somebody puts in a stent or somebody gives you a clot busting drug, you know, none of which we do in the dental office. Okay, all right, so somebody has chest pain. Let's keep going. Come on. Okay, so stable angina is relieved by rest and maybe some nitroglycerin. I'll spend some more time talking about nitroglycerin in here shortly. What time is it? Okay. If they get better, if they pull out their own nitroglycerin, or they say, oh, darn, I forgot my nitroglycerin. Can I use yours, Doc? And you use yours. But they've got a history of it. This is an important detail. They have a history of using nitroglycerin and it working. And they use it, whether it's yours or theirs. And they use it and they get better. And this seems consistent with your normal pattern of chest pain. Yeah, Doc, I'm just really nervous about this stuff. And, you know, if I fight with my wife or I come to the dentist or if I exercise too much, I get a little chest tightness. Is that all it was? Yeah, this is just like it normally was. Okay, proceed at your discretion. If somebody has some chest pain, it doesn't get better with rest, it doesn't get better with nitroglycerin, and so I would say up to 3 doses 5 minutes apart. So if you've got a patient that maybe has a history of nitroglycerin use, and yeah, okay, well, just relax. We'll not do anything here for a minute. Take a nitroglycerin, you know, and they take one. How you feeling? Yeah, it's still tight. You take another one 5 minutes later, maybe another one 5 minutes later. Are you looking for the chest pain to improve, or are you looking for the chest pain to go away? You want it to go away. Getting better is not good enough. So if they take some nitroglycerin and go, yeah, it's better, is it all better or just some better? Well, it's just some better. That's not good enough. If they go, it's all better, and this fits their normal pattern, they've used nitroglycerin before, fine, do your dentistry. That looks like stable angina. Anything else, I would consider unstable angina until proven otherwise. But that would probably happen in an emergency center. Okay, so chest pain not relieved by rest or nitroglycerin is an EMS call. So the way I think of it now, if I pull out my nitroglycerin, you're going to the ER. Unless you pull out your own or you tell me you forgot your own, you take it, and you get all better. That's the only situation that involves that involves nitroglycerin where I would not be sending you to the ER. So you sort of see how I kind of changed the way I talk about it. Nitroglycerin, EMS. Unless you've got the history, you use it like you usually use it, and you get all better. Okay, fine, we'll go on. Otherwise, everybody else goes to the ER. Any thoughts or questions? What about oxygen? What do you think I'm going to say about oxygen? how many of us in whatever school we did having to do with dental were taught chest pain, oxygen? Oh, come on. Every hand should go up. I know what you were taught because I taught it for a long time. I will show you what it looks like. I may not get to this detail before lunch, but there's lots of data that suggests we way overuse oxygen, but I'm going to show you how it's problematic. Here is a place, a specific place where oxygen actually can make the patient worse. So just sort of hold that thought. How are you going to figure out if they need oxygen? The answer is always the same. Pulse oximeter. The different organizations, Heart Association, Lung Association, Stroke Association, they vary a little bit in the numbers. Low, if a patient is in the middle 90s or above, they're fine. If you get down in the 92, 93, 94 range, give them enough oxygen to at least get them up to there. But the idea of oxygen good, more oxygen better, is not supported by literature. It actually makes them worse in certain situations. I'll get to that. So you just sort of have to hold on. And if you're calling EMS because of chest pain, go ahead and add some aspirin too. So your baby aspirin, if you have baby aspirin in the office, that would be at least 2 baby aspirin. Okay, so calling EMS. Got it. All right, so this is a really busy flow chart. We're not going to go through this, but when I want you to look at the bottom, it says American Heart Association, and at the top it says acute coronary syndrome, unstable angina, chest pain. So this is like for a patient that shows up in the ER. Okay? And now I want you to look. We're going to zoom in. Immediate emergency department general treatment. If the O2 sat is less than 94, so that means 93 or less, start oxygen. Well, so what if it is 94 or above? What does that imply about oxygen? No oxygen, right? Am I reading that right? Okay. That's the American Heart Association. So if you want to throw tomatoes, throw them at the screen. Don't throw them at me, because I'm not creating this stuff. Is this aspirin appropriate to have in your office for your emergency kit? And my answer is no. And the problem is it's enteric coated. This is for the individual that is taking aspirin every day. They've probably had like a stent placed, and the aspirin and maybe their Plavix are helping to keep the stented vessels from becoming restenosed. So it slows down the absorption in an effort to reduce gastric ulceration. Well, in acute coronary syndrome, you don't want slow absorption. You want rapid absorption. So like plain Jane baby aspirin or just plain Jane aspirin, a 325 is fine. But you don't want this enteric coated stuff in your emergency kit. What time is it? 45. Okay, so let's talk a little bit about nitroglycerin. So it comes in different forms. It comes in a spray. That spray bottle is a few $100s. The pill bottle is about $20 or $30. All right, it's the same stuff. It is primarily a venodilator. So its major action is to dilate veins. What will that allow blood to do? So if you give a patient a drug that dilates veins, veins are the tubes that lead back to the heart. And now you're going to make those tubes a little bigger. It'll allow blood to pool on the venous side of the fence a little bit. So will that reduce blood return to the heart a little bit? Yeah. So for a short period of time, you'll create a little bit of a fluid shift. and allow blood to pool in the veins. That reduces blood flow back to the heart. Less blood to the heart takes less oxygen to pump that blood out of the heart. So you're reducing what's called preload. So remember, so the question is, wait a minute, you're increasing, yes, you're dilating the veins, but what that will do is it allows more blood to pool a little bit away from the heart. If you squeezed the veins, you'd be pushing blood back to the heart faster. So earlier today we talked about drugs like epinephrine dilating big arteries, which would allow blood to get into a muscle easier. Allowing veins to dilate, big veins to dilate, especially in the lower extremities, just allows a few hundred extra milliliters of blood to pool down there for a little bit. So it's a closed system. Ultimately, the blood is all pumping. So over time, not much changes, but for a short period of time, you relatively speaking move a little blood away from the heart. Just because you simply created a bigger space for it to accumulate here before it actually does get pushed back to the heart. Okay? So I don't think it's a big difference. I can't give you numbers. Nitroglycerin will dilate coronary arteries a little bit, but its primary effect is as a venous dilator. So it reduces preload. You do expect blood pressure to fall a little bit. Has a fast onset, short durations for ischemic chest pain. 3 doses at 5-minute intervals, we talked about that. It may worsen what's called right ventricular infarction. So if somebody's having a heart attack, think back. So those of you that went to dental school, I'm not sure if hygienists may have done enough anatomy where you actually held a heart in your hand. Most of what you're looking at, if you're holding a heart in your hand, most of what you're looking at is what chamber? Left ventricle. So almost all the muscle in the heart is left ventricular muscle. The right ventricle is just sort of tacked onto the side of the left ventricle. And then the two atria are like little ears, little ear attachments up on the top. So very little tissue there. Most infarctions involve left ventricle because that's where most of the muscle is. That's what most of the muscle is. For the individual that is having infarcted, ischemic, dying tissue on the right side of the heart, using nitroglycerin where you reduce preload, you may actually worsen them a little bit. So I've seen some EMS folks caution and say, maybe you guys as dentists shouldn't be giving anybody nitroglycerin because you aren't going to know if it's a right or left heart attack. It's like, okay, there is some literature that actually looks at this and looks at nitroglycerin used out in the field where there is no information, is it a right-sided infarction or left-sided infarction? And what the data suggests is that even though this theoretical concern exists, it really doesn't manifest meaningfully in, I think it was roughly 1,000 patients. There are concerns about using nitroglycerin, but whether or not it's a right-sided infarction doesn't seem to be well supported by literature. So to me, it means I'm still willing to use nitroglycerin in the office. And those of you that have gone through a sedation inspection were mandated to have nitroglycerin. I don't know if you remember that, but epi and nitroglycerin you had to have to get past your level 2, 3, or 4 inspection. Okay? And there's also some concern about using nitroglycerin in folks that are taking Viagra, Cialis, or Levitra. And the concern there is that they're both vasodilators. There's actually literature that looks at this as well. Did I get this? Now I'm trying to remember, did I get this in the slide series? there's data that calls that into question as well. Let's see what I've got here. So you notice there's a question mark. It's sort of gotten hidden in the cap of the nitroglycerin. Do we really need to avoid nitroglycerin in patients that are taking ED drugs? That's the traditional teaching. And there apparently have been some reports of individuals developing low blood pressure that becomes unmanageable. And I think there have actually supposedly been some deaths. So the traditional teaching is to avoid nitroglycerin if the patient has recently used Viagra, Cialis, or Levitra. This was in a 2022 articles in the Annals of Internal Medicine, so it's a big journal. This was a Danish study. There was no statistically significant association found between prescription of nitroglycerin nitrates and phosphodiesterase 5 inhibitors, Cialis, Viagra, or Levitra, and risk for cardiac arrest, shock, myocardial infarction. Shock would be low blood pressure. So this study called that risk into question. But the traditional teaching is don't give it to somebody that's used Viagra, Cialis, or Levitra in the past, roughly the past 24 hours. How many of you were taught that the nitroglycerin tablets go bad once you open the bottle? I was. I remember being taught that. So that's old data. The traditional teaching, the tablets would break down. They would replace, once you open the lid, 3 to 6 months duration, no matter what the expiration date was. What happens is supposedly that the drug actually volatilizes, actually evaporates out of the tablets, which was surprising when I was reading about this. And it's reduced by maintaining a very tight seal. So the tablet, are you sure you want to shut? No. Let's not do that now. You guys would love it if I said yes, wouldn't you? I know that you would. I did have some curious computer issues this morning. Let's see. You notice that the nitroglycerin tablets always, if you buy the tablets, it's always in a brown bottle with a metal screw cap. It doesn't come in any other kind of container. It has to do with keeping out light and maintaining a seal, as close as possible, an airtight seal. So the short answer is that current formulations will retain their potency after opening all the way up until their expiration if the cap is tightened and the bottle is not kept in a warm pocket. So for women that carry nitroglycerin, the norm is, according to this study, is it sits in a purse. If a man is carrying it, it's generally in a pants pocket where it's distinctly warmer. So where is your nitroglycerin in your emergency? In your office. It's probably not in your pants pocket. It's probably in an emergency kit. So even if you've opened it, based on this study, I would say as long as you're within the expiration date, the tablets are good. What time is it? Is it 12? Okay, it's time to break. We're going to take, let's see, hold on. Here comes Dr. Cruz.
Thank you. Yeah, just make sure that everyone has their name registered for their CA credits at the end of the course, please. Thank you.
Okay, so we're going to go till 1. Is that right? It's 12 o'clock now? Okay, so I think lunch is on your own. For those of you that are willing to come back and suffer some more, I will be up here blabbing at 1. End. I knew that it would, but that's okay. Thank you guys for coming back. So we were talking about hearts, and I had a discussion right as we were going to lunch with one of the participants here that very kindly reminded me of some differences between men and women in the way that ischemic cardiac pain manifests. And it's particularly pertinent because most of the people in the room don't have a Y chromosome. So, the most common presenting symptom, so this is based on my understanding, in men by far, the major presentation for ischemic chest pain, heart tissue that is not getting enough oxygen, dull substernal crushing chest pain. And that's what I had on my slides. And what I failed to point out was that women are far more likely to have some of these odd presentations of chest pain. So I'm sure you've heard of jaw pain, which could actually be left or right, shoulder or arm pain, which could actually be left or right, but then even other unusual things like low back pain, or just a generalized sense of fatigue, or I think a term that maybe you used, do I remember correctly, hollowness, that you'd spoken to. So, gee, honey, I'm feeling kind of hollow today. I think I'm going to go down to the ER and get checked out for a heart attack. We sort of chuckle at that, but it's important to remember that I failed to point out that women are far more likely than men to have some of these unusual presentations of ischemic chest pain, of ischemic myocardial ischemia. That's the way I want to say that. So try and keep that in mind. But I really appreciate being reminded of that. And the way a really close friend of mine put it once is, none of us is as smart as all of us. So I love it when people have thoughts to add and don't feel like you have to do it in private. Feel free to just stick your hand up and go, well, my understanding is, and all of us learn when we do that. So thank you very much. So let's talk a little bit more about, so what do physicians do for coronary artery disease? Now it's pretty common to hear about patients getting stents. So stents were actually developed by a physician at the medical school in San Antonio back in the middle 80s. So I was a general practice resident when this happened. I don't remember us talking about it at all. I would assume this was huge news, but I don't know. We didn't talk about it, at least not that I remember. Maybe I was sleep deprived and just don't remember. But the way stents work, so we've had the discussion about the Big Macs and the pizzas and the donuts and these cholesterol fatty laden deposits developing in our arteries. And if they grow big enough and are fragile enough, then they rupture and a clot forms. Rupture and a clot, we've said that several times. So the idea with a stent is to take this little metal tube, if you will, slip it into the right spot in the coronary artery, click it into an open position, sort of like the cartoon there, and it holds the affected artery open. Now I want you to look close at those drawings, because those are drawings there, and kind of the image that it projects. So you've got this artery, and then you've got this discrete lesion there, and you slide the collapsed stent into place. A balloon fills up, it expands the stent, it clicks and locks into the open position. Holding now this artery is open, and then you withdraw the catheter, and life is good. And this is often done under what we would call moderate sedation, fentanyl and midazolam, in the cardiac cath lab, and the patient is awake and talking when a physician is doing that. That's just amazing to me that we can do that. Okay, so stents. Stents are pretty common. And for folks that are having unstable angina, acute coronary syndrome, evolving myocardial infarction, stents are absolutely life-saving. Here's an image that might have been taken before a procedure like this was done. So, dye, radio-opaque dye is injected into an artery, and then a radiograph or a fluoroscope, a moving, alive video of blood flow an image will be taken. And so here you see where the arrow is, what looks like a narrowed space. Then if you look way over on the right-hand side of the screen, there's maybe another place that looks kind of narrowed. And so physicians will use something like this in the EKG to help locate where the ischemic tissue is. And then they may be putting the stent in. Okay? So this physician, Dr. Carpenter, is a famous cardiac pathologist. And so what these funny looking sections are, if you were to take a heart and you were to dissect the large portions of the coronary artery, so the coronary arteries go around the coronal part of the heart, like the crown of the heart. So off the top, they come off the right and left side of the aorta, the big vessel that takes blood out of the heart. And then these vessels on the outside of the heart muscle then work their way down. So what he did was he took coronary artery, and there's about 11 centimeters of coronary artery in most of us. And what he did was he dissected away in a lot of specimens, so this is an example from one patient, specimens where he took that tube, that artery that he had dissected away from the dead heart, and he cut it into 5-millimeter sections. So that's, where are my periodontists? You know exactly how far 5 millimeters is. Okay, less than 1/4 of an inch. Turned them on their side, stained them, and then took photographs of them. So each one of those images is a 5-millimeter progression from start to end of the coronary artery. So now I'm asking you to look at that and go, where do you put the stent? Well, okay, but are there a lot of other places that are problematic? Okay, that's my point. The cartoon that I showed a slide or two ago showed a nice open red walled artery with a discrete yellow fatty plaque-laden image, and you put the stent right there and you open it up and you go, awesome, life is good. And now you look at this and go, where do you put the stent? So when somebody tells you that they got stents, did it fix them? Did it fix their problems? All their problems? No. So stents were originally designed for managing stable angina. Do they make us better? And these two studies suggest that stents for stable angina do not reduce death and do not improve exercise tolerance. Now for patients that have unstable angina, acute coronary syndrome, evolving heart attack, where you've got a rupture and a clot, rupture and a clot, rupture and a clot, stents are life-saving. But for stable angina, there seems to be a real question about, are we really doing any good? But the point I want to make is that why does it do that? That when a patient tells us they've got stents, I think a lot of us think, oh, you're fixed. But you saw the pathologic specimens that I think prove that, no, they're not fixed. I mean, you maybe fixed the worst part, but do they still have lesions there? Oh, yeah. Okay, that was my point there. They're still full of atherosclerotic lesions. They're all over the place. Okay, so now let's talk about when hearts quit working. So cardiac arrest means the heart stops pumping. It's usually going to be associated with a life-threatening rhythm change. The way the heart muscle is moving or contracting or not contracting is now such that no blood is pumping. So no pulse. Okay? what will this person look like? Think simple. No pulse? Say it out loud. Dead. They'll look dead. They're dead. In about half of patients, the presenting sign that, oh, you've got cardiac disease is when you drop dead. Which is actually, it's like, do I get to pick how I go? It's actually a nice way to go. So, for folks that are recoverable, for many people, when they go into cardiac arrest, there's been a lifetime of accumulating disease, and the heart is worn out, and no injection of epinephrine or no zap from a defibrillator is going to fix those problems. Some people are recoverable, some people are not. But for many, and most people that arrest, die and are not recoverable. But the time to defibrillation, so most folks that develop a rhythm where the heart stops pumping blood is either called ventricular fibrillation, where you get some quivering of the cardiac muscle, but no effective pumping. Sometimes ventricular tachycardia is there, which is a slightly different kind of rhythm disturbance, but often still doesn't pump blood. And if it doesn't pump blood, the brain dies within a few minutes. So the quicker you get to a defibrillator, the better. It's, when we're measuring this only in a few minutes. So if somebody loses a pulse, they desperately need basic life support. So what organ goes first when the heart stops pumping blood? What organ starts dying first? The brain. Right. So we got, 4 to 6 minutes after blood flow stops, we've got brain cells that are dying. So we've got this short-term clock ticking. So patients that go into cardiac arrest desperately need flowing blood. How do we do that? Start CPR. Good chest compressions. The core of any resuscitation, whether you're ACLS certified or basic life support certified, are good chest compressions. So good chest compressions are hard and fast, and you're compressing the chest 2 to 2.4 inches. Do I remember that number correctly? Okay. And so I practice with my residents at the dental school with a really cool, fancy mannequin that's a full-size mannequin. And I want to thank you guys for paying for it because your tax dollars paid for it. We use it every day that I'm there. And there are people in the room that have used it, and I think would attest that, yes, it's a good thing we practice CPR virtually every day. So thank you for that purpose. But what I see is I rarely see people doing chest compressions that are too deep. It's really unusual. And I'm usually having to encourage people deeper, deeper, faster, faster is what I'm usually seeing. Okay, so rapid defibrillation. So we want to get to a defibrillator quickly. And good rapid chest compressions. I think the rate would be 100 to 120, but it's kind of 1 and 2 and 3 and 4 and 5 and 6 and da-da-da-da-da-da. The staying alive thing, that just doesn't quite resonate with me. I know that's thrown out a lot, but I'd have to stop and go. It'd take me a while to sing the song to myself. So that just hasn't clicked in my own personal life. But fairly fast, hard and fast, fairly deep. How many of you have you done CPR for real? Okay, I've done it once for real, and that was on one of the trails at Grand Canyon, and actually walked up on an ongoing cardiac arrest. Ultimately, the guy didn't survive. I was there with my son, who was in high school at the time. And I remember as we walked off, because I sort of walked up, hi, I help teach CPR and ACLS, can I help? And they go, yeah, sure. And so I ventilated and did chest compressions, and we put in epinephrine into a bone and worked on him a while. Anyway, the EMS folks from the Park Service stopped the resuscitation, and we quit. That was the part I was not prepared for, because when you think about all your CPR training, it's stop compressions. Okay, let's check for a pulse. Okay, maybe we're shocking, we're resuming chest compressions. When we go on, maybe we switch. You can do effective chest compressions for maybe a minute or two, and then the effectiveness of your compressions goes way down. So we need to be switching frequently when we're doing chest compressions. In this particular situation, I was doing chest compressions while the leader is talking to the adult daughter behind me, and you can tell where they're going with the discussion. We're going to stop. Your father got everything he would have gotten in an emergency center. These EMS guys flew a helicopter over the edge of the Grand Canyon, landed a couple of 100 feet up, and came barreling down the trail, I swear, with a complete ICU rolled up in this big kit. And he did. This guy got, I think, everything he would have gotten in a real-life resuscitation. Anyway, the part I wasn't prepared for, and it's like I still choke up when I tell this story, is because I was doing chest compressions, and the leader says, we're going to stop. And the adult daughter, who is tearful, but she accepts that, okay, her dad is not going to walk back up the hill. He goes, okay, stop CPR. And then it was silent, just like that. And the Park Service guys start picking up the trash, because there's trash everywhere, because we peeled open all this stuff. And I look around, and I say to the Park Service guys that was helping me, and I go, is there anything else I can do? And he goes, no, thanks a lot. They didn't even know my name. And I got up, and I picked up my backpack, and my son picked up his backpack, and because he was watching, we walked off. And my son goes, oh, that's really so sad. And I was feeling bad because, oh my gosh, this guy arrested. So think about it. He arrested right in front of a mule train at Grand Canyon. Have any of you been to Grand Canyon? Seen the mules? The people leading the mule train carry radios and defibrillators. This guy arrested right in front of one, and his adult daughter knew how to do CPR, and from what I saw, it looked pretty good. So they had a helicopter coming, and then some yahoo walks up that teaches ACLS. That was me. So there were all these reasonably skilled providers right there, and I was feeling, it's like, darn, it's like, look at all these resources he had, and he still didn't survive. And my son goes, that's just so sad that he didn't survive, and I was feeling kind of bad about it. And then I said, he was with people he loved, he was with his daughter, in a place that was beautiful, doing what you assume he wanted to be doing, hiking, and he dropped dead. And I said to my son, well, I hope that's the way I get to go. So anyway, that's mushy aside there, but I was not prepared for, okay, stop CPR, and then start cleaning the trash up. Most people that arrest don't survive. Some do. If they are going to survive, they're going to get good CPR very rapidly, and they're going to get a defibrillator very rapidly. So this graph, what I want to point out is, this is looking at different patient intervention, healthcare intervention for patients that arrest in different places. So the two tall bars, the one on the left says in hospital witnessed arrest. So that's somebody that's in the hospital, they are seen to arrest, and then the hospital marshals their resources and resuscitates the patient. So that bar is pretty tall, but look at the taller one on the right-hand side. That's CPR and rapid AED in the field. That's us. And so if people get good CPR and rapid application of an AED. What I'm trying to point out is we are absolutely effective at resuscitating people that are resuscitatable. And even though a lot of us in the room need to have ACLS, it's like, okay. But the epinephrine and the amiodarone and the lidocaine and the procainamide and magnesium, that is not what saves people in ACLS. It's good CPR and rapid defibrillation and rapid EMS calls. Okay. Does it matter where you arrest? Well, yeah. If you want to pick a place to arrest, Seattle is the place. And the place not to arrest, which is not on the map there, on the graph, is Detroit. Okay, so how important is epinephrine? So if you think about advanced cardiac life support, and so level 2, 3, and 4 providers need to have ACLS. So the first drug of choice in cardiac arrest, whether you're shocking them or not shocking them, is epinephrine. How important is the epinephrine? Well, that's coming into question. In this particular study, the use of epinephrine within 2 minutes after the first defibrillation was associated with a decreased odds of survival. My personal opinion is if somebody arrests in my office, my focus will be EMS, CPR, which will include chest compressions and ventilation, and defibrillation. I'm going to let EMS. My guess is I would not have my act together well enough to actually be able to get epinephrine in them. I have it. We had the discussion about giving it earlier. But my opinion is focus on the defibrillation and focus on the CPR. Okay, so I'm sort of beating a dead horse. Call 911, check a pulse, spend no more than 10 seconds. Hard and fast, chest compressions, rapid defibrillation. Come on. Turn your AED on. It tells you what to do. Okay, definitive care. I sort of skipped over the 30 compressions and 2 ventilations there. We'll talk a little bit more about ventilations here in a moment. Can you do CPR in a dental chair? What do you think? Can you do effective CPR in a dental chair? I love it. Okay, so this was a study that appeared in 2021 in an anesthesia journal. It was actually done in Japan, and it was looking at 2 different dental chair designs and the ability of dental students to do chest compressions in the chair. Okay, and so this picture is pointing out differences in the supporting mechanism of the part of the chair that leans back. All right. What this graph is telling us is the dental students, the percent of dental students who managed to achieve a 5 centimeter compression. So that's a little over 2 inches, just slightly over 2.5, just slightly under 2 inches, right at 2 inches. With chair design A was pathetic. Chair design B, oh, there's a number there, 1%. And chair design B was 8%. So that fits with what you were saying a moment ago. Can you do effective compressions in a dental chair? And your universal answer here was no. And then I smirked. But now look at, well, what if they put the mannequin on the floor? How many of the dental students managed a 5 centimeter compression? A third. So to begin with, it's clear that their technique was consistent with what I see when people are practicing on our mannequin at the school, is that I'm usually having to encourage deeper and sort of more assertive chest compressions. Okay? So, this is an example of sort of how we do it. Now with the mannequin that you guys paid for, thank you very much, there is an indicator on the computer screen. I sit in a sort of a secret room where people can't really see me, and That's where I twist knobs and dials, and I can make the patient live or die or breathe or not breathe or have a pulse or, whatever. But I can see how deep the chest compressions are. And so in that particular chair, so it's an A-deck chair with a fairly thin pad on the back and no backboard and actually no chair underneath the headrest, we can absolutely get 2.5-inch chest compressions on our mannequin. I haven't convinced people to lie down on the chair and actually try and measure for real. But at least on our mannequin, we can absolutely do it, and the machine tells us that we get there. So, if you're not going to do it in the dental chair, what are you going to do? Are you going to get the patient on the floor? Okay, so how many of you are in an office where the staff members are petite and the person that arrested is 300 pounds? And so how effectively are you going to be able to get the patient on the floor, not drop them on the floor? And then my next thought is, how much space is there between your dental chair and the cabinetry? Do you have enough room to literally get down on your knees beside them and do your chest compressions? Do you have enough space to do that? Because I'll bet there isn't enough space, and if there isn't, then you've got to get them out into the hallway. How quickly can you do that? And remember, the clock is ticking, and every minute that goes by, you lose about 10% survival of those that are going to survive. So there's no messing around time. It's going to take you 5 minutes to get the patient off the chair, down to the ground, and then out into the hallway. I see that as a losing proposition. So my opinion is do the best you can as quickly as you can, which probably means keep them in the chair, let EMS get there, let EMS move them. That's my opinion. So there's literature that sort of looks at this, and you see both sides of the fence. If patients are in a hospital bed on a 6-inch mattress, it's virtually impossible to do effective chest compressions. I'm sure there are dental chairs with fluffier padding where it's harder. This particular example that we have where we keep our mannequin, that padding is really thin. That probably adds to our ability to be able to do effective chest compressions. My assumption is that the mannequin is pretty realistic, but I can't absolutely tie those together, so that's the best that I can give you. But I really worry about if you don't have big, strong people in the office that can effectively move the patient quickly, and, moving somebody that is dead weight, it's hard. It's really hard. So I would be cautious about making that choice. So I think I would rather try and do the compressions in the chair and let EMS move the patient. That's my thought. Okay, what about advanced airways? So all of us, or at least those of us in the room that are doing level 2 sedation, level 3 sedation, or level 4 sedation. So oral sedation with more than one drug, or IV sedation, or deep GA. Those are all the same. We are all mandated to have advanced airway equipment. So that means sliding something into the mouth that goes past the tongue. So it would be a device that's not this long, but a device that's probably at least this long. Maybe an endotracheal tube, maybe an iGel, maybe an LMA. There are a number of brands that would count there. Those are advanced airways. There is a difference in how we do chest compressions if you put in an advanced airway. So according to ACLS, once you put in an advanced airway, you stop interrupting chest compressions. Remember, when somebody arrests and their heart stops pumping blood, their brain cells are going to die quickly because there is no blood flowing to the brain. So they desperately need blood flow to the brain. I think, do we have an evolving, are we okay? Okay. We have a room full of resources here. May I use you as sort of as an example? You don't have to do anything, because I didn't talk about this when I was rolling through the bronchospasm thing. I think I completely failed to comment on what's the patient going to be doing. When we think about asthma or bronchospasm, we're commonly thinking about wheezing, difficulty breathing, but what I think often we don't attach to a bronchospasm is coughing. Somebody that's asthmatic that's coughing should have our attention. And the fact that you pulled out an inhaler there makes me go, I didn't talk about that stuff and I feel badly now. But really and truly, are you okay? Okay. Now, if the albuterol doesn't work, then what do we do? Now you're being tested. If you fail the test, we go back and do the material again. Oh no! So remember, we want something that's has beta 2 agonistic activity. Albuterol is a beta 2 agonist. It will relax bronchial smooth muscle. But we've talked about another drug today. Epinephrine has beta 2 agonistic activity. So we could inject epinephrine just like you would for anaphylaxis. And then I also brought up could you use Primatene Mist? And I sort of dogged using Primatene Mist as something for your emergency cart. Yes, sir. Oh, yes. Albuterol should be our first choice. If the albuterol, fails to resolve things within, I'd also be talking to the patient. So the assumption would be the patient would still be awake at this point, in some degree of distress. Are you feeling better? How much better? If you reach a point where they're still coughing, they're still wheezing, I'd have a pulse oximeter on them. So I'd be looking at, should we consider giving you oxygen? If you're desaturated, you need oxygen. If you're fully saturated, the American Academy of Allergy and Immunology, did I get that correct? Don't recommend oxygen unless, you're actually becoming hypoxic. So be ready for oxygen. But then in the event, if the albuterol doesn't work, epinephrine would be your next choice. And it would be the same dose that you would use for anaphylaxis. Okay, all right, so back to our advanced airway. So when we're doing basic life support, so I pitched the good CPR, 30 compressions to two breaths, okay? If you put in an advanced airway, your LMA, your King, your iGel, your endotracheal tube, then the idea is you stop interrupting chest compressions. So when somebody goes into cardiac arrest, blood flow to the brain stops. When we start doing compressions, how quickly does the blood get going? It takes a while. Are our chest compressions really good at moving blood? No. So good chest compressions result in marginal blood flow. Bad chest compressions, of course, are even worse. When we stop doing chest compressions, how quickly does the blood stop flowing? It stops. So every time we stop chest compressions, the blood flow stops. And then when we start back up again, it takes a little while to get going again. And the patient desperately needs blood flow to the brain, right? So interrupting chest compressions, is that a big deal? Yeah, So interrupting chest compressions is a big deal. So one pitch for the advanced airway is if you put in this advanced airway, then you don't have to interrupt chest compressions anymore. And you just simply ventilate every 6 to 8 seconds. And so you'd be doing that with your bag valve mask connected to the tube that would be the size, roughly the size of your thumb sticking out of the patient's mouth. Whatever design it is, there'll be a fitting sticking out of the patient's mouth that your bag valve mask would fit on. Okay? So, come on. So the idea is that stopping chest compressions is the devil. That's the idea. And these are some different designs. I don't know what I'm doing here. So these are different designs of airways. So my guess is many of you probably recognize a device that looks like that. In order to use them, they need some sort of lube kind of smeared on them. Whatever design you have, I'm not going to show videos for all of these, but whatever design you have, they're quick videos all over the internet. They're easy to get, but I would say you and your staff should look at them once in a while. They're all easy to use. These devices are easy to use. And you basically stuff them down until they don't go any farther. That's not exactly true with the one in the middle. That one, you sort of push down all the way. You blow up the balloons on it, and then you pull it back and you kind of find a sweet spot where it works. Nonetheless, whatever device you have, spend a little time looking at that video. I personally like the device on the bottom, which is an eye gel. There is no inflatable cuff, so there's no need for a syringe. You do still need the little packet of water-soluble lube, but you don't need the syringe. The two on the top, you can see that second little tube where you need a syringe to be able to inflate the cuff. If you don't have the syringe, the device becomes useless. Or if the cuff tears, it becomes useless. So I'm a glutton for a lot of things, so I decided I want to try one. Because I thought, wouldn't it be cool to go to a course and actually get to put one down somebody? And you go, that's it? And I'd go, yeah, that's it. It's like, that's easy. So I tried to numb the back of my throat as well as I could. And that was one of my assistants at the time. Okay, so that was a King device. And you can see it's essentially all the way down. And I could, the cuff had not been inflated, but I could tell, I could feel air moving in the tube. I could tell that air was moving in the tube, but within about the next 2 seconds, that tube was out. So I have not achieved the goal of being able to tolerate this well enough for a string of 50 of you to slide a tube down and go, that's it? It's like, yeah, that's it. They are really simple devices, and they are basically mistake-proof. You almost can't put them down the wrong way. If you manage to put one in backwards, which would be against the normal curvature, okay, you could make a mistake that way. But otherwise, it's very difficult to put down one of these devices incorrectly. So having said all this, and I made the pitch that stopping chest compressions is the devil. And if we use an advanced airway, then we don't have to stop chest compressions. Well, now here we've got some data that says even though 30 to 2, so that's conventional ventilation with a bag valve and a mask on the outside of the patient, is difficult to adhere to. If it is adhered to, survival was better in this study than continuous chest compressions. So now it's like, well, wait a minute, you just spent 15 minutes telling us to put down an advanced airway, and now you're saying the data says maybe it's actually better the simple way? I can't separate that out. Is there another expert in the room that would like to add anything to that? I don't know what to say. If your gut says, I'd like to put down an advanced airway, put down the advanced airway. If you feel confident you can do it quickly, fine. If not, good chest compressions, ventilate EMS. EMS ought to be there in what, couple of minutes? Couple of 3 minutes, 5 minutes? So, so many of these questions and answers are gray. It's not all black and white. There's a lot of stuff that is not black and white. So I keep splashing gray paint here and there. Okay, a couple of videos. So this will look at mask ventilating techniques. Bag about. The norm would be somewhere between 1.5 liters and about 2 liters. So 2 liters would be about half a gallon. So it's not as big as a gallon. Okay? How big is an average breath that you are taking after you ate, after you sat here all morning and listened to me drone on, and you came back, and now it's like, oh man, is he going to talk about anything interesting? Is he going to talk about teeth at all? It's like, no. So you're on the edge of sleeping, so you're as relaxed. You're aggravated, but you're relaxed. How big are your breaths right now? 500 milliliters, maybe, bigger people a little bit bigger, but about 1/2 liter, maybe 3/4 of a liter is an average tidal breath. So how much of the bag does it take to get 1/2 to 3/4 of a liter? 1/3 to 1/2, somewhere in there. Now that's assuming that you get a good seal. My sense of, well, how do I judge when I've squeezed the bag enough? I'm looking for a little bit of chest, I'm looking for some chest rise. We don't need, especially in cardiac arrest, are we moving a lot of blood? Now, do we need a lot of oxygen if we're not moving a lot of blood? We'll fully oxygenate the blood. You know, it's moving slowly through the lungs. It's probably much easier to oxygenate the blood, assuming you get decent seal with your mask. It's harder to get the blood, I think, up to the brain. Okay? So, let's see, I had another thought there, and darn it, I lost it. It'll come back to me. You just wait, you'll have these senior moments too. It was right there. 10 seconds ago, it was right there. Okay, so let's see. So we're squeezing the bag. Roughly half of the bag or so, but you're just looking for chest rise. Don't feel the need to collapse the bag. But most of the folks that I work with when we're practicing ventilation, they want to squeeze that bag not only fully, but they want to squeeze it assertively, hard and fast. What will that do to the pressure, assuming you get a decent seal? It's going to raise the pressure in the airway. And remember, one of the very first pictures I showed you was a bag valve mask that had a pressure gauge on it. So you would like, you know, holding the mask onto the face is rough and assertive. And it's hard to do it well. But squeezing the bag should be soft and gentle. And you'd like to see some chest rise. Now I remember what the deal was. When a patient's in cardiac arrest, it's hard to move blood, right? So anything that discourages the movement of blood is bad. When we take our airway device, our bag valve mask, and we assertively blow up 2 big balloons in the chest, that raises the pressure inside the chest. So we've got the diaphragm muscle on the bottom and our ribs on the side and the front and the back and up at the top. So that space is sealed and the heart and the lungs are in there. When you blow up these lungs and you blow up those 2 balloons, you raise the pressure in there. It's harder to get blood to flow back into the heart when you raise the pressure inside the chest. Especially as dentists, you know, we're very focused on airways and ventilation. When if I ever get to talking about direct sedation stuff, you know, it's breathing. What did I say this morning? Bad breathing, good breathing. It's all about breathing. You know, so that encourages, I think, the idea that, you know, we want nice, big breaths. If you've got a pulse, nice big breaths are great. If you don't have a pulse, big breaths with your bag valve mask actually inhibits blood flow with your chest compressions. And remember, if the patient is in cardiac arrest, if they have no pulse, if they look dead, they need flowing blood more than they need big ventilations. So that's what I was after there. Okay, I've got one more video, and come on.
If you have a situation where you feel like you're going to need to ventilate, we've covered the basic use of a bag valve mask in a different video, which I believe you have probably just seen. I want to spend just a moment talking about an oropharyngeal airway. These are fairly simple devices. The idea is to help hold an airway open while you're using a bag valve mask. It's critical that a device like this only be placed in somebody who is deeply unconscious. Anybody who has any responsiveness at all will likely retch or vomit if you try and place this. So anybody with any level of consciousness is not a suitable candidate for an oropharyngeal airway. They need to be deeply unresponsive, deeply unconscious. These devices come in different sizes, many different sizes in fact. The appropriate way to decide how to fit one into place, what is an appropriate size, would be to take the device, set it onto the side of the patient, and the idea is that this flange right here would sit at or just in front of the incisor teeth. This end of the device right here sits right at the angle of the mandible, and so that's something that's easy to palpate. Certainly you would want to have in your mind which size you potentially might use before there's a problem and not be going through a sizing exercise during a crisis. But once you've decided that there's a need to place one of these devices, and this of course would be when you are going to use a bag valve mask, there are a couple of different ways to appropriately place it. What you do not want to do is simply to just push it in this direction. That is not the appropriate way to place it. So the method I would recommend is open the mandible a little bit, open the mouth a little bit, place the device sideways, and then as you slip behind the tongue, you just rotate it into position. So that's what it looks like once it's in position. Let's take it back out and we'll put it in another way as well. So once again, you open the mandible and you can actually start with it upside down and then rotate it the full 180 degrees into position. But the idea is that the flange sits in front of the incisor teeth, and then the curved part of the device sits over the top of the tongue, and then this portion sits behind the tongue with the posterior pharyngeal wall back here and the tongue up in here. Once the device is in place, you now should pretty reliably have an open airway, and you can simply place your bag valve mask device over the top of that and ventilate.
I get to prance around here and talk like I know what I'm talking about, and you sit there and go, yeah, that sounds good. But it's hard to sit there and look interested all day. I totally get that. This is a hard way to get information, and so we're now deep into the afternoon, and I'm grateful that you're here, but I know that doing this material is hard, but I want to thank you for that. Okay, so now my question is, so now how do I politely say this? If you've got gray hair, and that's me, did you learn CPR doing mouth to mouth? I did. What do you think of that? Good? Bad? Okay, so I heard, now it's gross. Well, yeah, so I'll tell you, when I went to dental school, we didn't wear gloves. We did if we were doing surgery, but I remember doing scaling and root planing, and both hands were just covered in red. It's like, well, it's not surgery, so we didn't wear gloves. Yeah, okay, so the ooh and the ick factor is pretty different. But just from a technical oxygenation standpoint, let's talk about mouth to mouth. That's the way a lot of us learned CPR, was doing mouth to mouth. So okay, there's the ick factor of putting your lips over somebody else's. But you know, I grew up with that. So, and I grew up with not wearing gloves. So there was a part of me that, yeah, that was fine. Now, but what I want you to ponder is, can you adequately oxygenate somebody with exhaled air? Ooh, I heard a bold yes. Would anybody stand with her? Okay, hold that thought. How much oxygen is in the air that you're breathing right now? Does anybody know? Mas. 21%. So the room air, 21% O2, most of the rest is nitrogen. How much oxygen is in the air that you exhale? 17%. So most of the oxygen you inhale, You exhale. All right. I actually did a study of one, so I looked for literature on oxygenation, mouth to mouth, and I couldn't find any. So that means I'm prone to do a study on myself, which I've done. And so here's how I did it. So I would like people to critically review my research technique. But I took a trash bag. And so what I'd inhale a normal breath, and then when I exhaled, I would blow into this collapsed. I started with a collapsed trash bag. So the trash bag is empty. And I would exhale into this trash bag. Okay, and I did this for a few minutes. So I managed to fill, sort of a kitchen-sized trash bag with my exhaled air. So my assumption is that the oxygen level in that air was about 16 or 17%. So then what I did is I put on a pulse oximeter and I desaturated myself, and it's sort of a parlor trick. You could all do it. If you sort of know the trick, you can do it. But I desaturated myself, and I think I actually got into the high 60s. The last time I was the lowest I've ever gone, but I can usually get into the low 80s. So I desaturated myself, and then I start breathing air that was in this trash bag. So now I take air in from the trash bag, and then I would blow it out. Air in from the trash bag. So now I'm asking, what do you think happened? What did my pulse oximeter do? Would you care to hazard a guess as to where I sort of plateaued at? 92 to 94 is where I hung out. And so I resaturated, and how long will it take when a patient goes from bad breathing to good breathing? How quickly do they resaturate? About 30 seconds. And so yes, I went from the high 60s up to the middle 90s, 92 to 94, low to middle 90s in about 30 seconds, and then I just plateaued there. And I left that for, I don't know, a minute or so. And then I take the bag away and I start breathing room air, and now what happens? I saturate up to 99. So my study of one suggests that breathing exhaled air, mouth to mouth, reoxygenated me. Not completely, but is 94 good enough? My opinion is 94 is good enough. Okay, so like I say, I could not find really data that looked at this. But this is a 2011 study. It's in a journal called Resuscitation. And so when provided by lifeguards, mouth-to-mouth ventilation more reliably resulted in visible chest rise. So they were actually measuring volumes pushed into the patients. So on average, the lifeguards giving mouth-to-mouth were achieving, I think, about 750 mLs. Did I put some of those details? It doesn't look like I did. They pushed slightly bigger volumes, and there were shorter interruptions to chest compression than mouth to pocket mask. Because with a pocket mask, how many of you carry a pocket mask? I have one in my car. And so that's mouth to mouth, but there's a plastic mask in between. So it decreases the ick factor, but you're still using exhaled air. But you don't have to, it's easy. The thing is, it's easy to get a seal when you lock lips with somebody. Actually, you're not locking lips, you're sort of going. Well, yeah, you pinch I have to remember how to do it. You pinch the nose, and then you're locking lips. And yes, you can feel the seal better. So I just sort of throw that out there This is sometimes not well received that Ernie's trying to get us to do mouth to mouth. And it's like, not really, but I'm saying if you can't make the mask, the bag valve mask work, I'm telling you, I believe this is a viable option. That's all I'm saying. It's a viable option. Okay, that image is going to fail. Fade. Come on, fade. Oh, geez, it's supposed to fade because I got into trouble. Okay, I'm sorry. Forgive me. There it goes. Okay. Yeah, I am no means am trying to be the least bit offensive. But what the data that is being presented is real, that in public, women are less likely to receive chest compressions than men are. And that was documented in the first citation there, sort of in the middle of the screen. And the bottom citation conjectured why that was maybe the case. That there was fear of being accused of inappropriate touching or being, accused inappropriately of sexual assault by, doing chest compressions in public on a woman, especially since we're sort of teaching you bare the chest. Is that still a typical teaching? Is to pretty much, okay? So in private, apparently there is no significant difference between how often men get chest compressions and women get chest compressions. But in public, there seems to be a hesitancy, and it seems to be hesitancy on the part of men to apply CPR to women in public. So I just wanted to point that out. Okay, let's talk about oxygen. Oxygen, yes.
I think the percentage of revival is 65% with CPR, and with the AED it increases to 85%.
Okay, so say those numbers again. So with CPR alone, 65%. When you add the AED, you get to 85. Okay, thank you very much. I appreciate that. All right, so let's talk about oxygen. So here's where I say some things that are probably contrary to what you've grown up believing. Oxygen is good, so more is better, right? And my answer is no, that is not right. And that is very contrary to what almost all of us were taught. So how much is too much, or how is oxygen bad? So hyperoxia occurs when cells or tissues are exposed to an excessive supply of oxygen. There is no place in nature where we have this too much oxygen. Our bodies do have compensatory mechanisms when there's too little oxygen, but there's nothing built into our system to handle too much. So when you have oxygen molecules, a certain percentage of those are free radicals or reactive oxygen species, or you see it abbreviated in the literature ROS. They're present, and so of course in 100% O2, there's a lot more of it than in 21% O2. They are tissue damaging. They damage things. They tend to damage DNA on a microscopic level. They damage tissues on a macroscopic level. Oxygen is also a pretty potent vasoconstrictor and limits blood flow. So I want you to remember that detail. Limits blood flow. So this is an image of an incubator. Incubators were new back in the 40s. Oxygen back during that time was extraordinarily expensive. Now it's far easier to produce and distribute and use. It was really expensive back then. And so an incubator allowed newborns to be placed, and especially as premature infants, to be placed in a highly oxygen concentrated environment without pouring oxygen all over the room. So it became economically feasible to use high concentrations of oxygen, and it became very popular to put 100% O2 into an incubator for prematurely born kids. Okay. Shortly after that, let me see what I've got on my next slide. Yeah. There started to be a rise in what was called retinopathy of prematurity. A lot of kids that were discovered to be blind. There was actually, it took a few years, and there were some studies that were done looking at, could it be related to the oxygen? And in at least one of the studies, the nurses who were participating into the study were so convinced that it was wrong to have a control group that didn't get extra oxygen, that they were actually providing oxygen to the kids in the control group that were not supposed to be getting any oxygen. Well, what ultimately got figured out was the high concentrations of oxygen were causing damage to the tissues of the retina, which healed, but they healed with scar tissue. And scar tissue is not sensitive to light, so these kids were blind. So Stevie Wonder is thought to be one of those ROP, retinopathy of prematurity kids. So he was born prematurely, he was born in the right time frame, but this is all pulled off of Wikipedia, so the assumption is that he is probably associated with oxygen use as a premature kid. But there was a substantial rise in this otherwise very unusual condition. So that's just an example of too much oxygen. Okay, here's a cardiac example. So this is a group of patients. They're not having cardiac distress. And it's a small study, so we're looking at about 10 individuals. And we're looking at coronary blood flow, so the CBF on the top graph, coronary blood flow, and coronary vascular resistance, CVR. So the CVR, coronary vascular resistance, and coronary blood flow. Breathing room air, and then after breathing 5 minutes of oxygen. That's not very much, but oxygen via a full face mask. So they're breathing pretty close to 100% O2. So what happened to the coronary blood flow in every example there? Did it go down? Did it go up? Or stay the same? Every single one of them went down. Okay. The coronary vascular resistance in every single one of them went down, went up, stayed the same. Went up. Okay. Where is almost all of the oxygen that's in our blood? Especially the arterial blood. Think of the arterial blood. Where is all the oxygen? And the person that just went, heme. I was just going to say that's exactly right. It's on the hemoglobin. There is a little bit of oxygen dissolved in the liquidy part of the blood, the plasma, the watery part of the blood. There's a little bit dissolved there. By far, the majority of the blood oxygen that's in the blood that's available to oxygenate tissues is attached to hemoglobin molecules. So if you want lots of oxygen getting to tissues, you want a lot of blood flow. Does extra oxygen encourage blood flow or hinder blood flow? Based on this. Hinders blood flow. So and this was, let's see, this was in the journal American College of Cardiology. So there, the author's calculations was that even in the presence of 100% O2, myocardial oxygen delivery dropped by about 17%. So is that counterintuitive? You've got a patient with chest pain. Oh, That's myocardial ischemia, too much oxygen to the heart muscle. Let's put them on oxygen. And so what this is suggesting is that no, you actually decrease oxygen. You saw the algorithm from the American Heart Association. If the O2 sat is 94 and above, do you use oxygen? No. So the only time this is a problem is when we're using extra O2. When we get the hemoglobin full and then there's extra O2, that's when it's a problem. So don't take this as I'm dogging oxygen all the time. But how do you judge when you need oxygen? Yeah, I should have pulled this out earlier. I have 2 pulse oximeters with me. How many do you have? This should guide your oxygen use in an awake patient. Now for folks that are in cardiac arrest, I don't think there's any disagreement. Use 100% O2 into your bag valve mask or whatever ventilation device you're using. But for the awake patient, guide your oxygen use with a pulse oximeter. If they're low, give them oxygen. But if they're not low, you probably don't need oxygen. And I'm trying to point out there are multiple times when using extra oxygen is bad. So here's one example. What about up in the brain? So how many of you use nitrous? Yeah? And so what do you do at the end of your nitrous appointment? You shut the nitrous off and you let them breathe oxygen. Okay, and why are we doing that? Okay. So to flush out the nitrous, I hear that often. There's also conjecture that it helps prevent diffusion hypoxia. And so the idea there is that there's so much nitrous coming out of the blood so rapidly that it just simply dilutes the oxygen trying to get in. Okay, that has been shown to occur in the operating room with full face masks and very high concentrations of nitrous oxide, but it's difficult, if not impossible, to demonstrate in a dental office with like 50%. Okay, so that's beside the point. But what does that oxygen do to cerebral blood flow? So this graph is looking at cerebral blood flow. So this is from the European Journal of Anesthesiology. So I'm just trying to point out that these are mainstream journals. So the left to right of this is time in minutes. So this is when oxygen is started. Right here, right there. Okay, so cerebral blood flow plummets between 25 and 30% when you put them on oxygen. Well, does that make sense because oxygen is a vasoconstrictor? It seems reasonable to me. Did you know you're doing that? And my guess is none of you are thinking, yeah, I know I inhibit cerebral blood flow 30%. For a few minutes. Now, is it a huge deal? Are patients dropping like flies because we do that? No. So am I telling you that you're hurting your patient? I can't say that. But does it maybe change a little bit the way you think about it? I mean, I don't really believe in the diffusion hypoxia thing. I do believe in this. What happens if you just take the nitrous mask off? Just take it off. So I challenge you to put a pulse oximeter on your patient when you do that. I think it's extraordinarily unlikely you'll see them desaturate at all when you turn off your nitrous. So you could go, oh, well, I don't need to flush it out. I don't need to worry about the diffusion hypoxia, but there's another problem. was just taking the mask off. Where's all that nitrous going that they're breathing out now? It's just in the room. So that's the other thing, that leaving the mask on and the scavenger going is picking up the waste gas. So I'm not telling you just to shut the nitrous off and take the mask off. All I'm trying to say is, did you know that you decrease oxygen delivery to the heart? Did you know that you decrease blood flow to the brain? Did you know that if used in premature kids, we induce blindness in a certain percentage of them? I'm just trying to point out, big doses of oxygen have their issues. That's all I'm trying to say. But I think many of us grew up with oxygen good, more oxygen better. It's like, nah, the right amount of oxygen good, too little bad, too much bad. Do we give extra oxygen for chest pain? We've sort of already had that discussion. And my answer is no. If they're not hypoxic, they do not need oxygen. You actually potentially make them worse. This is actually looking at oxygen use and cardiac arrest. Now, this was a study. I'm sorry that the graph is so fuzzy, but that's the best resolution I could get. This was a study done in dogs. And so the dogs were arrested. Cardiac arrest was induced in these dogs. They were put to sleep. And then cardiac arrest was induced. They were allowed to fibrillate for, I believe, 9 minutes. They were ventilated during that time. And then they were, maybe it wasn't 9 minutes, but then they were defibrillated and resuscitated. Okay? And the x-axis left to right is time in hours. So the arrest was, pretty short-lived. The y-axis, the up and down axis on the graph, is measuring neurologic deficit. So the higher the line, the more intense the neurologic deficit. So the lower the line, the better the brain function. The top line is the line where they used 100% O2. The middle line is where they used room air, and the bottom line is where they were using an experimental drug to reduce. It had an antioxidant in it. I don't think it's available commercially. I didn't write it into my note, but the point is that at one day, after a few minutes of ventilation, at one day, there was still a difference in the neurologic deficit. Now then, this was in cardiac arrest. I said a moment ago, in people, I think it's still accepted to use 100% O2 in a cardiac arrest. I'm showing you a study in dogs that says, well, the dogs that got resuscitated on room air did better than the dogs that got 100% O2. So I'm throwing gray paint out there again. Okay. Hyperoxia, room air, okay, and that was and then the bottom line was the experimental drug. Okay, I'm close to the end on this part. In ventilated stroke patients, arterial hypoxia was associated with in-hospital death compared with normoxia or hypoxia. So too much oxygen was the worst of the three. High concentration oxygen therapy caused a clinically significant increase in CO2 in patients presenting with severe asthma. So I've shown you data looking at hearts, lungs, brains in hypoxic, over-sedated patients with poor or no ventilation, resaturation occurs just as fast with room air as with 100% O2. And then the citation there is loose personal observation. So those are experiments that I've done on myself again. So I'm not going to make you watch the videos because it takes too long. But what I've done is, I can desaturate myself, and then I can resaturate myself breathing room air. I can resaturate myself breathing 100% O2 coming out of whatever oxygen source. And so when I do that, and how long does it take for the O2 sat to rise back from 75 to 95? 30 seconds. Now is that with oxygen or room air? It doesn't matter. In me, it's the same. And I've done that over and over and over again. It's about 30 seconds. So when I say, when I'm talking about a sedation crisis, I intentionally word it as, what's gone wrong in a sedation crisis? The patient has developed bad breathing, and the fix is good breathing. Did I use oxygen? Did I say the word oxygen in there at all? No. Now, am I telling you not to use oxygen? No. But I'm saying that doesn't seem to be the core fix. The core fix is moving air, whether it has 21% O2 in it or 92% O2 in it. Okay, let me see what I've got here. Okay, so I've hit a lot of these things. I'm gonna express some of this. So now I'm talking about doing awake sedation. So I'm talking about our level 1 providers, maybe even our nitrous providers, our level 2 providers, our level 3 providers, where we're all doing sedation where the expectation is the patient is awake or at least easy to wake up. So picture this 4-square grid, and we're thinking about responsiveness, and we're thinking about breathing. So you can have awake and not awake, breathing, not breathing, or not breathing well. So we're going to sort of make a matrix here. And I want you to pay attention to the colors too. So the green box is I've got a patient that's breathing at least reasonably well, and they're awake. Is that a good state to be if we're doing level 1, 2, or 3 sedation? Yeah. I'm relaxed. How you doing down there? Oh, I'm fine. This is awesome. Is it okay if I snooze a little bit? Yeah, wake me up if I snore. Wake me up when you're done. That's a great way to have a sedated patient. Okay. Now, why does it do that? I don't get it. I'm sorry. I'm wondering if it has to do, we had a bunch of issues and I had to do a couple of hard starts on my computer this morning. So it's just behaving a little different. So now we've got a patient that's breathing, but I can't wake them up. But they're breathing. Their O2 sat is 97. They're moving lots of air. What do you think? Well, is it a problem? I would say it sort of defines deep. Now I'm assuming that you've tried to get the patient to wake up and they didn't really wake up. Is it okay for our moderate, if we're doing moderate sedation or minimal sedation, is it okay for our patients to sleep? I'm going to say it is okay for them to sleep as long as they're easy to wake up. Yeah. Okay, yeah, okay. So if I either talk to them or gently poke at them, the rules will allow me to gently poke at them. If they'll respond with a gentle poke, Ernie, turn your head. Or if I just talk to you, Ernie, turn your head. And I do? Okay, that's responsive. So now let's say that I've been unable to at least easily wake you up. But I'm breathing well. Are we in trouble? So now I can tell, so I'd say just sort of hold this thought, but look at the color that I put that in. So now you know which box is coming. Not ventilating so well, but they're awake. Do you ever see this? Do you ever see an awake patient that's desaturated to 92? I see it all the time. What do we call that? Wait a minute. Is it scary? Okay, so I'm in jail because of the TV camera. So those of you that are on the call but not in the room, I stayed on the stage because of you. Because if I walk around, then I walk off camera. So in honor of you, I stayed on the stage. I haven't paid enough attention to you. But if I desaturate myself, which I could do, but it'll take a few minutes, but I can get myself down to 92. How many of you are going to worry that I'm going to get into trouble? Actually, none of you, because you would be very happy for the day to end right now. And I get that. I totally get that. You guys have been awesome. And I know a big part of why you're still here is you're waiting for a completion code. I'm absolutely aware of that. Okay. But I assure you that if I desaturated myself to the low 90s or to the 80s or even to the 60s, because I did it in front of a group and I got down into the 60s, I'm awake and looking at them. Not one person pulled out their phone and called EMS. Why not? Just think simple. I'm awake. Now then, does that mean I'm encouraging you to leave a patient desaturated? No. But is the sky falling? No. I'll say not quite. Not quite. So how do we get that way, though? How can you get a patient to be awake and talking to you, but they've desaturated to 90?
Different episodes, maybe, like the stop them and then they come back.
I'm going to tell you, it's not that. I'm going to tell you, let's have a patient that's just awake and talking, but they've desaturated. We're not on the top of a mountain. We're not at altitude, so nothing goofy like that.
You said not taking enough deep breaths.
Why not? Do awake people obstruct? No. If awake people obstruct, where are their hands? Yes, they'll be up at their neck because they're obstructed with a piece of gauze or a tooth or some foreign object. Are they going to obstruct with their tongue awake? No, we had the discussion, how do you stop people from obstructing that are asleep? You wake them up. Does that predictably pull the tongue off the back of the throat? Absolutely. Okay, so now we've got an awake patient. They're relaxed. You've given them fentanyl and midazolam. Probably less likely to see it with just triazolam. But if you do level 2 sedation and you've mixed an opioid and a benzo, or level 3 sedation, an opioid and a benzo, yeah, I see people desaturate. How does that happen? The drugs that we give, in order to decrease their CNS wakefulness, also decreases their sensitivity to bad breathing, their sensitivity to elevations in CO2. They're also less sensitive to lowered levels of oxygen. And the doctor term for that is respiratory depression. They have respiratory depression. Okay? So, is the sky falling at 95, and they're awake and talking to you. 94? 93? 92? 91? Yeah, you know, it's like, do the state board rules tell us where that line is? No. I can't tell you what's considered acceptable from an O2 SAT standpoint, assuming that you're at roughly sea level. I can't tell you, and I also think it would vary according to the personalities at the State Dental Board, because they don't write it into the rules. I would say it's certainly in the 90s somewhere. I doubt you'd get much of anybody to say, oh yeah, it's fine to let somebody camp out in the middle 80s. Okay, but I'm going to throw some gray paint on that here in a moment. Okay, so now what color is the next box going to be? It's like I click it and it doesn't go, and then I click it again and it goes 2. Okay, it just went 1. So not ventilating and unresponsive. What do we call this in awake sedation or conscious sedation? This is the definition of, starts with a C, R, I, S, crisis. So for our level 4 providers, the people that are using propofol and inducing deep sedation, general anesthesia, this is what they expect, is to get a patient unresponsive and maybe breathing, maybe not breathing. They are well trained to manage the unresponsive, non-ventilating patient. So it's their norm. But for the rest of us in the room, it is not our norm. So unresponsive and not breathing is crisis for us. Now then, let's go back to ventilating but not responsive. And one of you earlier on said, sort of muttered quietly, that's deep sedation, which is correct. And deeply sedated patients may ventilate on their own, they may not. But they're hard to wake up or impossible to wake up. And I asked, is this a problem? And then there was sort of hemming and hawing in the room. And I asked earlier in the day, do we have deaths in moderate sedation? And the way I would answer that is we have no deaths when people remain moderately sedated. Now, I haven't gone through the definition yet, and you can't wait, but I'm going to do that next. You were supposed to chuckle at that, so I've clearly worn you out. All right, so for patients that are truly moderately sedated, they'll maintain an airway and they're easy to wake up. But they maintain an airway. Okay. So, and when people breathe badly in sedation, it's almost always they obstruct. So if they stay obstructed, and they just stay obstructed, they're not moderately sedated. My pitch is we don't have deaths in patients that remain moderately sedated. We have deaths in patients that were intended to be moderately sedated, but were allowed to reach a state of deep sedation, and then it didn't get managed or recognized. And that's when bad things happen. So the entry point, in my opinion, the entry point to crisis in awake sedation is the unresponsive patient that's still ventilating well. The patient that was deeply sedated first, but probably still breathing. And you're going, this is awesome. I'm getting work done. They are quiet, still, and it's great. What's going to happen the first time you let somebody get deeply sedated? Let's assume you're not a level 4 provider. Most of us in the room are not level 4 providers. What's going to happen the first time you let somebody get deeply sedated? And I want the staff listening to this too, because You know, we function as a team, and I want everybody to have a sense of what conscious sedation is and what it isn't. And if there's a sense of, wow, my IV sedation doc, man, we get these patients blasted all the time. You know, we can't wake them up. I don't know what this guy was talking about on the stage. We can't wake them up. That's a risky state. You know, and I may be touching some sore nerves, nerve endings here saying this.
Ask me a question, or you ask a question, is it feels great that you're sedated, did all your work, it doesn't take as long to wake them up. You know, once you're done, it's like, how long are you gonna wait till all that?
You're right. So, yes. So,
You're gonna sleep.
so people, the deeper you get them sedated, the longer you can expect to get them to wake up, especially if you're using, traditional drugs like midazolam, fentanyl kind of thing. You're absolutely right. The answer to what I was trying to get to a moment ago was what's going to happen the first time you let a patient get deeply sedated? Nothing. They're going to do fine. What's going to happen the second time you do it? Nothing. They're going to do fine. And the 10th time, and maybe the 100th time, and then you start to believe these ivory tower dentists, and I'm an ivory tower. I've been in the ivory tower for 40 years. I can see enamel rods like you wouldn't believe. You were supposed to laugh at that one too. And you didn't. So yes, I absolutely live in the ivory tower, but if there's one thing that I'm going to get on my soapbox about, it's we have such an awesome privilege to be able to do sedation out in our offices. And there are places in the world, UK has pretty much eliminated, I believe, in-office sedation. I think. I'm not sure I've got that detail right. There are lots of places where it's gotten very restrictive. And we still have the privilege of doing lots of drugs in an outpatient setting where we pretty much take care of it ourselves. You know, we don't have to necessarily have an outside anesthesiologist there or do it in a surgery center, which dramatically increases complexity and cost and all that hoo-ha. But in order to keep the privilege, it's important that, we do things the right way. So what I'm getting to is for the awake sedation providers in the room and on the call, deeply sedated patients are the devil. And the subtly risky part of this is not everyone's going to get into trouble that becomes deeply sedated. Remember, our oral surgeons and dental anesthesiologists do it every day. But they're trained to do it. They're trained to get people out of trouble when trouble comes. It doesn't come very often, but they're good at getting people out of trouble. The rest of us don't get a ton of training. And you get me blabbing about it on a screen, but that's different from actually getting to ventilate people for real, or actually putting airways down, or actually reversing, or actually making our team work together as a team. I can't wake up our patient, I'm not sure they're breathing. Can you pull out the naloxone and the flumazenil for me? Put 2 cc's of flumazenil in a syringe, put a cc of naloxone in. Hand me the eye gel, please. Have the bag valve mask ready. And if we don't get a patient awake in the next 30 seconds or 60 seconds, I want to call EMS. Will you call out the time for me, please? That's easy for me to blab off standing here on the stage. Making that happen in the office when you think something really bad may happen is an entirely different thing. Yes, sir. Thank you for your patience.
So Diane wrote here last week addressing our local society. She seemed to indicate that rules were coming down the pike that we no longer allow sedation permit holders to do the operative dentistry as well as the sedation simultaneously. Do you have
Did she go any farther in terms of what level? Like, did that apply to a level 1 provider?
No, I don't think level one, but above level one, as I remember, that's what she was saying, that they were going to come further.
Well, there are places in the country that have at least imposed age limits on level 4 providers to do the procedure and the anesthesia themselves. A level 4 sedation. I think California, Caleb's law, if you're less than 6, I think you have to have a separate anesthesia provider. I can't remember that detail. So, I don't know. If the farther down the sedation permit level they go with that, if you've got to bring in somebody separate to do level 1 sedation in order for you to do your amalgams, or you're not doing amalgams anymore, you know how old I am now. Your composites, that's really going to put a kibosh on, providing sedation to patients.
I don't think she can commit.
Yeah. Well, but, even 2, I don't know. Now, I haven't heard those murmurings yet, but, Diane would also, she would be in the know. She would be in the know. So that'll be interesting. I think about retirement every day. Although, that's my business model, is I don't touch teeth very much anymore. So for me, that wouldn't affect me much, but for people that do live, especially enteral sedation providers, whether it's level 2 or level 1, that'll introduce a huge impact on their practice, I think. Okay, anyway. So, deep sedation is the devil. If I could get people to believe one thing, and especially the staff, the non-doctors in the room, to be a little bit challenging if you feel like, wow, our patients are supposed to be awake, but sometimes it gets really hard to wake them up. It's like, is that right? It's like, should I say something? Should we say something? It's like, am I going to say something to the person that signs my paycheck? I can understand that's a tricky thing, but my pitch is it's easy to let people become deep, and it's easy to let that become sort of your norm and accept it as that's just sort of the way it is. We do that. I've been doing it forever and it's fine. Yeah, it's fine until it's not fine. So that is sort of my biggest thing about sedation is respect, responsiveness. If you're doing awake sedation, your patients need to be awake, easy to wake up. I think it's fine to let them snooze. I can assess responsiveness pretty easily by, can you turn your head to the left? And if they turn their head to the left, that's a response. I don't need to go, Ernie, open your eyes. Are you awake now? I don't have to interrupt the procedure for that. If I see them cross their legs and then uncross them and go the other way, that's a conscious response. If I see them reach up and scratch their nose, that's a conscious response. Those are all responsiveness signs to me. But if they're hard to wake up, that's where the devil lives. Because bad breathing doesn't become a real problem until they are unresponsive. Then we have to have all these technical skills, the bag valve mask, the eye gels, the OPAs, all these gadgets that we don't get to practice. We're good at what we practice. We're not good at what we don't practice. And most of us don't get to practice those things very often. Okay, I've been preaching too much again. So, sort of a stepwise algorithm. Recognize a problem. That's code for, well, is my patient a little hard to wake up? Or, gee, is their O2 sat? Has it dropped? Okay. Are they responsive? Can you easily wake them up? Wake them up and talk to them. Tell them what to do. And it's always going to be, Ernie, take a big deep breath. Okay. If you can't wake them up, so you see the red arrow, be willing to hurt them. Now if you get them awake, talk to them. So you're still good. So I'm not giving reversal agents. I'm not calling EMS yet. If I cannot get you awake, and this is about a 5 or 10 second process. Ernie, 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 wake up. When I get to poking you hard, inflicting some discomfort, I am opening the airway at that point. I don't wait to look and decide is your chest moving or not. I'm just, I just open the airway. Okay, so I'll open the airway, and if you're breathing, okay, I keep stimulating you, trying to wake you up, and I'll reverse you. So is this patient deeply sedated? Now they are. If I can't wake them up, you're deeply sedated. It's great that you're still breathing, but you're still deeply sedated. The devil lives in deep sedation. And then it's even worse if you're not breathing and I can't wake you up. So now we're ventilating and reversing. And that's sort of that was my threshold for EMS. If I'm pulling out the bag valve mask or the reversal agents, I'm calling EMS. In my 40-year career, I've loaded reversal agents twice. I've never actually given them in a crisis. So am I practiced at this stuff? I'm very good on a plastic mannequin. But I don't deal with this stuff in live patients. As much as I talk, it's like I live this stuff. But I still don't get to practice the emergencies on live patients. It's hard to get that practice. And what are the consequences of fouling it up? Pretty significant. It's front page news when it happens. Okay. This is just a little quirky thing, a device called a Life Vac. You can buy this from your favorite online retailer. Some of your dental supply companies probably have it. Come on. It's a Life Vac. It's about 60 or 70 bucks. It's kind of like a backwards toilet plunger in concept. So it pushes air instead of draws backwards. Okay? All right, so the company advocates if somebody is choking that you still do traditional, abdominal thrusts, what we used to call the Heimlich maneuver. Okay, that you still do that, but if you cannot dislodge the object, that the patient will ultimately collapse. And let me play this video. Pressure difference with that device than you do doing these abdominal thrusts. When we squeeze up and in on the abdomen with an abrupt up and in, we create a little bit more pressure in the lungs to push the hot dog chunk out. The Life Vac dramatically reduces the pressure on this side of the hot dog chunk. But the idea is that they claim we get a much bigger pressure difference, so there is a more abrupt pushing the object out. It's just a gee whiz thing to have, if you want to think about it. Yeah, I mean, it's that big. Okay, it's time for us to take a break. So let's take 10 minutes, and we'll come back and we'll figure out what we're going to do for the rest of the day. But you have been extraordinarily patient with this very long discussion about emergencies. That would provide for emergency preparedness protocols and checklists, and they changed the defibrillator rule. So You know, now if you do any level of sedation, including nitrous, you've got to have a defibrillator on, you know, in the office. Back before 2017, you only had to have a defibrillator, I think, if you were doing level 3 or level 4 sedation, and I want to say it was only if patients were ASA 3 or higher. I'm not sure I have that detail right, but that was a pretty significant change in the defibrillator rule. So I assure you, this talk has 9 slides in it. So I am not going through all the rules, which I know you don't want me to do. But I've tried to pick out a few highlight points. I do get asked by attorneys to look at records, and it's, you know, the ones I'm willing to look at are, you know, have something to do with sedation. And so this is just my sense of what I see as common trouble spots based on records that I'm asked to look at. So that's sort of where I'll focus here. And come on. Okay, so just a little bit about sedation levels. I've sort of already alluded to a lot of this. So I think there are probably a number of folks in the room that practice level 1 sedation or minimal sedation. So that means that you are using a single oral agent. The doses are absolutely limited. The initial dose has to be as small as or less than what's called the MRD. I'll expand on that in just a moment. You are allowed 1 single extra dose, and you are allowed to mix that with nitrous oxide. So that's minimal sedation. For the most part, the drugs that people are using for this, I think, are benzodiazepines, so triazolam, brand name Halcyon, diazepam, brand name Valium, lorazepam, brand name Ativan, are probably some common drugs. In youngsters, I think it's also common to see midazolam. An old brand name is Versed. I don't think you can get brand name Versed anymore. So that's minimal sedation. Just briefly, let's talk about the MRD. So if you're doing level 1 sedation and you're using a benzodiazepine, somebody throw out, what drug do you use if you're doing level 1 sedation? Okay, so I heard Halcyon. Did I also hear midazolam? Yes? Did I hear some midazolam in the back? Okay. All right. So triazolam or Halcyon, I'll talk about both. Triazolam or Halcyon, very clearly stated in the package insert. And so MRD stands for the manufacturer's maximum recommended dose for daily home unmonitored use. Triazolam is approved as a sleeping pill. So there's absolutely recommendations for daily home use. And the package insert clearly says we should not exceed 0.5 milligrams. So if you want to practice minimal sedation within the rules, your initial dose of triazolam or Halcyon, if you buy the brand name stuff, cannot exceed 0.5 milligrams. Now, does that mean that that's your initial dose? Now, does that mean that you could give everybody 0.5 milligrams of triazolam and they will stay minimally sedated? Absolutely. So my mom would be a perfect example. She's 4'10", she weighs less than 90 pounds, she's over 90 years old. If she can smell triazolam, she gets sleepy. I mean, she's just really sensitive to drugs. So 0.5, she would be, I don't know, out for the day. She would absolutely be deeply sedated. But there are a lot of people that will stay minimally sedated on 0.5. Can you tell by looking? No, you know, you can get a sense that, well, like older petite people probably are pretty sensitive to the drugs, but you know, you just can't tell by looking. That's one of the disadvantages to oral sedation. Is you sort of look at them and go, 0.375. And, you know, when you throw it at the patient, you see what you get. What about midazolam? So I assume if you're using midazolam, you're using it as a liquid or a syrup. I believe it comes 2 milligrams per ml. Now, midazolam, does midazolam get used at home? No, it's used as a pre-procedural sedative in an office or hospital kind of setting. So the package insert talks about 0.5 all the way up to 1.0 milligrams per kilo, I believe with a recommended maximum of 20 milligrams. My sense of what I think the board would accept. So the reason I say this now, so on the triazolam, I said the package insert very clearly states do not exceed 0.5 milligrams, you know, per day. So that fits right in with the definition of the MRD. The MRD kind of doesn't work with the midazolam because it's not used in the same way. Although we use it as a minimal sedation drug. I'm not saying don't use it as a minimal sedation drug. Midazolam's a great drug. I use it almost every day. In fact, I haven't had any today. Well, you chuckle a little bit. Okay. The day does wear long. I totally get it. My sense of what the state dental board would accept as a minimal sedation dose would be 0.5 milligram per kilo. But I do not have that in writing anywhere. And I don't think you can pull out a package insert that would clarify that. Now, if you have a level 2 sedation permit, your drug privileges are dramatically expanded. And so you'd be allowed to use 1 per kilo. For minimal, my sense is 0.5 per kilo would be defendable as a minimal sedation dose. Does anybody have can anybody add to that, or any experience you may have had with either other courses, other instructors, or maybe the board on this issue and how they looked at oral midazolam by dose? Okay. You know, I've not been able to get that. They certainly don't write it into their rules. They just say your initial dose can't exceed the MRD. In order to extend the effective duration of the sedation, you can add 1 additional dose. But the pitch is to extend the duration of the sedation, not deepen the initial level of sedation which you now deem to be inadequate. Do you see that difference there? If you're trying to deepen the level of sedation that sort of never got where you wanted, that sounds like you're trying to titrate. If you give it to extend the effective duration of the drug, that's like saying, well, my lidocaine is starting to wear off. I'm going to give some more lidocaine to keep my patient numb. We do it all the time with local anesthetic. Okay, all right, so enteral level 1 sedation, okay, your single additional dose plus the initial dose cannot exceed 1.5 times the MRD. So for triazolam or Halcyon, that would be 0.5 plus a maximum of 0.25. So that's a total of 0.75. If you're getting it in 0.25 milligram tablets, that would be 3 tablets. Yeah. What about diazepam? Anybody using diazepam? Okay. For moderate sedation, so now we've got really no restrictions written the same way about drugs. Level 2 is you can use a mix of oral drugs and nitrous. Level 3, you can put a mix of drugs in IV. And really the only caveat about dosing is drugs and techniques should carry a margin of safety wide enough such that unintended loss of consciousness is unlikely. That's pretty vague. That sort of says don't do anything stupid. Really, I mean, that's about what I interpret that to say. So level 1 is pretty restrictive from dose. Level 2 and 3 is not very restrictive. Level 4 would even have more, is more liberal because the intent is to make people unresponsive. So you're using the full spectrum of anesthesia, sedative drugs. So I'm really not going to go into level 4, sedation anesthesia. So with minimal sedation, level 1, the triazolam, the midazolam only, or maybe you mix it with nitrous. That can be all level 1. The patient must be responsive, and the wording in the rules is they must respond normally to tactile stimulation or verbal command. So that to me means the response of the patient, even if they fall asleep. It's like, shoot, I fell asleep in the dental office as a kid with no sedation. I remember my dentist yelling at me about it. He was not very nice. Open your mouth! Okay, so I take the rules to mean our patients can fall asleep as long as it's easy to wake up. And if your permit is a minimal sedation permit, when they do wake up, their response must be pretty normal. I would say pretty brisk. They maintain an airway all by themselves without interruption. What does maintaining an airway mean? What's that code for? Well, so I'm hearing breathing in with our normal limits, and I would say that probably happens, although I'm thinking of it with a little bit more narrow spectrum. If somebody loses an airway, what has happened? Say that again? They obstructed, and what is almost always the obstruction? The tongue. So when people lose an airway, the tongue relaxes on the back of the throat. Now express that the other direction. They maintain an airway by holding their tongue off the back of the throat well enough, whatever well enough is. But they do it all the time without help. Okay, so that's written into the rules. So that's what I take maintaining an airway to be. They also remain normally responsive to tactile and verbal stimulation. Okay, so we beat that horse to death. Come on. I think, was there anything else? That was about it. Okay, and we talked about the dosing limits already. So that was minimal sedation. So for moderate sedation, they must easily respond. So both minimal and moderately sedated patients respond easily. The response of a moderately sedated patient can be a little bit more obtunded. So the wording in the rules is they must respond purposefully. I don't see a lot of difference in the depth of sedation between minimal and moderate. They both need to wake up easily, and they both need to maintain an airway without help. Responsive, maintain an airway. Responsive, maintain an airway. For both of them. Okay, responsive to tactile and verbal stimulation. Okay, so same thing. The moderate rule goes on to say ventilations are adequate. Well, what's that mean? Rules don't tell us what that means. Could you have adequate ventilations if your SpO2 continues to track down? No, I think you'd have to say no. You aren't even maintaining a steady state anywhere. What if they maintain steady state at 98? Is that adequate? What if they're breathing a bunch of extra? What if they're at 95? What if they're at 95 but they're breathing a bunch of extra O2 because you've got them on nitrous? Are those ventilations adequate? So once again, I'm pulling out the gray paint here. So I'm going to make things not so clear. But ventilations are adequate. That's probably going to be judged by the State Dental Board by looking at your O2 sat that gets recorded. I would believe that anything in the middle 90s, 94 and above is probably going to be reviewed pretty favorably. I think you'll start to get people uncomfortable at 93 and 92, and if you get recordings down below 90, I believe that would probably get other people looking at your record, it would get them agitated. The idea that, is your patient responsive, or are they unresponsive? Can you tell responsiveness off an O2 sat? No. But do I think it happens? Yeah. I think judgments get made, but that's just Ernie's opinion. So I think our ventilation's adequate thing is a hard judgment to make. But the higher the O2 sat is, the better it looks. Right? Well, how do you get the O2 sat up? So why do ventilations get bad in the first place? We've given the patient drugs that blunt their sensitivity to bad breathing. So the reason you're breathing without thinking about it is CO2 and oxygen levels are sort of bumping up against sensors in your brain that tell you to keep breathing. When we give patients drugs that decrease that sensitivity, you desaturate some. You also get sleepy and relaxed, which is the way you all are, but you're really uncomfortable because you're sitting there and you're sitting upright and you're trying to look interested, but you're really not. And it's Friday afternoon, you really want to go home. And I assure you, I have a life too. It's like I want to get back to as much as I love you all, it's like I do want to get back to my life too. But we're also, we're going to fulfill the spirit of the State Dental Board. And so we're going to keep working for a little bit more. Yes?
Okay, sometimes we get started, we get an oxygen saturation 97. And somebody's, you remove the finger or their hands are very cold. I can't get them to breathe low.
What? Our monitors aren't perfect? So if you couldn't hear that for those of you that were on the call, the comment had to do with, well, what if the finger probe is misplaced a little bit, or there's nail polish, or the fingers are cold? So let's talk about monitoring a little bit, because I'm probably not going to have time to open up a whole presentation on it. How does pulse oximetry work? So we've got this little doodad, or maybe it's got a cable and then it's connected to the box with a printer and a blood pressure cuff. Pulse oximeters shine red light and infrared light through whatever tissue they're shining through, whether it's an earlobe, a nose, a finger, a toe. While I'm thinking about it, one way, if you're having trouble getting a pulse ox to read and you're willing to buy a different kind of sensor or different kind of probe, the ear probe. Does anybody have the ear probe? The earlobe, it's sort of like a clip-on earring. Do any of you wear clip-on earrings? I remember my mom coming home, so this would be in the 60s, and my mom and dad would go out for whatever. My mom would come home, and what's the first thing she did when she walked in the door? She plucked off those clip-on earrings. They were obviously very uncomfortable. But there are SpO2 probes that will clip on to an earlobe, but they will also apparently work pretty well if you pinch the skin like right between your thumb and your index finger. So one thing to consider is if you're having trouble or you seem to have consistent trouble getting your finger probe to work is consider getting another probe that would be intended for earlobes, but actually you could clip it on right here. That's one way, but that doesn't really fix part of the problem. So are our patients awake? Yes. Do they move around? Yes. Are they going to scratch their nose? Yes. And is the SpO2 probe going to get a little whoppy-jawed? Yes. And you maybe have it under a blanket. Maybe you don't see it. So do those things happen? Can you get the pulse ox to read but not read perfectly? Absolutely. So now, if it prints and it's 91, and you go, oh, 91, and you look and you find the probe, it's all whoppy-jawed. You put the probe back on in the right place, bing, 96, 97. Well, now you got a problem because the printer printed, at least if you use an automated printer, now you've got a printed 91, right? So what do? So I love what you're saying. Our monitors are not perfect, but once something gets printed, then I would say those numbers are gospel unless you make some sort of notation or something that out of anything else acknowledges that you see that. So often in my own practice, if I see that and I fix the pulse ox probe and now the SpO2 is where I want it, I just fire off another blood pressure. And so I have another set of vital signs now 30 seconds or a minute later, and the SpO2 is okay. And I just sort of circle the low one and draw an arrow to the next time. And that's my acknowledgement that, and I might write misplaced or malposed or something. I think almost any notation just screams at me. If I'm asked to look at a record, that screams at me, you're paying attention. It's like I see people with odd O2 sats all the time. You know, our monitors are not perfect. And if the fingers are cold, oh my gosh, you know, now it doesn't matter which probe you're going to use. So how do you deal with cold fingers? Yes, sir.
How often should you have your monitors professionally calibrated?
I asked so the question was, how often do we need to have our monitors professionally calibrated? So I asked my Criticare dealer, and his answer was, does it come on when you turn it on? Yes. He goes, it self-calibrates. That was his response.
Maybe not the older users. I know I've had a credit card for maybe close to 20 years now. It still works, and I do have it calibrated periodically. Not on any schedule, but
Well, I would say that was his comment, was you don't need to calibrate it. Now, we didn't have the discussion, well, does it matter what year model? Is there a mandate from the board that you get it calibrated? Not that I'm aware of. Okay, not that I'm aware of. So, have you had the sense that sometimes your SpO2 probes get stingy? How many of you ever have more than one pulse oximeter probe on the patient at one time? I do. I carry two little ones. I have my big box, and I probably have 4 or 5 probes, finger probes, you know, that plug into the box with a cable in between, that all work. But I often get, if I flip those around, this one pretty consistently gives me the highest number. Well, which one makes me feel better? Which one do I want in my record? This one, the problem is it doesn't have a printer attached to it. So the idea that these monitors all read perfectly, they don't. But once it gets printed, it's gospel. Unless you sort of write or acknowledge that, wait, this isn't quite right. This is what was going on. And sort of this is what we did. Sometimes that can be very easily sort of addressed by shoot another set of vital signs. At least that's my opinion of what would be considered acceptable. Because the board doesn't write anything in their rules in regard to this. How are you going to deal with fingers that are cold? Bingo, warm them up. How are you going to do that? Well, yeah, I would say getting your patient to do this long enough. I would say I've had difficulty with that. I'm not going to dog your idea. So there are certainly heating pads that you can throw into a microwave, and they'll warm up, but they're also going to get cold fairly quickly. I carry an electric heating pad with me. Now, the main reason I carry it is I start a lot of IVs, and I start a lot of IVs on little old ladies with skinny little veins on the back of their hands. And I tell you, that heating pad will double the size of veins on the back of their hands. So it's become an awesome aid to enhance IV starting skills. But at the same time, a lot of patients just find it really nice to have a heating pad right on their lap. They've got a blanket, they've got a heating pad. But if their fingers are cold, I just ask them to lay their hand on the heating pad. And, it makes the pulse oximeter, if your pulse oximeter has a wave kind of function, some do and some don't. But I'll go from getting a flat little pulse wave to a tall pulse wave. Now, it takes a few minutes. But what are you going to do if you can't get your pulse oximeter to read? Okay, so you checked all that stuff. You can't get it to work. If you don't have a backup. I mean, at some point, do you not do the case? Of course, if you don't figure that out until after your oral drug went in, it's like your drug is in. I don't have a super answer for that, but I do. I like the idea of backup pulse oximeters. They don't have to be the expensive box. And so sometimes I asked about a stingy pulse ox probe. So the corded one on my Criticare is sometimes 5 points different than this. And this is actually, this isn't a $10 pulse oximeter. This was like a $200 one that somebody gave me. And so, I looked it up to see what it would have cost to buy it. It's like, oh my gosh, this thing's expensive. And it's from what seems to be a pretty reputable company. But the two monitors are definitely, they're sort of doing this kind of stuff. So, but once it gets printed, doctor, that was the O2 sat. What did you do? Why didn't you do X? Well, okay, so that's an issue. That's an issue with pulse oximetry. Why do we use a pulse oximeter? So it shines the color of two colors of light, red and infrared, through our fingers. Light gets picked up on the other side, and then the wizardry inside the computer tells us how much of the hemoglobin is full of oxygen. But why do we want to know how much oxygen is on the hemoglobin? We use it as a proxy for an indicator of how well the patient is breathing. Okay, has anybody on the front row got eagle eyes? Because if I'm in jail up here, I can't climb off the stage. Okay, so the top number there is 99. But the top number is 99. Can you read that? Okay, so we use a pulse oximeter to tell us if our patient is breathing, right? oximeter any good at telling you if I'm breathing in the short term? No, pulse oximeters are useless in the short term. Now then, why is it that when I hold my breath, I held my breath a whole lot longer than that. Do you want to know what the parlor trick is? Okay. So the parlor trick is, what makes you, when you hold your breath right now, and you stop breathing, and then you go 30 seconds or a minute or maybe a minute and a half, and at some point you go, what makes you finally let go and take a breath? CO2 is building up in your brain. And so there's this stimulus to take a breath, take a breath, take a breath, dang it. And you finally take a breath. And if you're sleeping, so those of you that sleep next to a noisy sleeper that maybe stops making noise at some point, if you leave them alone, what happens? They'll snort. You know the jokes you're supposed to laugh at, you don't laugh at. And then the snorting thing, it's like now you're just all over it. Okay, so do they wake up? You know, maybe with sort of an ugly, sort of a snort, but they wake up every time? How often do they not wake up? So how often do people suffocate themselves to death asleep? My sense is pretty close to never. So the drive to breathe, the drive to overcome an obstruction in the unsedated patient is powerful or not very or weak? That's a perfect way to put it. When you can't breathe, nothing else matters. Okay, so if I was to walk up to one of you and I obstructed you with my hand over your mouth and nose, you'd maybe tolerate it for a few seconds and you'd start to consciously struggle. And then in a few more seconds, you would unconsciously, what's the word I want? You wouldn't be able to help but struggle. You know, there's no way that you could just sit there, at least not a normal person, just sit there and allow yourself to be suffocated to death. It would be an I can't come up with the right word, but an unconscious struggle to breathe. You would do whatever it took to take a breath. When people are sleeping, they will wake themselves up ultimately. Now, they may desaturate acutely before they do, but they'll wake themselves up. Does that always happen in sedation? If a patient is sedated, if we throw some drug into the brain, would you need this course if patients did wake up every time? No. That's how people, deep sedation, they start out breathing well, they quit breathing well, it doesn't get recognized or fixed, and there they do. They just quietly lie there and die because that protective mechanism, which would be intact with everybody in the room right now, is blunted when we throw opioids and benzos and antihistamines or propofol or anesthetic gases or alpha-2 agonists. My take is all our sedative drugs are respiratory depressants to some degree. Some are worse than others. Okay, so the parlor trick is, how do you desaturate yourself? So it's CO2 that's building up in the brain. Is there a way to artificially decrease your CO2? Is there a way to get rid of CO2? Well, not into a bag, just hyperventilate. So you could do this in the privacy of your own home. Just go home and hyperventilate. Just sit there and hyperventilate. You just take lots of big, deep breaths. You're unloading CO2. You're disrupting the equilibrium that's normally there with your CO2 level. And at some point, you'll start to feel some tingling, and you might even develop a little bit of tetany. So this is an odd kind of an emergency. Has anybody seen a patient do this? Where they're just sort of sitting there, and then they go, and their eyes kind of roll back, and maybe their legs draw up. May I ask, what was that called? Or what was it associated with? Yeah. Really? Okay. Okay, that's my take, is that he hyperventilated. Carpopedal spasm has occurred to me once. I was doing one of my very first sedations after residency. I was at the dental school, and this was the child of a medical malpractice attorney. And I had just put like the test dose of meperidine in, and just very quiet. I don't remember the patient. I think they were just quietly hyperventilating, and their hands drew up and their eyes rolled back, and her feet, her knees sort of came up, and my first thought was, geez, we didn't talk about this one. I just remember that going through my mind. And the thing to do is nothing. You know, it's self-resolved. They'll sort of stop breathing, and their CO2 will build back up, and then they'll relax. And that's what happened, because I was, And she turned and looked at me and goes, what happened? And I go, oh, you just sort of fell asleep for a moment. And she goes, oh, okay. So anyway, if you go home and you hyperventilate yourself, and you blow off a bunch of CO2, now when you hold your breath, instead of taking in a big deep breath, you blow out all the air you can. So you've just unloaded or gotten rid of all of your respiratory reserve. So when you saw me hold my breath for 30 seconds there and I did not desaturate, why not? Is my heart still beating? Is there still oxygen in my lungs? Is blood moving through the lungs still picking up oxygen? So have I still got pretty full hemoglobin then out at my finger? Yes, but was I breathing? No. Now, have me breathe some 100% oxygen for a while. Have me breathe a bunch of extra oxygen. So now instead of having a lung that still has 20% O2, I've got a lung with 100% O2 in it. Will I go longer before I start to desaturate after I'm breathing? I'm sorry? Well, you can only get the hemoglobin so full, but I just filled up my tanks with premium grade 100% O2 instead of regular grade 20% O2. So will it take longer? We start to desaturate when we've used up the oxygen that's stored in here. So is it going to take longer to use up the oxygen? Yeah. So is a pulse oximeter a good ventilation device? Not in the short term. Over a period of minutes it is, but over a period of seconds it's not. And remember, go back to one of the very first things I said today. Sedation goes bad because of bad breathing. I intentionally am saying breathing and not oxygen. It's breathing, breathing, breathing. We want to know if the patient is breathing. Does our pulse oximeter tell us that? Not in the short term. It gives us a hint, and that was one of the first devices we had. You go back into the early 80s, and those pulse oximeters were brand new, and they were very expensive. And before that, it was kind of like EKG and blood pressure and pulse. We didn't have capnography. We didn't have, those were the biggies. I was thinking of there's a cerebral thing, which is not EEG. I can't remember it at the moment. Okay, so let's see, what else did I want to say about monitors and pulse oximeters? They're crummy ventilation detectors, especially if you're using extra O2. How many of you are doing sedation where you use extra O2? If you add nitrous, you're using extra O2. Okay, so if you're adding nitrous, your pulse oximeter is of less value as a ventilation detector. Well, remember the rule said our ventilations must be adequate. So my gray paint is you can cover up bad breathing with lots of oxygen and make it look good on the pulse oximeter. Remember, ventilation is at least a two-way street. You're getting oxygen in and CO2 out. Well, you have to move air to do that. You can easy to suck in oxygen-rich air. That's easy. Comes out of a tank. But how do you suck out CO2 if you're not moving much air? We don't have a suction that'll suck out the CO2 from your blood. Can't do that. Okay, there's also the caveat that unintended loss of consciousness is unlikely. So moderate sedation, a lot of things about moderate sedation are similar to minimal. There's more, come on, what's the problem? Okay, let's talk about monitoring. Monitoring requirements. For minimal sedation, the rules are actually, they say two different things in two different places. So I'm going to give you the higher level requirement. So this is assuming you're using like triazolam or halcyon with or without nitrous. You need blood pressure and pulse and SpO2 every 10 minutes. Now, if you're really comfortable with the rules, you could say, well, if I don't use the nitrous oxide, I am not obligated to use a pulse oximeter. And I would go, you're absolutely right. But you've got it. So go ahead and put it on, is my opinion. If you do use nitrous with your level 1 sedation, you are absolutely obligated to monitor the the oxygen saturation with a pulse oximeter. Okay, so that's level 1 sedation. 10 minutes, SpO2, blood pressure, pulse. And it needs to be written down. Okay, so I showed you a picture of a $2,000 box on the left-hand side of the screen. I put the red X over this pulse oximeter. Now the rules say nothing about the kind of pulse oximeter that you use. So from a State Dental Board rules standpoint, this is adequate. I'm uncomfortable with it. Because when I put this on, tell me what you hear. Nothing. When you put the big box on, what do you hear? At least I hope that you hear. Beep, 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 beep. So the pitch goes up and down as the O2 sat goes up and down. What else do you hear? Beep, 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 beep. You hear rhythm, and you also hear rate. Beep, 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 beep. Or you might hear beep, beep, beep. You know, you can pick up a lot about rhythm by the sound. I'm not going to go into EKG tracings today, but you can tell a lot about rhythm by the way just the rhythm sounds. Remember, a pulse oximeter works because it detects a pulse. If your fingers are cold, you're pretty vasoconstricted, so you often don't get much of a pulse. It's hard to detect. I didn't emphasize this earlier today, but in cardiac arrest, or if you're suspicious of cardiac arrest, you know, people are taught to look for a pulse. So what does the literature say about people that don't check a pulse very often in a crisis? Are we any good at it? We're not very good at it. So we don't do it very often, especially in a crisis where there's probably a lot of, somebody is dying. Pulse oximeters become great, great pulse detectors. If there is a pulse, it will work. If there is no pulse, it doesn't work. So consider a pulse oximeter as an awesome objective pulse detector in a crisis. If you got a patient that isn't awake, you know, if they're awake, they've got a pulse. But if they're not awake, I would throw on a pulse oximeter. I want vital signs in sort of any crisis as it's evolving. But if I'm concerned about, is there a pulse oximeter is a great way to decide, do they have a pulse? Okay, for sedation, I'm uncomfortable with a little pulse oximeter like this because it doesn't make sound. I can't hear the rhythm, and I can't hear the pitch from the O2 sat. So I've known people that do sedation, and they turn off the beeping because it annoys them. And it's like, you're turning off the safety mechanism. You can keep your eyes focused on the patient, on the mouth, and hear the beep, 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 and hopefully when that pitch changes, you immediately look at the monitor and go, oh, we need to do something here. Okay, so I'm uncomfortable with the small little pulse oximeters for sedation, not for emergency management. I think they're great for that. Come on. If you're doing level 2 sedation, so now we're talking about using more than one enteral agent, with or without nitrous. Now you still got to do the blood pressure, the pulse, the SpO2 every 10 minutes. Got to write it down, and you have to record the respiratory rate. So now I'm primarily talking to gray-haired dentists in the room, because we were doing sedation when there was still oral conscious sedation. And at that point, I think we were doing vital signs, was it every 15 minutes? Or maybe there may not have even been requirements, but at one point there was a 15-minute requirement and there was no respiratory rate. And then I can't remember when the rules changed, but somewhere they did, and they grandfathered a lot of dentists who were doing oral conscious sedation up to level 2. I can't remember now what it took, but you could get yourself grandfathered all the way up to level 2 just with some paperwork. But then at some point, the board instituted this, now you got to add the respiratory rate. And so this is all based on records that I get asked to look at. So I see a lot of level 2 dentists that have gotten into trouble with the board because they are not recording respiratory rate. There is some event that prompted some investigation by the board, whether it was stumbled at an inspection or a patient complains about something. They may have complained about a crown that you did, but if there was a sedation involved, then oh my gosh, that gets scrutinized very closely. So sometimes I get asked to look at a record and make a comment on, well, does it look like you followed the rules or didn't you? And what I see more than anything else in level 2 sedation are dentists that are either recording vital signs every 15 minutes, which doesn't meet the rules, or they're not doing respiratory rate, which does not meet the rules. And you know, it just doesn't matter if I did it the other way for 30 years, there was never a problem. Why do I have to do this? So Big Brother says you have to do it. That's, you know, that's sort of it. You know, you'll never win that argument with the board. Okay, so that's required monitoring with level 2. You've got to do the respiratory rate thing. That's the big deal. For level 3, so now we're talking IV moderate, blood pressure, pulse, SpO2, we must run a continuous rhythm tracing. You are not obligated to print the rhythm tracing. At least my take is that the rules do not mandate printing a rhythm strip. I never have. You must also record the respiratory rate all every 10 minutes. Level 4, I don't have a slide for level 4. It's, I think, the same things every 5 minutes. Okay, but the biggest stumbling block I see with vital signs recordings with dentists are level 2 providers not getting the 10-minute interval or not getting the respiratory rate. And the board is really under the thumb of the legislature. The legislature has made it clear, you guys need to get this sedation thing under control. And so if you think that the board is just out to make your life difficult, remember they've got somebody putting them under the thumb. And so yeah, they're hard-nosed about this documentation stuff. Okay. This is just an example of a sedation record. There's nothing magic about this record. But I thought I would put it up. I'm almost done with slides. But I thought I would put it up because it just let me sort of roll through at some things that I think are important to document. Okay, so we've got name, date of birth, date, cell phone number. You see that chart on the top right? That's a sleep apnea screening questionnaire. So it's not written into the rules, but I've clearly gotten the sense more than once talking with different individuals that, oh, we need a sleep apnea screening tool, or we at least need to be screening our patients for sleep apnea. Can you tell by looking? Is everybody with sleep apnea an overweight middle-aged man? Absolutely not. You know, skinny people have sleep apnea. Plenty of people have airway issues. Okay, so that's a sleep apnea screening tool. That is the stop portion of stop bang. Okay. Let's see. PMH is past medical history. PSH is past surgical history, and then you also see anesthesia history. So I assume you're all familiar with the checklist, which mandates medical history, surgical history, anesthesia history for the patient, and at least anesthesia history for the family. Why do we need anesthesia history, family anesthesia history? Well, there's some potential for a condition like malignant hyperthermia to have a genetic component to be inherited. Do the drugs that we use in minimal and moderate sedation cause malignant hyperthermia? Benzos and opioids and nitrous and alpha-2 agonists? No. Is there anything that we do use that is associated with some weird reactions that could be familial? Have you seen a paradoxical reaction to a benzodiazepine? You've seen somebody get angry, belligerent, tearful, crying? No? Really? Somebody say yes. Okay. Thank you. It's like, wait, am I the only one? It's like I see plenty of it. So years ago, we were taking out third molars on a young man. His sister was graduating from dental school. So we did the case. Everything was fine. We're writing records at the end. The resident pokes the patient a couple of times. You doing okay? You doing okay? And then at one of those, this kid just comes unglued and he's yelling and ripping off monitors, and it's like, whoa. Sort of now after the fact, and things sort of settled down some, but he stayed pretty upset for a long time. So we discovered that, because his sister, the graduating sister, the new dentist, was in the room. Her eyes were this big. Have you ever seen this behavior from him before? Oh no, he's the sweetest kid. She goes, they told me I was a jerk when I got my wisdom teeth out. And now that I think about it, my mom said she was too. Okay, so we got mom, sis, brother, and guess who's scheduled that afternoon? Brother number 2. So, there's at least some potential that paradoxical reactions to a benzodiazepine. And so I would assume if we're doing sedation in the room, you're using a benzo. There's some potential for a paradoxical reaction, I think, to have a genetic component to it. I don't know that there's literature that supports that, but I feel like I've seen it. Okay. So I think there is value in taking an anesthesia history, and it's simple. When you've been put to sleep or had sedation, has anything weird happened? Anything weird happened in your family? Typically, that's how long it takes, and the answer is typically no. Okay. All right, so anesthesia family, we are obligated to get their medications down and any modifications that maybe you apply to their meds. Maybe you've altered some anticoagulant drugs or antiplatelet drugs based on a surgical procedure maybe you're doing. Maybe. Allergies, ROS is review of systems. This is also where I would put a comment about, have you had COVID? So I'm probably not going to get to a COVID presentation. We'll see. It's 4:15. Would you say that your patients consistently tell you if they've had COVID if you don't ask? Yeah, my sense is lots of them have had it. When I ask, I've gone through a health history. No, I'm really pretty good. I'm really pretty healthy. I've got some high blood pressure. Have you had COVID? Oh yeah, I get COVID. Oh yeah. Why ask, have you had COVID? Why single that one out? So the comment was pulmonary fibrosis. There's a significant number of patients that have had COVID that have recovered, but they've continued to have long-lasting symptoms. So when I think about COVID and sort of how it affects the bodies, to me, some of the big ones for us would be lung involvement, brain involvement, heart involvement. And so lung is a big thing. So as the virus gets in and starts doing its thing in the lungs, junk starts to collect in the air sacs, and there's dead cells and trash in there. Mucus and fluid is collecting from the blood, surrounding the alveoli, where we're trying to exchange gases, and you get all this junk in there. You can't exchange well. There's lots of inflammation. And sometimes it seems to heal with some scarring or fibrotic changes. So the reason to ask, have you had COVID? Okay, tell me about your COVID. How severe was it? Did you end up in the hospital? If you were in the hospital, did you get oxygen? How was the oxygen given? Was it just dribbled in through a little tube around your nose? Or did you maybe wear some kind of big mask that sort of pushed it in? Or did you actually have a tube down your throat? Were you intubated and on a ventilator? So the literature is pretty clear. For people that got really sick with COVID, you're more likely to have these long-lasting symptoms. For people that were hospitalized that had more invasive methods of oxygen administration, they're more likely to have significantly altered lung function or lung imaging months down the road. And so the longest study that I've seen is a year down the road. And for people that were in the ICU that were aggressively ventilated at a year, they still have substantial imaging and lung function tests, altered lung function tests. But I think you can get a lot of information by asking the patient, so did you get, how sick were you? Were you in the hospital? How'd you get oxygen if you did? Do you feel like you've recovered? Is there anything residual? Do you still feel a little weak? Or do you get tired more easily? And often when I'm in a group like this, can I ask, has anybody here had COVID that feels like there's still some lingering stuff? Well, it hasn't popped up here, but the last time I had this discussion, that answer was yes. And in a room this size, there were two people that were describing now a year later, still not being able to function, and they still had some brain, what they called brain fog. Okay, so we've got maybe some decreased exercise tolerance. I'd also be looking at what's their O2 sat on room air. So if somebody's had COVID and they're not fully saturated, so if you're, especially if you get the O2 sat before your drug goes in, and they're at 97, how do you feel? I feel good. About 96. I still feel good. About 95. I'm thinking about it. I could show you some literature that would say normal is down to 94. Although I'm not sure that everybody, based on a case that occurred within the dental school and an interplay with the state dental board, I'm not sure that everybody at the board would accept 94 as normal. But certainly you get into the 94, 93, 92 range, that will have people's attention as, wait a minute, that's not normal. So would you start a sedation on somebody that's where their O2 sat is 97? Sure. 95? Pretty much, yeah. 93? I need a reason for that. And then I have to decide, is that an acceptable reason? So, but knowing that ahead of time, so if you've had COVID and your beginning O2 sat is 93 before I give you any drugs, and maybe you think about it a little bit, you ask the patient to take a couple of big deep breaths. This is before drugs. I bet they can drive their O2 sat back up. But then if you continue to chit-chat with them for another couple of 3-4 minutes, and it comes right back down, then they're hanging out at 93 or 94. It's like, that represents a substantial change in lung function. So now let me ask you, I'm drifting away from the rules here, how would that affect your sedation? Would you proceed if you are going to proceed, would you do anything different than normal? Because if you haven't had this patient, at some point you will. So here's my take on it. You know, how long has it been since the COVID? If it's been 2 weeks, so this was some months ago, and I was less familiar with some of the literature here, and a patient was about 2-3 weeks post-COVID. They'd not been hospitalized, but they said they were pretty sick, but they're a whole lot better. And when I talked with them on the phone about a week ahead of time, they were still coughing. I go, okay, well, let's sort of play it by ear and see how you are in another week. The appointment is set for another week. And we get to the day of the appointment, and she's really not coughing. And her room air O2 sats was about 95, 96. Okay, then we get into the appointment. So I sedate her for a prosthodontist doing some restorative. And she's a 70, 75-year-old woman. I don't remember what her other health issues were, but I don't remember them being big. I don't remember her being a smoker. But she did start coughing because they were struggling with some water, you know, in the restorative. And she started desaturating. I mean, you know, she'd go down. Mrs. Perkins, take a big deep breath. Come on. I mean, it was just, oh my gosh. She seemed to have really crummy reserve was my sense. But she was only 2-3 weeks out from her COVID. So there are some more current recommendations that would suggest that you're probably waiting at least probably 4 to 6 weeks before you're doing some elective procedures. Okay. How else? So maybe waiting a while longer would have been a wise choice there. How else might you alter your sedation technique? Okay, so I do moderate sedation with an IV. So I'm using opioids, benzos. I'm also using alpha-2 agonists. Is anybody in the room using alpha-2 agonists, either clonidine or dexmedetomidine? That's sort of a separate discussion, but I'm using a lot of benzos and opioids. If you had to picture one of those drugs as, oh, that's the worst respiratory depressant, what would you pick as the class of drug as the worst? Your opioids. So I'd probably be thinking, maybe I'd limit my use of opioids. What's another thought about how I might sedate Mrs. Perkins? So maybe decrease my opioid a little bit, or maybe eliminate it. You know, a lot of people do sedate just fine with just a benzo. But there are clearly people that sedate better with the opioid. It's just smoother. They're not more sedated, it's just smoother. What's another thought? If I'm concerned about her ability to stay saturated. Lighter level of sedation. You know, she's wide awake. She's middle 90s, 94, 95. She's fine. You know, so if somebody comes in, yeah, I want to be like my neighbor across the street. She said she snoozed, you know. She said you told her that she talked once in a while. You talked with her once in a while. She doesn't remember any of that. I want you to do that for me. And your response is, well, Mrs. Perkins, just 3 weeks, 4 weeks after your COVID, you know, that's not safe. Because it sounds like, and so you'd also be listening to her lungs. I'm an advocate of listening to lungs anyway. If their lungs didn't sound clear, I'm not sedating you today. But even if they do sound clear, you know, and you are coughing a bunch, your COVID manifested with lung stuff, I'm still suspicious that there's some ongoing stuff. I'd like to see it be as good as possible. There's some evidence, 4 to 6 weeks, okay? But lighter levels of sedation may be limiting your opioids a little bit. Extra O2, but remember you're masking your ability to see and breathe. But other ways to see and breathe include precordial stethoscopes and capnography, which is something that we'll probably not get into here. Okay, let's see what else on this. So some exercise tolerance, Mallampati. So our checklist mandates an airway assessment as necessary. So the checklist has gone through some evolution in terms of, what we have to do. And so now there's some indefinite, ambiguous requirements regarding airway assessment. My opinion is for moderate sedation, so that's level 2, level 3, or deep, that we're doing an airway assessment. You're either looking at Brodsky score or Mallampati score. TM, thyromental distance, lungs. I also believe we should be listening to lungs, although the State Dental Board has also given us wiggle room, listening to lungs as necessary for appropriate patient evaluation. I think that was done when a lot of level 1 providers complained that we don't need to be doing the airway stuff or the lung auscultation. So I think the board has accepted that if you're doing level 1 sedation, the airway stuff and the lung stuff is not that big a deal. My personal opinion is I do it. It's easy to do. It takes me 15 or 30 seconds. So it's not a big deal. I do mark off if they tell me they have sleep apnea, if they smoke. So if I've got a patient that's been smoking for a while, a couple of decades, has your doctor ever told you have COPD? No, huh? Okay. How much do you smoke? Well, I've been smoking 20 years. How much? Pack a day? Half a pack a day? 2 packs a day? Yeah. It goes up and down. I probably average, I don't know, a pack a day. Okay. But the doc says, I don't have any COPD. Maybe. Maybe you didn't want to hear it. Maybe you don't go see the doctor. Who knows? Do you think there's some lung damage in there? Oh, yes. Oh, my gosh, yes. So what are ways for you to get a sense of, well, how much lung damage might be there? That's easy for you to get. What's their room air O2 sat? So remember, what should it be before you give drugs? High 90s. If it's not in the high 90s, if you're reaching 95, 94, 93, you need a reason for that. Now then, if somebody smoked for 20 years or 30 years and their O2 sat is 94, and they're seeing a physician regularly, and let's just say that they do say they have some COPD. Now what? Are you going to sedate them? What's your concern? Why would you choose not to? Let's talk about why you would be concerned. Are you concerned about their airway? So remember, when we sedate people and they lose an airway, that's code for what? Tongue on the back of the throat. When people obstruct or they lose an airway, we're talking about tongue relaxing on the back of the throat. If somebody's been smoking for 20 or 30 years, are they more prone for their tongue to lay back on the back of the throat? My opinion is, I don't know that I would automatically make that connection. What is different, though, about lungs, lung function in somebody that's been smoking for 20, 30 years? Do their lungs effectively exchange gas like yours do? No. So, remember, how does sedation go bad? Patients develop bad breathing. How well will they tolerate that? You saw me hold my breath easily for 30 seconds, and I didn't desaturate at all. I've got lots of reserve. If I had COPD and I held my breath for 30 seconds, would I stay saturated that full time? You don't know patient by patient, but they're going to desaturate much more quickly. So can you sedate them? Sure you can. I don't think they're particularly more at risk of obstructing, but if they do develop bad breathing, they're apt to desaturate harder and faster than you or I will. So that means you've got to be better and faster at managing the bad breathing. In the event that they become unexpectedly unresponsive, remember what crisis was in sedation? Unresponsive and not breathing. And so if you get a COPD patient, for instance, to a point where you can't wake them up and they're not breathing, instead of their O2 sat slowly going down like it would for you or me, they'll fall off a cliff. Name another patient group that is prone to having their O2 sat fall off a cliff when they stop breathing. Obese individuals? Give me another patient group. Somebody that has active airways disease? Okay, I'll give you that. Are there any parents in the room? Are there any parents of little kids? Little kids will fall off a cliff. Little kids. When they stop breathing, they will desaturate very quickly. And these are healthy little kids. Now what about a kid that's obese with asthma? You know, probably won't have a smoking kid, but you could have a kid with asthma that, oh, by the way, they also had upper respiratory tract infection. And they had COVID. Yeah, so it's like as long as they're awake and breathing, they're okay. But if you get them to where they're not awake and not breathing well, they're apt to decompensate rapidly. So we've just identified some folks that are higher risk to sedate. Chronic lung disease, smoking-related disease, COVID, obese patients will desaturate rapidly. They have poor reserve. Little kids, and so by little kids I'm talking like 2-year-olds, 3-year-olds. There was a death in Hawaii 2, 3, 4 years ago about not quite a 3-year-old. Do I have the name right? Finley Boyle, I think. The patient died in the office, and ultimately the dentist, so they finished a trial recently, and the dentist was exonerated. And part of that hinged on the mom, who was an RN, apparently did not tell the team that her daughter had had a respiratory tract infection, what was probably a viral infection. This was before COVID. A week or so before the appointment. And the dentist's position was, oh, we never would have sedated her had we known that. So in the end, the dentist was not held liable, but at the end of the day, there's still a 3-year-old girl that didn't leave a dental office. So that's a bad deal. So let's see, what else did I want to say about risky patients? Okay, that's good. Let's see what else we need to be sort of finishing up here. Height, weight, BMI. So when you're thinking about the checklist, remember the checklist mandates that we collect: height, weight, blood pressure, pulse, respiratory rate. What got left out there? SpO2. You do not have to have SpO2 for your pre-op vital signs. You may have to record it during your sedation, but it's not mandated in the checklist. Height and weight. I also didn't say BMI. I said height and weight. Now, I have a personal beef with that. BMI tells us nothing about where the weight is distributed. Where is excess weight problematic from an anesthesia standpoint? Sort of central adiposity here. So extra weight here is a problem. You lay somebody flat on their back, it's hard to breathe. It's hard to ventilate. If the bulk of the redundant weight is here, much less of an impact from an anesthesia standpoint. What about, linebackers that they have 100 pounds here and 100 pounds here, but here to here they're just muscle and built. They may have a BMI of 35 and even 40. So 30 is obese, 40 is morbidly obese according to BMI charts. But the football player may not be at all obese. So BMI just doesn't tell us where the risk is. Unfortunately, it's penetrated deeply into our patient assessment culture. The next, right below the height weight BMI is ASA classification. Does BMI impact ASA class? Yes. If your BMI creeps above 30, you're now automatically at least an ASA 2. And if your BMI creeps over 40, your ASA creeps above 3. You have to be at least a 3. If you're a moderate sedation provider or a deep GA provider, and you're sedating ASA 3 and 4 patients, you've got to have this high risk endorsement. So let's talk about, who are patients that are ASA 3? The general wording is they have substantive functional limits. Okay, that's vague. But there are some automatic number 3 triggers. We just went over one of them. A BMI over 40 makes you an ASA 3. If your patient has had a stent, they're an automatic 3. If your patient has had a bypass, pretty certain they're an automatic 3. If they've had a heart attack, they're an automatic 3. If they've had a heart attack or a stent, and they stopped smoking, and they lost 100 pounds, and now they run marathons, they are an ASA 3. Doesn't matter what their functional capacity is at that point. If you've had a stent, you're a 3, at least a 3. If you've got an implanted pacemaker, you're at least a 3. I believe you would be considered at least a 3 if you have an implanted cardiodefibrillator. If you've had a TIA, a transient ischemic attack, a mini stroke, or a full throttle stroke, you're at least an ASA 3. If you've had these stents, strokes, bypass grafts, TIAs less than 3 months ago, you're a 4. So the last thing you want to do is sedate somebody that you don't have a permit for. I don't think the likelihood is really high that, you're going to get into trouble because you sedated them. You'll get into trouble with the board because of something else, but then somebody may go, wait a minute, this was an ASA 3 patient or an ASA 4 patient, and you don't have the high risk endorsement. So you're in essence sedating without a permit. And that doesn't go over well. So the break between ASA 2 and ASA 3 is really important. And the flip side to this is the board does not take kindly to underclassifying the ASA. Okay, I know we need to be done here. So let's see, ASA 1 patients have basically nothing in their health history. So if there's anything, hypertension, well-controlled anything, you're a 2, at least a 2. What else do I want to say? Verifying written instructions, monitors. If you're doing moderate sedation, you need to write down when the drugs go in, when your individual increments of drug go in. That needs to be written down. The time-oriented part also ties vital signs to when those drugs went in. Discharge criteria down on the bottom left. That's fairly prescribed, so there needs to be some formal discharge criteria. Post-op vital signs. Who was in the room? I've seen a case hinge on what was written in the record regarding who was in the room and what the doctor had written and what the patient contended. And when the doctor doesn't write anything about who was in the room, then who wins that argument? The patient. If the doctor has written into the record who was in the room, the doctor will likely win that argument. Okay, this is the very last slide I'm going to show today. Yeah, I know. I get it. I assure you I get it. I know. I just want to make sure everybody is filling out a checklist. You must fill out a checklist for each sedation you do, even if you're sedating the same person over and over again, even if it's just for nitrous. I get it. We didn't do it for years. Why do we have to do it now? You'll lose that argument with the board. But these are things that our checklist must address one way or the other. Now, my take, the rule doesn't really say what you have to write, how you execute the checklist. I do not use the checklist as an excuse to rewrite the health history. Although those of you that know that and believe that I live in the ivory tower, you would think, oh, he just wants to write the health history twice. It's like, I do not. I don't. And I don't write the health history twice. I just write on my checklist, reviewed. And it is fully reviewed on my anesthesia record or in my dental chart. It's easy to get a fairly detailed health history that I've done. The meds, the allergies, their NPO status. Did you limit food? That needs to be addressed one way or the other. Your checklist needs to at least verify that you've got that written down. That's the way I think of the checklist, is write something that makes it clear that you verified you got that information somewhere. My opinion is it does not have to all be on the checklist form. If somebody has a complicated cardiac history, can you write that into the little box where you have past medical history? No, you can't write all that stuff. Just write, reviewed. And it's on somewhere else in your record. Don't rewrite it. Meds, modification to meds, instructions, consults, ASA physical status, we've talked about all that. Airway assessment as necessary, respiratory rate. So for some reason, the board wants to know how you captured respiratory rate. Observation, auscultation, or capnography. I don't think it matters. Just note that you did it one way or the other. Is your equipment ready? Is anybody in here a pilot? Okay. I fly a little homemade airplane. When I learned to fly, we had a checklist. Do you want your pilot flying your commercial airliner to have a checklist? Do you think it has one line that says, is your airplane ready to go? No, there's 20 things that they look at. So on this point, I think the board underdid it. But that's a different story. Okay, high risk or pedo, that needs to be acknowledged on your checklist. And were there any omissions? Okay, all right, it's quarter till. Are there any thoughts other than, what is the darn completion detail? Okay, so hold on, let me get that, because I put it at the end of a different presentation, and Okay. Let's see. Hold on. Hold on. Because now I have, come on. Hold on. I have to undo one thing. I'm hurrying. Okay. Get your cameras out. You guys have been extraordinarily patient with me. I appreciate that. I can't tell you how much I appreciate that because I know as much as I enjoy doing this, I know you don't. I'm so sorry. I know you don't. Okay, I can't do that. I'll leave it alone. So you scan this, and this apparently steps you through the CE credit process. So are there any thoughts, comments, questions? I hope you guys have a great weekend. You have really been a terrific group. And it's a beautiful day outside. Is it still light or is it dark yet? Okay.
Well, thank you, everyone. Before I thank Dr. Luz for your awesome presentation, at the end, please go over to the main entrance and you can pick up your CA certificate. One last thing to mention is probably you have seen the what we're announcing that we'll have T-MOMS in September, which is Texas Mission of Mercy. It's an event that there is a mobile dental unit. It will be held here at the Bird Other Arena, and it's been sponsored by Renaissance and Lone Star Bank, and we expect 40 chairs in the arena, and hopefully to see as many patients with low income from our area to be seen. For those dentists, assistants, hygienists that would like to participate, please just be on the lookout. And for those that will attend, I'm working on, and I'll have a OSHA, a HIPAA, and opioids course for 8 hours for those that attend after that event. In the meantime, Dr. Luz, thank you so much for coming. I really enjoy it. It's fantastic, always seeing you, and we always learn from you. And everyone, thank you so much for coming.
So I just learned that this QR code is only for the people that are being broadcast to. You guys have your CE credit here. I'm sorry for that, Hal. I didn't appreciate that detail.